Welcome back home. I hope you all had comfortable flights. Some of you had issues with the delays and all, and have slept well last night. Several years ago, all of us have from gate number 1 and 2 inside this institute with feelings mixed with anxiety, curiosity, and after 2-3 years we went back to the same gate when these two feelings were transformed into competence and confidence. So what is that magic potion that made this transformation? Nobody has yet figured out whether these were our sleeplets call nights, you holding the pulse of a unstable transplant patient overnight, managing patients landing in the emergency on dialysis, or those biopsy meetings where your bosses will make sure that you have read about the case at least a night prior. So whatever it is, but this was a transformation that all of us have experienced, and now you are back to the same gates again as a very different person, excelling various heights in various areas of your career, practice, academia. So we are very delighted to host you all for this magnificent moment, and we are here just the facilitator. It's your day today. So we assure that this will be mixed with academics, fun and learning, and you will get to interact with all your friends, colleagues, and will cherish the memories that you have lived here through all those glorious years. So I will just recap a bit. Where is this? So we prefer today to call this department as AKD. That's how we have all remembered. And so this was the Iron Lady who established this department as a division of nephrology in the Department of Medicine initially, and then as an independent department itself. 1962, these were the Alval's kidney that was donated by a Swedish philanthropist, which led to the establishment of AKD later, and later it was supplanted by another major donation by Rockefeller Foundation. This was a Kills dialyzer. From this humble beginning, the unit grew and became the only unit that provided dialysis services in the city of Mumbai until 1973. In the 60s, this was the place where first deceased donor kidney transplantation was done. This was also one of the first places to start the postgraduate training in nephrology in the form of D&B initially, and subsequently in 1986 the DM nephrology program. Laboratory was Madam was passionate about this laboratory service, and she was very meticulous. It was not just the laboratory issuing the reports. Every reports will be, as you can see in her handwriting, signed, and the instruction given as to titrate the dose of insulin or whatever. Bacteriology also was her another interest. This is something that we all have learned from her. This is not just the papers lying there. This is a case, this was one of the DMCs of that time admitted with fenformin-induced lactic acidosis in Madam's unit, and she has managed this case. So this record, we all know this is a initial consultation sheet, and this is a OPD performa, which would be 6-page length. And everybody is expected to fill every field. Nothing was allowed to be left blank. Somebody from, of her colleague from all across the country would refer a patient, and then Mr. Kishore would create a performa, and the journey of the patient would start. This was not just the journey of the patient. This was a start of a legacy of learning at this time. From these notes put in 1991, this would start, many stalwarts would identify their own handwriting here. Dr. Almeida, Dr. Hemant Mehta, Dr.
Good morning.
So many of you. So everybody has seen this patient, and this record continues to teach generations of budding nephrologists here. Okay. And still today, okay, this patient teaches us what a malignant hypertension is and what. So Dr. Hase used to tell us, if you want to know about malignant hypertension, go and read the Schreier in the library. But if you want to really understand it, you have to study the 5 performas of malignant hypertension maintained like this. That would tell you something that no Schreier or guideline would be able to offer. So this is something that one can imagine as early as 1984, she conceived an idea of interdisciplinary research where she involved IIT people. And this was the first of its kind meeting where nephrologists were interacting with biomedical engineers. And many of you who are currently stalwarts will identify them as a tutor in nephrology, a reader in nephrology, and tutor in medicine, Dr. Khanna. This was the conference that was hosted by Madam, and many stalwarts from abroad, Oliver Long and Ramesh Khanna, sir, were the part of this conference. And this is just a trivia. I used to say that Septran you will never see a medical representative because it is cheap and effective. But this was a conference that was supported by Septran. And then this towering legacy was carried very successfully forward by Professor Dr. Alan Almeida, who was mentor to dozens of DM nephrology students who are reaching various heights in academia and research, various parts of the country.
And overseas, very importantly, major development in style was the expansion of marriage services with the help of government of Israel. Israeli people donated a lot of donations, so that is really to expand. And these two people are going to be
by their beloved student in the night, and I'm not going to cross into Dr. Jatin is not there. Probably he's making the list of charges that he wants to frame sir with. But he was a man of very strict discipline. And I would only say this Kabir's Doha that Guru Kumhar Shish Kumbh hai, Gadi Gadi Kadhe Khot. Antar Hath Sahar De Bahar Bahe Chot. So all of you have received this from outside, but that was to make you into something what we are today. Now, Dr. Hase took over in 2005, and he was my student in MD, and he continued to be my student in 2000 in nephrology, my teacher in nephrology. And importantly, he expanded the services further to CAPD program that we have built up today, about 50 plus patient prevalent, and various OPD services, dialysis services, lupus nephritis clinic, tubulopathy clinic. So all these he could expand, and he is also going to be framed with various charges. Dr. Billa is waiting. I am not going to intrude there, but one allegation I would place here is that he had lured lot of his student into nephrology. So from Sion, 3 of us from a batch of 10 ventured into nephrology. That's because of him kindling interest in this discipline very early in our life. And many of you, Dr. Halankar is there, were faculty for some time, and he was a teacher for the second student. And a lot of you, I have not been able to include many of you here who were the faculty for some time, more or less. So I will quickly take you through. This is going to be a tour shortly in the day later, but this is how department looks like now. These are the faculties on the left. Dr. Divya Bajpayee, Dr. Saili Thakre, Dr. Shreyashi Bose, and people who have passed out, they stay with us as lecturer, Dr. Nikhil Rao, Dr. Kratish Kumar, Dr. Ashwini Joga, Dr. Pratik, and this is a batch of current residents, Dr. Abhimanyu Singh, Dr. Rita, Dr. Shruti, Dr. Aditya, Dr. Tapsi, and Dr. Ajit. This is the dialysis unit. Currently we are 15 bedded. We perform about 40 treatments in the unit and several in various ICUs. They are not transferred to the unit but are offered the dialysis bedside. This is the transplant Ward 34 ICU located just beside AKD, managing the critical nephrology patient. This was a unit that was conceived and developed during the time of Dr. Hasse's HOD ship, interventional nephrology, equipped with CIAM, bedside ultrasound. So most of the nephrology procedures are done here. Laboratory services now include fully automated ELISA and biochemistry and hematology services. This is a transplant ICU. We recently completed 850 transplants. We do now all deceased donor, live donor across the blood group and sensitized recipients as well. These are the OPD services. You all are aware of Tuesday OPD and 2 R clinics. Now it is expanded to glomerulonephritis clinic, hemodialysis, PD. First of its kind, tubulopathy clinic, which is catering to the rare tubular disorders, and a lupus nephritis clinic. Dr. Saili and Dr. Divya respectively are leading these 2 clinics. We have an active research department now, a research officer, coordinator, a data entry operator, and Mr. Mahipat, you must be recognizing him after retirement. He continued as a research assistant. So this is not the best way to know what is the research activity in the department, but we are able to publish at least 4 to 5 papers in PubMed Index Journal every year. This is over last 13-14 years. I stand here on behalf of so many people, nurses, technicians, residents, and all paramedical staff who are crucially important to do what we are able to do today. And with this, I will stop here. As I said, we are just facilitator. This is your day. And I now welcome Madam Dean. She has took out time from her Sunday. And I call upon dignitaries to inaugurate today's meeting. Thank you. So, with the lightning of the lamp, we will. She has took out time from her Sunday, and.
I call upon Dr. Hasse sir, Dr. Alan Mleda sir, Dr. Arun Shah, Dr. Umesh Khanna, Dr. Chafekar, please. Dr. Sharat Sheth sir, please.
Hello, check, hello, check. Hello, check. ठीक है. सध्या मी साऊंड ऑफ करतो.
Now I request our Dean, Dr. Sangeeta Rawat, Madam, to address the gathering.
Good morning, all respected dignitaries and all the stalwarts of KEM Nephrology and St. GS Medical College. Thanks to all of you for coming today. So, welcome to the 100th year of St. Govinda Sundardas Medical College and King Edward Memorial Hospital. I think it's a proud moment for all of us. And today also in the world map, KEM stands so tall because of the alumni who are spread all over the world, not only in Mumbai, Maharashtra, India, but all over the world, and making name of KEM Hospital to the top. So today it's a mixed feeling that all of you will have the MLT where you might have given the exams and the corridors where you might have walked in the past. It's all again together, and I'm sure you're going to enjoy this. And there are a lot of changes also in KEM campus, and I'm sure you'll enjoy those changes also. So 100th year hai, so I thought KEM should be beautified. How in wedding we have no clothes, new clothes. So we made some fountains in the KEM hospital, some new LED panels where we are putting up the patient education films, which we are making. 100 films we are planning to complete in this year. And all those are displayed on this. And I think nephrology has also made 4 films. So those LED panels are there, and there is a subtitles also where patients can read them. And also the OPDs have all the TVs put up. And we have a QR code for the patients to take those films on their mobile, and they can go and show it to their relatives or at home, and they can listen to it carefully. So that was the whole concept was done by whistling boards of Subhash guys doing the filming. But the best part is the script writer, actor, everything is KEM doctors and KEM staff. So the ward boy becomes a patient and the doctors are themselves there, so that we don't have to take any consent for showing these films anywhere. So there are many, I'm sure the nephrology department is one of the topmost department in the India for KEM, and the number of transplants they do, I think there is always a long list, and I get very often the phone call, Dr. Tukaram ka appointment chahiye, madam, can please help kar do. So I think that talks about that how the KEM nephrology department is sought after by so many. And there are many affording patients who come here because the treatment given is up to the mark and to the best possible treatment. And also the transplant results are so excellent. And I think the record keeping which Tukaram showed has really, which is initiated by Dr. Acharya, the founder member, has really continued and carried forward by all the department people. So that always is very important because in nephrology, once the patient has gone on dialysis, is there with you after the transplant also till the patient is alive. So I think that's important that such good follow-up records are kept. To talk about something more on the KEM hospital, what we have done in a couple of years is we have come up with 7-8 new ICUs, and all the ICUs currently which we have, if you can visit, they are all of the corporate level. I think nephrology had an additional new dialysis unit, and that was done within 10 days we were supposed to do, and then we did it. And we are carrying forward those added 15 beds with additional technicians and all that we are trying to manage. And then we have many new projects which we have done, a new IVF center, a new burns ward, and a new sports center which is done by, all these things, majority are also done by CSR. And I have actively started that CSR projects which are possible. And we are also going to now do my last project probably before I retire is new NICU in the gynec wing, which is going to be sponsored by alumni batch of 1976. That's my husband's batch. And they came for a treat, their 50th meeting at my bungalow, and then they said, we will do this project. I said, good, so I should host every batch at my bungalow, and I can get more donations. So there are many new buildings which are coming up in KEM. So one of them is the Centenary Tower 1, which is next to UGPG hostel, where we are planning that all the labs can be shifted and the patients have to go only to that building for their blood collections and the test. And also ground floor will have a X-ray, sonography, the basic investigation of radiology. There are other building which is a Karmachari Bhavan in orthopedic campus opposite Tata, where we are going to have 2 wings. One wing has 100 flats for the staff of KEM and almost 75 flats for the doctors of KEM. So all of you know who have left KEM that how powerful the corporates are in pulling away our good faculty. And we just lost one of them from this department also. And so if we can offer a flat, then maybe in a Bombay, in a Parel area, if you get a good flat, I may be able to keep more good brains back in KEM. Also, we are coming up with a convention center of 700 capacity, and then 2 halls of 300, 150, and some boardroom with pre-foyer area, pre-function area and everything, which will be across at the nursing quarters, which is going, and the AD bungalow and Dean bungalow, all 3 are going to be broken. So convention center, nursing quarters will be another 32-story building, which will be, currently we have a GNM nursing and we'll be starting BSc nursing. And also we will have another building, the Dean bungalow will have a multi-story building of 20 floors and maybe the Dean may get a penthouse or something and not the bungalow anymore. So these are a few things but here there was nothing for the patients' beds we are increasing. So we have asked for one building at where CO quarters 1, 2 and 3 are there, where some of you might have stayed there. Those are going to be broken, and a 40-story building we have asked, but that is not fully sanctioned. Till now only 17 floors are sanctioned, and we plan that we should have a helipad on top, so the transplant becomes much more easy. Carrying out the patients and all. But the DCM Shinde sir announced it, but he has to come back after the election and follow up and make sure that it is being done. So we are waiting for that. And then there are many things which the Eckworth near the leprosy compound. Now hardly there is only one ward which is going on. Rest of the whole campus is vacant. So there we have got hostel of 1,200 students, which is already built, and there are 3 wings. A wing will be given to us by end of January. So the new hostel, and currently we are writing in first MBBS, no hostel for the first MBBS students. So probably henceforth next year onward we'll stop that, because when we were there as students, I think 80-90% were from Bombay or Maharashtra, and so we would always like to go home. But now I think 90% are non-Bombayites, so the hostel facility has to improve, and that's what the plan is. If the undergraduate students go there, probably the PGs will be accommodated here. Currently we have some rented places around KEM where we have kept the postgraduate students. So even the boys hostel, which was that time was the girls hostel where Lopa Mehta used to stay, now it has become an annex boys hostel. That also is just recently renovated 2 years back. So these new buildings are there, are coming up shortly. So I think and MLT you have seen has really renovated. And the KEM campus is also renovated. And there are many other projects which we have done, but I won't bore you, all of you. But I'll request, please take a round of the campus and you'll enjoy that, the new feelings in campus. We have renovated 6 wards also, which are basic medicine and surgery wards. So once again, I really thank all of you for coming here on Sunday, and I'm sure you're going to enjoy the moving around the kattas of KEM, remembering your old boyfriends and girlfriends, and the cutting chai at Milan. And there is also a selfie point now which we have created where the Dean's garage was there, so there's no more garage. There is a selfie point which we have created. So I'm sure you all have a wonderful time today, and I think department is going to do wonderful today for entertaining all of you. And I think basic entertainment, that you meet and greet together and remember the old days, and also remember in future what to do for your alumni. So your parent institute, what you will do. So thank you very much for coming, and thanks for calling me. Thank you.
Thank you, ma'am, for gracing the occasion. Today's event beautifully bridges the past, the present, and the future, where pioneers, practitioners, and young minds come together under one roof. And hence, we have with us a program specifically curated to show this amalgamation. As we commence the morning sessions, we wish to present recent and ongoing original work and research being done right here in our department. After lunch, we will have the privilege to listen to a few of our esteemed alumni talk about issues closest to their heart, such as hemodialysis, peritoneal dialysis, interventional nephrology, and unique challenges in nephrology in everyday practice. This will be followed by a departmental tour and tea, after which we will all proceed to the dinner venue. Perhaps the most exciting bit that the evening holds in store is a unique interaction where the tables will finally be turned. The student grills the teacher in what we have called AKD Ki Adalat, with our former head of department in the spotlight. This will be followed by a fun meet and greet session and dinner to conclude.
So without further delay, we proceed to the first session. Atypical HUS, complement-mediated TMA. A disease so complex and elusive, we are not sure what to call it. However, over the past decade or so, owing to the sheer volume of our patient base, we have been able to identify a cohort of around 100 odd patients, advancing not just our understanding, but also potentially altering how nephrologists all over the world understand and deal with this disease that otherwise evades us so. Furthermore, we have been able to procure eculizumab for a few of these patients, handing us a unique opportunity to study some really interesting outcomes. For this session, we call upon our chairpersons, Dr. Kamini Mehta and Dr. Prakash Khaitan, to please come up on stage and to present atypical HUS outcomes and experience with C5 blockade. I call upon Dr. Aditya Anurag. Dr. Atul Sasgure as well to join us.
Good morning, one and all. I am Dr. Aditya Anurag, nephrology resident at KEM Mumbai. And firstly, I'd like to start by thanking the department for giving me this opportunity to present our outcomes and experiences with C5 blockade in cases of atypical HUS that we encountered at KEM in front of this esteemed audience. So to begin my talk, I'd like to discuss two cases. The first case is of a 25-year-old pre-morbidly healthy male who is a smoker, and a patient presented to us primarily with puffiness of face in June of 2026. Patient had associated bilateral pedal edema, and he was slightly hypertensive to begin with. There was, the patient did not give any history of any preceding illness. The labs revealed increased creatinine levels. There was nephrotic range proteinuria and microscopic hematuria. Patient had anemia, but no thrombocytopenia to begin with. Further workup revealed evidence of microangiopathic hemolytic anemia. So, based on these findings, the patient underwent renal biopsy. The first picture revealed, there are two gloms in first picture. The right glom showed marked congestion of glomerulus, which is glomerular paralysis. And the left glom in the first image shows fibrin mesangiolisis and focal fibrin thrombi. The second image is also showing mesangiolisis. Similarly, the third and fourth pictures revealed changes of TMA in arterioles. There were thickened arterioles with narrowed lumina, fibrin deposition, and RBCs in the wall. Further workup revealed that the patient had normal C3, C4 levels. His anti-factor H and anti-factor H antibody titers and C3 nephritic factors were negative. So based on these findings, patient was started on plasmapheresis therapy. After 8 sessions of plasmapheresis, patient had persistent anemia and his serum creatinine stabilized at around 3 to 3.5. But worsening creatinine and persistent anemia on follow-up meant that the patient was given 5 more sessions of Plex, following which his hemoglobin slightly improved. However, renal function continued to deteriorate. It is also worthwhile to note that it was difficult to define hematological remission in this patient as the patient did not have any thrombocytopenia to begin with. So we looked at no drop in hemoglobin as a parameter for his hematological remission. During the ward course, patient had a fever spike, which was primarily attributed to SD catheter related infection. It is to be noted that the patient developed new onset thrombocytopenia for the first time following this febrile illness. He was treated with antibiotics and observed. However, patient had worsening of kidney function and his fluid status was suboptimal despite adequate fluid and salt restriction. Cardiac evaluation done at this point showed normal ejection fraction, that is EF of around 60% with thin rim of pericardial effusion. Patient continued to gain weight and there was worsening of blood pressure control. Patient was initially needing only one drug of blood pressure for his blood pressure control, but during the ward course, patient needed as high as 5 drugs for blood pressure optimization. In view of persistent renal dysfunction, patient was again treated with dialysis, hemodialysis, and he was restarted on Plex sessions. After 7 sessions of Plex, patient was started on eculizumab therapy on 6th of November 2025. By this time, we have gotten back his genetic workup. His MLPA revealed heterozygous deletion of CFHR1 and CFHR3 genes, which is not uncommon among the cohorts of patients suffering with HUS. Clinical exome sequencing revealed that the patient had a CFH1 mutation, CHF mutation. Since the patient was anti-factor H negative, so we labeled the pathogenicity to this mutation in this patient. So to sum it up, the patient had anemia to begin with, which persisted during ward course. It responded slightly to plasmapheresis, but overall it was refractory to treatment like plasmapheresis. There was some improvement in baseline after we added erythropoietin during ward course. Also, thrombocytopenia, which was not there to begin with, persisted, first came after one febrile illness, and it persisted throughout after that event. His blood pressure control continued to worsen during ward course, and his antihypertensive requirements gradually went up. The renal dysfunction was persistent, and despite plasmapheresis, the patient required dialysis, ISOUF removal during ward course. His cardiac function also deteriorated during ward course. Initial evaluation revealed normal cardiac function, but on repeated echoes done during the ward stay, patient had a reduced ejection fraction of around 30% with moderate TR, MR, and moderate pH. We attributed it to persistent uremia and the associated endothelial dysfunction associated with HUS. So the patient was treated with eculizumab. We can see here that the patient is currently on eculizumab therapy, and his hematological parameters have showed marked improvement. His hemoglobin has jumped up from 9.3 to 12.9, and his serum, his platelet counts have also risen. But his renal dysfunction continues to persist. There is no marked improvement in his serum creatinine levels, and proteinuria is also persistent. Also, an important thing to note is that his antihypertensive requirements have not come down. However, his home blood pressure chartings shows a better blood pressure control on evaluation. So to sum it up, patient is actually a case of CFH related anti-factor H negative atypical HUS. So the diagnosis was primarily based on kidney biopsy, and it was later corroborated with clinical and lab findings, which was later confirmed with genetic workup also. The treatment was primarily focused on plasmapheresis and eculizumab. We did not emphasize much on immunosuppression as the patient did not have any anti-factor H positivity. Now, coming to the second case that we encountered, this is a case of a 11-year-old female. Patient initially presented to Goa Medical College with complaints of abdominal pain, vomiting, and vomiting. She did not give any history of hematuria or loose motion. Patient was normotensive for her age, and the first lab values revealed that the patient had anemia. There was thrombocytopenia, and there was renal dysfunction in form of raised serum creatinine and nephrotic range proteinuria with microscopic hematuria. So based on the clinical suspicion, these clinical suspicions, she was labeled as a case of atypical HUS. She received 8 plasmapheresis at Goa Medical College, and following this, her there was hematological and renal remission. Patient, however, relapsed within one month. This time, her anti-factor H was done, which was positive. So she was treated with 7 sessions of plasmapheresis, and she also received immunosuppression in form of MPS and cyclophosphamide 500 milligrams. Patient had anemia and thrombocytopenia to begin with. She responded initially, and then she came to KEM, where we continued on her maintenance immunosuppression. We continued her steroids and started her on MMF, maintenance doses. However, she relapsed within 2 months, and she had 2 relapses while she was on steroid and MMF. So during this relapse, we stopped her MMF as we considered the disease refractory to mycophenolate, and we started her on eculizumab therapy at this point. Patient required 3 antihypertensives during follow-up, and after giving a full course of 6 months with eculizumab, patient had marked improvement in her hematological and renal parameters. However, an important thing to note here is that the patient continued to have persistently high levels of anti-factor H titers during follow-up. Her genetic workup was done. There was no pathogenic variant that could be found on clinical exome sequencing. However, there was heterozygous deletion of CFHR1 and CFHR3 on MLPA. So, how did she respond to her eculizumab therapy? She did very well. Her hematological parameters showed marked improvement. Her thrombocytopenia settled, and her serum creatinine reached almost at her baseline of 0.93. There was also a substantial decrease in her proteinuria. And however, one important thing again to note here is that her antihypertensive requirements did not come down. She needed initially 2, and while follow-up, the antihypertensive requirements continued to rise. So we decided to stop her eculizumab therapy after 6 months of eculizumab, and she relapsed immediately after 2 months of withholding eculizumab. Patient had worsening hypertension, and so she was treated with steroids. She needed hemodialysis for renal dysfunction, and she was treated with 10 sessions of plasmapheresis, and it was at this point that we gave her rituximab. However, with this therapy, her renal dysfunction did not resolve like it used to earlier, and there was persistent renal dysfunction on follow-up. She landed back in our ward again 1 month down the line with hypertensive emergency, with acute SDH, and uncontrolled blood pressures. She needed 8 antihypertensives this time for optimal blood pressure control. But there was no relapse at this point of time. It was only after 20-25 days that we labeled it as a relapse because there was a drop in her hemoglobin. Her platelets started to dip again, and there was significant worsening of her renal function from 2 to 5. So it was at this point that we restarted her on eculizumab therapy, on which she is doing well. Her hematological parameters have not improved as of now. She has received only 2 doses, and but her platelet counts have started to show an upward trend, and there is a significant improvement in her renal function. Her serum creatinine has come down from 5 to 1.74. So to sum it up, this patient is a case of anti-factor H antibody-related atypical HUS. Patient's primary diagnosis was not based on kidney biopsy like the last case. The diagnosis was made primarily on clinical suspicion, which was later confirmed by labs and genetic workup. Also, as far as treatment is concerned, as compared to the last case, the focus was not on immunosuppression in the previous case. In this case, we have tried multiple immunosuppressive agents. So, coming to National Policy for Rare Diseases, it is a Ministry of Health and Family Welfare initiative which was launched in March 2021, which includes 63 rare diseases. Atypical HUS is one of them. Financial supports of around 50 lakh per patient is provided for treatment at notified centers of excellence for rare diseases. And a total of around 1,100 patients have been benefited under this policy till August of 2024. Our center, that is KEM, is included among the Center of Excellences, which has been identified with facilities for diagnosis, prevention, and treatment of rare diseases. So, as far as our data is concerned, we have currently treated around 93 cases of HUS, atypical HUS. The male and female distribution is almost equal, 49 males, 53% male and 47% female. This disease is primarily considered a disease of pediatric population. In our cohort, the patients are predominantly of pediatric age group. However, the disease tends to involve adolescent and younger age group also. So, owing to young onset, the patients usually do not have any premorbidities. However, 17% of the patients in our cohort had first presented with HUS when she was pregnant. The patients usually deny any preceding illness. However, the patients have some infective. Some patients have some infective episodes prior to the onset of HUS. Most commonly, they have URI, and there are 4 cases in our cohort who have presented with tropical illnesses like dengue and malaria prior to developing atypical HUS. The most common clinical features in our data set are edema, which is seen in 71% cases. The patients have decreased urine output. They usually present with vomiting, abdominal pain, and hematuria. It is not uncommon to have other complaints like loose motion. 57.5% of these patients had positive anti-factor H antibody titers. All patients were either hypertensive to begin with or developed uncontrolled blood pressures during ward course. 3 patients in our set did not have any thrombocytopenia, but significant hemoglobin drop was noted in all cases. So around 80% patients required dialysis due to renal dysfunction at presentation. We gave plasmapheresis to almost all cases, but 5. These cases were primarily pregnancy related, and it was only after their hematological and renal parameters improved that due to persistent some renal dysfunction, we planned a renal biopsy on which we got the findings of some TMA. So median number of plex sessions that our patients received was 6. 9% patients received plasma infusions, and 66% of the patients required steroid therapy. These were primarily the patients who had anti-factor H antibody positive titers. And second immunosuppression was used in around 50% of the cases. So, important thing to note here is that the 20 patients did not need any antihypertensive medication at discharge. That is, they had hypertension during the ward course, but after treatment, their antihypertensive requirements came down and their blood pressures normalized. In a majority of the remaining cases, the blood pressures were fairly controlled on a single drug. However, the median number of antihypertensive medications was 1 in our data set. After treatment, hematological remission was achieved in all cases, and it took around 13 days to achieve this remission. Renal remission could be achieved. Renal remission, that is GFR of more than 60, could be achieved at the end of 3rd month follow-up in only 43 of 66 patients. That is around 65%. So, when we look at these cases, the 43 patients who achieved renal remission, at the end of last follow-up, only 7% patients had a GFR of less than 60. While those patients who did not attain renal remission at the end of 3rd month, till their last follow-up, around 35% of these patients have a GFR of less than 60. And in this subset, the mean age is slightly higher. that is 26, the mean age is around 26.5 years. It is predominantly female, and it is also important to note that most of these patients required hemodialysis to begin with. Also, around 50% of the patients require more than 2 antihypertensive medications during their follow-up for blood pressure control. One important finding that we came across was that most of the patients did not have any relapse. It was 60 patients did not relapse, while 4 patients had only 1 relapse. It was only in 2 patients that we had more than 1 relapses. The antihypertensive requirements have come down. 28 patients did not require any antihypertensive medications, while the median number of median antihypertensive requirement in the remaining patient is 2 in this data set. So currently, 5 patients are currently on eculizumab therapy at our center. We have varied phenotypes of this disease. 2 patients are anti-factor H antibody-related atypical HUS. One has received therapy of 26 weeks, while the other has received it for only 6 weeks. The longer duration follow-up has helped with hematological parameters. His hemoglobin has improved, the platelet counts have improved, and renal dysfunction has settled. Proteinuria is also showing an improvement, but antihypertensive requirements again have not come down. In the second case, the patient has received eculizumab for 6 weeks, but the hemoglobin has not settled. However, thrombocytopenia has started to settle, and serum creatinine has started to come down. Another important thing again is that the patient's antihypertensive requirement did not come down even in this case. We have one interesting case in which the patient has anti-factor H antibody negative renal limited TMA. When we give eculizumab to this patient, there was no much change in hematological parameters. It was fairly normal to begin with. However, the renal function started to improve, and her serum creatinine has come down from 1.9 to 1.3. The fourth case that we are treating with eculizumab is a complement factor H related anti-factor H negative atypical HUS. This patient has received eculizumab for 8 weeks, and there is a substantial improvement in his hematological parameters. However, renal dysfunction is continuing to persist, and antihypertensive requirements again have not come down. The fifth patient that is currently on eculizumab therapy in our center is a post-transplant who has a recurrence of TMA with acute allograft injury. Patient has received eculizumab therapy only for 4 weeks. There is no much improvement in hemoglobin as of now, but platelet counts have started to improve. The renal dysfunction, the graft dysfunction is persistent. The patient continues to remain dialysis dependent. On last follow-up 3 days back, the patient's urine output is improving. It was nil to begin with, and it has come up to 300 ml. But the patient continues to remain dialysis dependent. The antihypertensive requirements did not come down. So, thank you.
Yeah, very nice presentation. I think we all will agree that it's a bad disease to have, very dreaded disease, and probably when we were students, I think we did not heard of this entity that much. A lot of work has been done on this disease for last 2 decades, and now we have some therapy available which can at least halt the progression of disease. So one thing, what was the mortality? There was no mention about mortality. How many patients died of this disease? Because it is one of the disease where death is common, and it's everything we do, still we lose the patient. So there is no data about mortality.
Sir, most of the patients did not have a recurrent course of this illness, and only a few patients were dialysis dependent. So, mortality related to poor renal outcome, we have seen that there are 4 to 5 cases who have expired because of ESRT. However,
Probably, as sir said, mortality, there is a high mortality in the acute presentation when they come, but probably by the time they have come to us, they have been probably out of that acute phase. And that's why whatever mortality we are seeing is not the real representative mortality of the AHUS. Because, of course, in acute stages, mortality as high as 20-40% is described in various reported series prior. But we had about 4 or 5 deaths amongst the 93 patients. But this is probably not the real mortality of the disease. 5.
Any data on transplant and any patients going for transplant of these all which you have treated?
No, transplant only we had a patient who had recurred and referred to us. We had no patient that we had treated for AHUS and then went for transplant and got recurrence. This patient, which we are treating, was not thought of as a AHUS when native kidney disease was diagnosed, but she had a severe hypertension at presentation and some borderline thrombocytopenia, unknown etiology CKD. And she maintained for almost a year well, without any problem, graft function stable. And suddenly on one of the follow-ups, she noted that her creatinine has gone up, blood pressure has gone up, platelet count has dropped. And then she was referred to us. She's, we can say hematologically, her platelet count has never gone above 30-40,000, has normalized, hemoglobin has stabilized. We are hopeful because anuria has, output has increased to 300-400 ml after, I think, 4th dose she has received, and we will continue and see what happens.
May I ask one question? Excellent presentation and very impressive data from our hospital. My question is, did you notice any relation between the duration of onset of disease and eculizumab administration and the outcome? Because I guess what the changes that the antihypertensive requirement which persists and all, these changes are actually occur at the time of onset of the disease and they persist later. So I think if the duration is less, maybe we'll get even a better outcome. It's difficult to have less duration in our setting because we need to arrange the drug and all. So did you notice any difference whether the outcomes were better if the duration, if it was administered early?
of the 5 patients that we have treated, sir, there was not much difference with the antihypertensive requirements. One patient, that is this post-transplant patient, has received eculizumab within 2 weeks of presentation, and one other patient required as long as 3 months after diagnosis of HUS that we were able to administer him with eculizumab. However, there was not much difference in the antihypertensive requirement in both cases.
Okay, thanks.
I was curious to know that the relapse rate in your data was, very few patients were treated for a relapse. But if you look at the meaning, and all of us know the outcome of atypical HUS, the renal outcome is usually very poor. So these patients are the ones who had the bad kidney involvement right in the beginning, or probably ongoing fibrosis or something, so that the renal outcome is bad, but the relapse rate is not so much. Yes. Is that true?
Yes, ma'am.
And regarding the genetic, once you send anti-factor H antibody, suppose if they are positive, do you do for genetic test, or all those who are negative only are going for
No, ma'am.
genetic test?
Now we are trying to send genetic workup for all the patients.
For all the patients, irrespective of their anti-factor H antibodies. Yes. Because the management, as you are trying to tell us, is immunosuppression, no immunosuppression. So the category-wise, it is anti-factor H antibodies positive or negative. So then negative, probably genetic workup, meaning that is what I was analyzing when you were talking. Now it is open for the audience. If the audience has 1 or 2 questions, I think Bhavesh has a question.
What's the dose of plasmapheresis that we used? Can we change it in a patient who is relapsing?
Sir, it varied. It varied. Few patients responded immediately with plasmapheresis. Few patients required.
How much of plasma?
Single volume, double volume.
Sir, 1.5. 1.5 times fluid replacement was usually done. 1 to 1.5 plasma volume. Yes. One thing that we tried was we tried to give consecutive plasmapheresis if there was no evidence of infection. We gave it back to back. Yes, sir.
You saw any, what was the replacement solution? Did you see any fibrin or any bleeding tendency post plasmapheresis or anything? The replacement solution?
No, we did not see that.
Plasma
but,
to plasma, full?
No. FFP. But
Volume to volume?
Yes.
And no albumin or, okay. Any other question? Otherwise, yeah, please.
Sorry, I should know this, but what is the cost of eculizumab in India?
Sir, it has come down. It is 65,000.
A year.
Per vial, sir. 300 milligram vial, 65,000. Adults will require approximately 3 vials to begin with, and then weekly we need to give for 4 weeks. Then every time, once in 2 weeks. This was actually for our patients. Ours is the National Rare Disease Program Center of Excellence. So every patient who's registered here gets up to 50 lakh treatment free of charge.
Okay. The reason I ask is because in UK, a typical HUS is managed in Newcastle and it costs £250,000 a year. My second question was, out of interest, when we were students here, we may have mislooked at typical HUS because we just diagnosed them as HUS. And has there been any initiative to go back into the records to see was there any possibility that this was missed?
Sir, we'll try to do that.
Yeah, sure. Because we don't keep.
Yes, sir.
Thank you.
Yeah, thank you, sir.
You had minimum resources and you only had to investigate the cause of atypical HUS with a limited number of tests and try to get the maximum bang for the buck. What would that algorithm be?
Sir, it is a heterogeneous, this disease has a very heterogeneous presentation. Patient, but invariably have a significant drop in hemoglobin and platelet counts are
so probably with regards to management, only thing that would probably make a lot of difference initially, apart from the hematological diagnosis, AKI, MAHA, and that is the diagnosis of AHUS. But with regards to treatment, only thing probably that would make significant difference is anti-factor H antibody. And we are sending ADAM-TS13, but it takes about more than what usual turnaround time is expected because we have to rule out first TTP and then, but factor H antibody is something that would immediately tell us whether we want to immunosuppress this patient in addition to plasmapheresis or give just plasmapheresis. So because probably our population is slightly adolescent and adult, we had a lower frequency of factor H antibody disease. But otherwise, in pediatrics, majority of them are factor H antibody. And as Kamini Mehta madam was saying, most of them don't have other major genetic basis apart from this CFHR1 and 3 deletions. So we don't have to put money over there and rather put anti-factor H antibody and go ahead with the treatment.
I think one more thing that this type of treatment could be done only at institute like KEM. In private, it will be very difficult for most of us are doing private practice and working either own hospitals or corporate hospitals. To provide such kind of treatment at our setup is really very difficult, I think. So I think if we have patient, we should send it to our alma mater so that they get a good treatment.
Mehta madam.
We should also adapt the genetic studies regularly and all to build up our database, because what we have been seeing, was that you have multiple combination, which is not only anti-factor H antibody, and this becomes very important for the transplant patients. We have seen patients who have transplant, going for transplant, genetic abnormality positive, we are all ready to see if there's recurrence, it doesn't happen, and vice versa. And hence our database for genetic studies is very important. And I think they are now charging around 6,000-7,000.
It's not very.
Go through our,
yeah, but in private also it is 12,000. When I get it done, it is 12,000. Yeah, so it is very not very.
CFHR1 creates 37% in normal population, but still they'll end up with clinical?
So as Madam said, this terminology and this risk assessment is evolving so fast, and this controversy conferences, they keep on changing the terminology also, whether you want to call it as a complement mediated or genetic, and what is the role of antibodies. But as you said, there are so many patients we have seen, like before eculizumab even, who were transplanted with an unknown etiology chronic kidney disease, and a lot of them had only one clue probably toward thrombotic angiopathy was a severe hypertension at presentation. One couldn't even find thrombocytopenia or severe anemia, and these patients were transplanted, and they had a bad recurrence as a AHUS. And we don't know whether this malignant hypertension is one of the very common phenotype of chronic kidney disease in our patients. Second, third, fourth decade of life, they just land with 200 and 120 blood pressure, creatinine elevated, and nobody knows what is going on. And some of them who are biopsied have changes of thrombotic microbiome. This is another phenotype probably that is being considered as like one of the risks for post-transplant recurrence. Sir.
This biopsy is not done very frequently.
Yeah, I agree, yes, sir.
Because if you do a biopsy, whether to use eculizumab or not is very important, because if it is showing a chronic changes, it will not really help us.
Yes.
Because the cost is somewhere around 3.5 to 4 lakhs.
Yes, sir. Yes, sir.
For the whole course. So biopsy might help us to use eculizumab very effectively and efficiently.
Yes. So as sir said, in NPRD, a lot of your patients can benefit by eculizumab, provided that they are not very, unequivocal diagnosis of AHUS is something that is required for initiating the treatment and enrolling the patient in the program, because this being a affair of 50 lakhs and plus, later on some questions and queries may arise as to what was the basis of diagnosis of AHUS. And a lot of time we get into these discussions with hematology, and then probably a third expert in the field, whether it will be worthwhile enrolling the patient for the treatment. And then by consensus, sometimes we agree upon if there is a disagreement. But yes, in that situation, it would be a very strong case that we have a biopsy diagnosis.
Another category
Yes, sir.
of patients we are coming across quite frequently, those with IgA with severe hypertension.
Yeah.
When biopsy is done, we say TMA. And probably implicate that TMA to malignant hypertension associated with IgA. We have been previously discussing that and left away these as, yes, this is IgA with malignant hypertension. But two of the patients I have seen, both developed post-transplant reticulae.
I agree with Dr. Vilas that there is a phenotype of IgA who typically come with a malignant hypertension and advanced changes on biopsy, but they have some changes of thrombotic microangiopathy, severe vascular changes. One of our residents is currently working on this malignant hypertension and their complement and genetic evaluation. But this is another phenotype, as you said correctly, that IgA deposits are there. There is a vascular changes of thrombotic microangiopathy, whether it is advanced IgA or it is some overlap between IgA and AHUS.
Yeah, one of that patient is already on, you have seen that.
Yes. He has come with bad recurrence.
So, when we say the severe IgA with malignant hypertension, would that TMA seen on the biopsy not represent the pattern of disease rather than the actual TMA? That's what we are.
So basically, when the cases which probably Dr. Vilas is referring to, there are changes mainly observed in the vascular compartment, unlike the ones classically seen in the mesangiolisis, and those glomerular ischemia is less predominant, but they have a small vessels sometimes showing fibrin thrombi and arterial wall necrosis. And there is clearly a suggestion that there is some microangiopathy that is there in addition to IgA biopsy. Usually glomerular compartment is affected, like chronic changes are there, and these patients are not considered eligible for immunosuppression. But there are vascular changes, what to do of that, especially when we are assessing the risk of recurrence after transplant.
IgA with TMA is quite common.
Yeah. We need to understand this phenotype much more. I think we need to explore it.
I think we'll close the session. Thank you so much, everyone. Thank you so much.
Thank you, Aditya and the chairpersons, for such an engaging session. Sir, dialysis चालू हो गया है, 3 महीने हो गए, फिस्टुला भी बना दिया, पर यूरिन पूरी तरह बंद हो गया, क्या करें?
अरे दोनों किडनी फेल है, यूरिन कैसे आएगा? तभी तो डायलिसिस किया जा रहा है.
So is this really the case, or is there something else which can be done to protect our kidneys when on dialysis? So for this next session, I call upon our chairpersons on the stage, Dr. Surat Kal, Dr. Praveen Muralidharan, Dr. Kalpana Mehta, and Dr. Abhay Sadre. And our speaker for this interesting session, Dr. Pratik Shirke, to tell us all about the therapeutic benefit of PD in recovery of residual kidney function.
So, good morning to all my respected seniors. I'll be speaking regarding residual kidney function in peritoneal dialysis. To start with case 1, he is a 48-year-old male with multiple comorbidities like hypertension, retroviral disease, renal calcular disease requiring intervention, and chronic kidney disease since 5 years on conservative management. He presented to us with fluid overload and creatinine being 10. He was initiated on peritoneal dialysis with 3 exchanges of 1.5 and 2.5% solutions. At that time, he had a residual urine output of 1 to 1.5 liters. There was an uneventful PD vintage for the last 2.5 years, and currently he is doing well with 2 exchanges of 7.5 and 2.5%. The residual urine output has increased to around 3 liters now. These are his graphs. The first one shows urine output which has increased from 1.5 to 3 liters. Second, creat clearance, which has increased from 45 to 68 liters per week, and even the residual KTVV also shows improvement. Second case, she is a 51-year-old female, hypertensive since 5 years, already on maintenance hemodialysis for the last 3 years with no residual urine output. During these 3 years, she has had multiple vascular access failure, and for the same reason she was referred to KEM with access flow issues and catheter-related infection. She was initiated on peritoneal dialysis after removal of the TCC with 3 exchanges, and her urine output had increased to up to 300 ml over a period of 3 months. She is also doing well on PD at present with 3 exchanges. Urine output, as we can see, has increased from 0 to 300, and similarly even the creat clearance and KT/V has also shown improvement. So following these 2 cases, we can see the urine output has slightly improved. We already know that during the first year of dialysis, the rate of RKF decline is twice as fast in hemodialysis as compared to peritoneal dialysis. There are studies which show that there is 65% lower risk of renal kidney function loss in peritoneal dialysis as compared to hemodialysis. Why are we emphasizing so much on residual kidney function? Because it has a lot of advantages to offer, like volume control, which indirectly has better BP control, better cardiovascular outcomes, lesser dietary restrictions, so better quality of life, and the most important of which is increased survival. Canusa study has already shown us that there is a 36% decreased relative risk of death for every 250 ml increase in the urine output. Similarly, for every 5 ml increase of GFR, there is 12% reduced relative risk of death. Similarly, with Nicorsat study, which states that for every 1 increase in KT/V, mortality reduces by 56%. And the ADAMAC study, which shows us that it is the residual kidney function which offers a survival benefit and not the increased dose of dialysis clearance by increasing the dialysis clearance in PD. This is a recent meta-analysis of 2023, which has studied sustained recovery of kidney function in patients of ASKD. This is a data of over 35 years, with including 2.5 lakhs patients, and includes 10 studies. We can see that the mean improvement in the residual kidney, the mean recovery of kidney function in this study comes to 1.5%. They have defined the recovery as no requirement of any form of RIT for a period of 1 month. Few studies in this cohort have also compared peritoneal dialysis versus hemodialysis, and it was shown that PD has a more better chances of renal recovery as compared to hemodialysis. So there is no doubt that PD has to be considered as the initial best modality so as to preserve RKF, and should be offered as the initial modality for all patients who come to us with ESKD. However, we do not see this in practice. In our experience, most of the patients who are referred to us for PD, they crash land, and PD is offered to them as a part of rescue modality when all their access have been exhausted and there is no option left for continuing hemodialysis. The second category of patients who come to us are special populations like pediatric populations. Again, they have difficulty in access creation. Then people living with HIV, they don't find adequate centers catering to these people for dialysis. And the third are insured patients who get financial assistance for PD catheter implantation and for procuring the PD fluid from the government. So we studied recovery of kidney function after initiation of PD in our cohort. Anephric has been traditionally defined as a GFR of less than 1 ml per minute or a 24 urine volume of less than 100 ml by KDOKI. We studied recovery of residual kidney function. We assessed the patients after 3 months of initiation of peritoneal dialysis. For those patients who had a urine output who were anemic to begin with, a urine output of more than 100 ml was considered as renal recovery. And for the patients who had a baseline output of more than 100 ml, an increase of more than 250 ml per day was considered as renal recovery. These are our results. Total of 63 patients ranging from 18 to 60 years, equal predisposition between males and females. Regarding native kidney disease, most of the patients were belonging to the chronic tubular interstitial disease or the unknown category. This unknown category includes hypertension, retroviral diseases. 35 of the 63 patients had chosen PD as the initial modality. A significant number, almost 40 to 50%, were those who were transferred from hemodialysis in view of access failure. For these patients, the mean hemodialysis vintage was around 3 years. And the mean PD follow-up for our patient was 15 months. Of the 63 patients, 26 patients did not have any residual kidney function at the start of PD, and 37 patients had some amount of residual kidney function with them. 8 of the 26 anuric patients and 12 out of the 37 patients with residual kidney function showed improvement in the urine output. So a total of 20 patients. Of the subgroup of the patients who were transferred from hemodialysis, 20 had RKF absent and 8 had some residual kidney function present. Of this, 4 patients and 3 patients in the above categories showed improvement in the residual kidney function, so 7. For the patients who showed renal recovery, most of them belong to the unknown chronic tubular interstitial disease category. We can see here that the urine output in these patients who showed renal recovery had increased by at least three times from the start of peritoneal dialysis. Similarly, create clearance has almost doubled, and even the mean KTVV has increased by 2 to 3 times. These are the graphical representation of these patients who showed improvement. So final outcome, of these 63, 36 are still alive, of which 25 patients are ongoing with peritoneal dialysis. 7 had to be transferred to hemodialysis in view of refractory peritonitis or PD technical failure, and 4 patients have been transplanted. 27 patients have expired. A significant finding, 17 of these 27 patients who have expired did not have any residual kidney function to start with, suggesting that absent residual kidney function is an important predictor of mortality in these patients. So to conclude, 20 patients showed improvement in the residual kidney function after start of PD, and of these 20, 8 patients were from the anuric subgroup which includes 4 patients who had been transferred from hemodialysis to peritoneal dialysis in view of access failure. Thank you.
Check. Nice talk and concise too. I think for getting any benefits of residual renal function, you have to start peritoneal dialysis very early when the patients do have any residual renal function. And that is why the concept of PD first. But most of our patients, we start very late, and PD is a procedure of default more than the primary procedure. That is one thing. And the other is any experience with biocompatible fluids on the effect of RRF?
No, sir. We get PD fluids from the government schemes only, so they provide the usual things. Glucose based.
The other, there's a novel concept of using keto analogs with low protein diet rather than using high protein diet to try and preserve the renal function. Any take on that?
So our patients belong to the government category, so most of them don't afford to get those keto.
But you are doing eculizumab.
Because that is also provided by the government, sir.
I have a quick question regarding residual renal function versus preservation of residual renal function versus recovery of residual renal function. These are two different things. You're talking about recovery, which is sort of, I don't know whether that is a real concept, because many of these patients have been on dialysis for a long period of time. I don't know whether it's just a little bit of increase in urine output that you're talking about. But definitely preservation of renal function is something that there is a lot of data about. And somebody has been on dialysis for a long period of time. Recovery would be almost impossible. That is what I feel.
So by recovery, it meant only increase in the urine output, not complete renal recovery leading to...
Dr. Praveen said that recovery from somebody who is established on hemodialysis is something that is not very conceivably possible. But probably what might have happened, we were thinking about these findings, why somebody who is on dialysis for years and his anuric and his urine output has come up. So probably what has happened is, as you can see, this is a very weird kind of PD population who is opting PD as a rescue modality, which is probably not the ideal situation to begin a PD, but then we don't have any option. We call them as NVL, no vein left, for catheter or fistula. So if you are to survive, you have to be on PD. Probably what has happened in this patient is they have crash landed around the time of PD initiation, and they have gone through a lot of hemodynamic instabilities, episodes of bloodstream infections, and possibly that might have accelerated the loss of kidney function while they were on hemodialysis before getting on to the PD. So that is one thought why this must have happened. But as you said, somebody who is on dialysis for months, but as you can see here, 1.5% of the patients from the meta-analysis in Nutrients recently published, when established for more than 3 months on hemodialysis, showed a recovery, and they are talking of recovery as good as stopping dialysis. So possibly, as Dr. Ramesh Khanna used to always say, hemodialysis is a nephrotoxic medicine. So every time you are into dialysis, you are exposing your residual kidney function to something that is not very friendly to the kidney. And moreover, as I said, these people were very critical when they came to us, like on inotropes, in sepsis. So possibly that is one thought why they might have recovered from anuria to some output. And 300 ml from anuria, I would consider a very significant benefit. That's how we defined it. If you have anuria, 100 ml will be considered as significant. And if you had at baseline, then 250, and this we derived from Canusa, that 250 increment over the any increase would mean significant benefit in the survival. But thank you for the input. So we are in the process of putting this together. We are also in close discussion with Dr. Ramesh Khanna. Over last 1 year, we were discussing these cases with him. And he was very intrigued by the finding, and he encouraged us to put everything together. And he encouraged us to write it up. So we are in the process of writing up.
In your study, have you segregated the patient from urban area and rural area, so that whether to offer a positive selection peritoneal dialysis for rural area and negative selection for urban area?
So we have not segregated. Usually, patients who come to us from even from far off of Maharashtra, like they come from Pune or they come from other place, and they keep continuing peritoneal dialysis because they get the fluid from KEM itself. So they can continue. The PD technician goes to their homes and gives them the necessary instructions. Also.
Does the
Just one comment.
Does the PD prescription change? And did you notice the improvement as per the PD prescription? That means the high transporter versus the low transporter versus the improvement.
So no, sir, we haven't done that. They have been on the same PD prescription, and the improvement has also been noted with the same, like the prescription which was started to them. It has been noted with the same.
Yeah, we are in the same boat like you, because we also get the fluid from government and we have to depend on that. Only practical point which I would like to convey is that, of course, it's a very good modality. It helps preservation. I agree with you, the word should be preservation of the renal function. But, over time, we have seen that as the time passes, first 1 year, 2 years, they do extremely well, even from those who are coming to population like government hospitals or public sector unit. And after 1 year, 2 months, 2 years, then the cutting of the corners happens. Infections which become so bad and refractory that ultimately losing the peritoneal membrane. That's another problem which we are facing. I don't know about here. And secondly, those who are doing PDs regularly, if you can, at least it's my experience and our experience at Nair, including Atim would agree with me, that the catheter migration was so often, and that leads to so much of intervention, and this peritonitis part really affects the further progress of this PD. This is just a practical point as far as the peritonitis PD is
Shankar
concerned.
or Dr. Kolle, sir. Dr. Barchan, sir.
Those patients who have recovered from bit of renal function and started passing urine on PD, have they started on diuretics, or would you contemplate to start diuretics for that?
Yeah.
Or change the PD concentration?
Yes, sir. For all the patients who had an output of more than 100 ml, we have started them on maximum tolerated dose of diuretics, sir.
Kolle, sir.
All were on CAPD or some on APD also?
All are on CAPD, sir. Yes.
Many of these patients are ACE inhibitors or ARBs. They are also probably known to keep the. And how many of us are comfortable using ACE inhibitors or ARBs provided potassium is acceptable in our dialysis patients?
So those patients who had hypertension and had a significant residual kidney function, we have started them on ACE inhibitors.
Can I just ask, did you use extra knee in PD?
Yes, 7.5%.
Yes, sir. We use 7. Yes.
And while patients on cyclers, CCPD?
No, sir. All the patients are on CAPD only. Manual CAPD.
Okay.
Did you notice any differences in the improvement or in residual renal function as per the cause of chronic kidney disease?
Yes, sir. Mostly it was seen more often in the patients who had chronic tubular interstitial diseases and the hypertensive kidney diseases, and less often in diabetic kidney disease and glomerular etiology.
For a patient who moves from hemo to PD, and you see that there is some degree of improvement in urine output, which you got recovery of kidney function, assuming that this patient's dry weight estimation on hemo has been done perfectly, I think there's a big problem there in practice, where I'm not sure we pay enough attention to dry weight estimation on dialysis the way we should. If we do, you would realize that we will be able to preserve their renal function by, as measured by, as you said, urine output, far longer than if you don't. And I've seen this all the time, and we don't have too many options in estimating this dry weight, but to whatever extent it's useful, I swear by the BCM. And every patient on hemo with me has to undergo BCM every 2 months, and I was amazed to find the delta in the actual dry weight of these patients.
Yeah. I think we should reiterate this point that we are talking about recovery of RKF and not recovery of kidney function, because recovery of kidney function would mean we would successfully discontinue the dialysis. We are talking about the recovery of residual kidney function, which is not enough to discontinue dialysis, of course, but we we at least hypothesize that this recovery is probably substantial and would mean something in long term for the patient to maintain volume and possibly be having a survival benefit also, as already demonstrated by abundant literature in PD.
I would concur with Pilar. So, yes, we have also started using this.
BCM.
See, these patients of hemodialysis have had one episode of breathlessness sometime in their career. And then they're so obsessed. So they insist on the technicians, even if they're going to hypertension, remove my fluid.
Yeah.
Most of them end up being on the drier side.
Yeah.
And that's what the BCM rate
Yeah, they're trying to make most of the 4 hours. Trying to make. Yeah.
Just that.
Yeah.
Some amount of urine. That's so fine.
Yeah. Manjunath, any literature is there on the BCM, any recent or any?
So I recall BCM in the clinical assessment takes precedence.
Is there any data supported by any practices based on the BCM versus clinical assessment? So Dr. Birla might have some.
So we presented this in last year's ISM Con.
Okay.
Where the whole Lal Bagh Charaja, that cohort, subjected this to this huge bill. And huge difference to hospitalizations for pulmonary edema and
Hypotension.
hospitalization for AV fistula
Failures.
because of the delta.
Dr. Binda, when do you do the BCM? The timing is when?
It doesn't matter. It could be pre-dialysis, post-dialysis, periodically once in 2 months. Because it gives you an absolute figure. I'm not saying it's gold standard, but it definitely gives us a direction.
Mostly pre-dialysis.
We use the Fresenius machine.
Fresenius BCM. Anybody in the house has any other thoughts on? Dr. Vidyas Shankar, I think, is not in the audience. Which probably PD practitioners from down south, if they have some different observations. Okay. So, we can.
Shall we conclude?
"2023 marked a pivotal year for the department when it decided to break the shackles of Western glomerulonephritis data and guidelines and investigate key characteristics of glomerular diseases in our own Indian population. The Vidya Acharya Glomerulonephritis Registry was born, paying tribute to our greatest alma mater and the mother of nephrology herself. I invite chairpersons Ulhas Kondpalle, Dr. Hemal Shah, Dr. Atim Pajai, Dr. Sharad Seth, and to present our work and the lessons we have learned and continue to learn from this registry, let me invite a key architect of this masterpiece, Dr. Shreyasi Bose.
Good morning, everyone. I am Dr. Shreyasi Bose, and I'm very honored to have this opportunity today to talk about Dr. Vidya Acharya Glomerular Disease Registry. We began this registry in January 2023, and since then it has been a difficult yet a very rewarding experience for all of us. So today I would like to talk to you about why we decided to have this registry in the first place, how the registry practically functions in our department, and also some of the lessons that we are learning from this registry. This is an often asked question. What is the contribution of glomerular diseases in the CKD burden? So to answer this, we went back to one of our department's older works in 2015, towards which many of you in the audience must have contributed to. So this was a cross-sectional study which included 462 patients from across dialysis centers in Mumbai. And it was seen that 10% of these patients had chronic glomerulonephritis as the etiology of CKD. Also, to note, 50% of these patients did not have known etiology. So it is quite possible that some of the patients of this unknown etiology group also could have had undiagnosed CGN as the etiology. Even recent data, that is this 2021 data, also concurs with this. So which brings us to the main motive as to why we started this registry. That is, glomerulonephritis is a significant contributor to ESRD burden, and progression to renal failure can be slowed down in most and completely avoided in some of these patients if they are diagnosed well in time, if proper treatment is given, and if these patients are maintained with good follow-up. Also, we know that significant racial and regional differences exist, and for us to be able to treat our patients better, we need to know how our patients fare to how our patients behave and how they respond to treatment. So before we move ahead, I would like to look back into history, because this is what inspired us. Somewhere in the early 1970s in Toronto, the first glomerular disease registry was set up. This registry had a very simple framework and very clear goals. They wanted to have a good patient data set so that they could study the course of diseases better for better treatment and better research purposes. Let me remind all of you about how immensely this registry has contributed to our present understanding of glomerular diseases. This is a very well-known photo from the KDIGO membranous nephropathy treatment guidelines. As of today, the most accepted treatment of membranous nephropathy is that, barring the patients who present with life-threatening nephrosis, we give all patients of membranous nephropathy an optimum dose and duration of non-immunosuppressive measures. So how did we reach here? How did we know that this was the right way to go about treating membranous nephropathy? This knowledge actually comes from this Toronto Glomerular Disease Registry, Glomerular Registry group, who in 1974, over a period of a decade, followed up 184 membranous nephropathy patients, and they presented their findings in this 1992 paper. And I quote them, they said that the severity of proteinuria at a single time point is not very useful in predicting chronic renal insufficiency. They found the parameter persistent proteinuria to be a better risk predictor. And they also write that even severe proteinuria of more than 8 grams per day does not necessarily carry an adverse prognosis, provided that it is not persistent for over 6 months. And these insights that they got during the 1970s and 80s still hold good today, despite there being so many newer advancements in the field of membranous nephropathy. Now let us come to what we have learned from our cohort of membranous nephropathy patient. This is an easy question to answer. We know that membranous nephropathy carries the highest risk of thromboembolic events. Easy to answer now because, again, back in 2012, the Dr. Barber and team from the Toronto Glomerular Registry group, they analyzed this disease-specific risk of thromboembolic events in different primary glomerular diseases. And in their cohort of almost 1,300 patients, they found that 7.9% patients of membranous nephropathy had thromboembolic events. So we tried to answer this question: what is the risk of thromboembolic events in our population? Is the risk similar? Is it higher or is it lower? And we were surprised to note that in our cohort of 90 patients of membranous nephropathy, the risk was as high as 17%. And majority of these patients had some of the other life-threatening severe embolic events. So now moving on to IgA nephropathy. We know IgA is still a clinical conundrum. This disease does not behave similarly in different parts of the world. Initially, it was considered to be a benign glomerular disease in the Caucasian population, and now we are realizing that our patients behave differently. We have a more severe outcome of this disease. This too was first picked up by this 2013 study in which the Toronto Glomerular Registry group had analyzed this first multiracial cohort of patients. So they divided their cohort of IgA patients into two groups. The multiracial group had patients who were from Pacific Asian origin, the others who did not have Pacific Asian origin. And they definitely proved that Pacific Asians had more risk of decline in renal function and ESRD. However, that did not quite answer the question for Indian patients, because a footnote in the study said that patients of the Asian origin were reported to be from China, Philippines, and Vietnam. But Indians, Pakistanis, and Sri Lankans were actually clubbed together with the Caucasians and black population. So till very recently, we did not have any representation in the global IgA map. And this was changed by this group, the GRACE IgA group from CMC Vellore, who have studied 201 patients of IgA nephropathy from all across the country. They longitudinally followed up these patients for a period of 3 years and recently reported their findings in this paper, where they report that South Asians with IgA nephropathy have extensive glomerulosclerosis and tubulointerstitial nephrosis, even with preserved GFR and milder proteinuric states. And they have a significant risk of ESRD progression, particularly in the male population. So now a look at our IgA cohort in the VNA-GN registry. So we have 94 patients, predominantly male patients. The mean GFR at presentation was 47.9 ml per minute. Mean proteinuria was 3.2 gram per day. 53.2 had severe, 53.2% of patients had severe hypertension at presentation. 71.2% of patients had vascular changes of arteriosclerosis on biopsy. The broad clinical outcomes in this cohort, there were 20.2% patients went on to dialysis and 12.8% patients died during the period of follow-up. So we tried to answer this question: how can we better predict the risk of 50% decline in kidney function or end-stage renal disease in a patient with IgA nephropathy? And while we were analyzing our data, we realized two factors prominently stood out as risk factors. So severe malignant hypertension at presentation and chronicity score on kidney biopsy. The chronicity score on kidney biopsy was calculated by combining these four parameters together: the percentage of ischemic and sclerosed glomes, interstitial fibrosis, tubular atrophy, and arteriosclerosis represented by thickening of intima. This score was actually proposed by Dr. Sethi and team in 2017. So when we were analyzing our data, we realized these two were significant predictors of risk of kidney failure and death. However, our data analysis is still in its early stages, and hopefully in the next year we will be able to understand this with much greater clarity and much more in-depth knowledge. So not just the older registries, some of the newer registries have also contributed an immense deal to the newer advancements that are happening in all across glomerular diseases. We have newer insights into the autoimmune etiology of podocytopathies, and two of the newer cohorts, the Neptune cohort and the Hamburg glomerulonephritis registry. The Neptune is a North American cohort and Hamburg registry is from Germany. These two cohorts have participated in the studies that have analyzed the autoantibodies in podocytopathy. Other registries like the Podonet registry, this is the largest registry of pediatric steroid-resistant nephrotic syndrome patients. And so we have many good global glomerular disease registries ongoing. However, we are still underrepresented in this list. So a big shout out to the first Indian multi-centric glomerular disease registry, that is the iTangible registry. And they recently published their findings last year. Also the GRACE IgA group. So now coming to how practically we run this registry in our department. The framework is quite similar to the Toronto registry framework. This is our team. Apart from the nephrology department, we have two nephropathologists, Dr. Gwendolyn Fernandez and Dr. Amay Rojekar. We have 4 very dedicated registry staff. We have a biostatistician from our institute. This is the registry office, which we will all walk you through during the department visit. The brief outline of our clinic is we have our general nephrology OPD on Tuesdays, where a suspected glomerular disease patient is assessed and a biopsy appointment is given. The patient comes for the biopsy appointment, where a patient proforma is made. After the biopsy, we have weekly nephropatho meets on Saturdays, where we discuss with our pathologists, and a formal diagnosis and plan of action is decided for the patients. And then these patients are called to the special glomerular disease clinic on Thursday afternoons. In this clinic, in the glomerular disease clinic, the patient first comes for the nephrology consult, after which they are informed about the registry, and informed consent for participation in the registry is taken, following which they are directed to the registry office, where the registry staff uploads all relevant details of the patients to disease-specific Google Sheets. The disease-specific registry number is given to these patients, and registry staff maintains an appointment register, and they give appointments for subsequent visits. Till now, so we have included all patients whose biopsies have been done from after January 1st, 2019. So till now, we have enrolled 694 patients in our registry. The maximum number of patients are in the podocytopathy and SLE cohorts. We also have IgA, MN, and MPGN, total of 5 cohorts. The mean age is the highest in the membranous nephropathy group. We also have the mean age in the podocytopathy group is also higher, because we have included all the adolescent and adult patients of nephrotic syndrome, and pediatric, only those with atypical features who have required biopsies have been included in this group. Male, most of the all the groups have a higher male percentage, except for the lupus nephritis group. Hypertension at onset of the disease was significantly seen in the IgA nephropathy cohort. Also, quite expectedly, the heavy proteinuric conditions of podocytopathy and MN had the highest mean proteinuria at onset of the disease, more than 6 grams per day. eGFR at the onset was lowest in the IgA cohort, and in tune with that, maximum of the IgA patients, almost 20%, went on to dialysis. Death as outcome was seen almost equally in the IgA and MPGN cohorts. So over the last few years, we have realized that the registry staff play the most pivotal role in maintaining of the registry. They are not only trained to identify all relevant documents, investigations, clinical sheets, and uploading these documents after every OPD visit of the patient, but their biggest challenge is to ensure that patients do not get lost to follow-up. So we have multiple ways of doing that. The staff maintains a log of phone numbers where they periodically contact these patients, especially if they miss their OPD visits, they are reissued new appointments on the phone. But despite so many measures, we are still seeing a significant 20% patient loss to follow-up. And that the maximum number of such patients in the podocytopathy and membranous groups. Possibly because in these disease conditions, once the patient responds to treatment, once edema subsides, once the patient start feeling better, they generally do not come back for follow-up, mainly because they travel from very far off places. But this is an area that we are working upon and hopefully will improve in the coming days. And lastly, this is the last segment of my talk. We are very happy to share that this registry works as an excellent research platform. We have recently completed a randomized control trial in our department to study the safety and efficacy of dual RAS blockade in primary glomerular diseases. We have 2 ongoing trials. The first one is of C3 glomerulopathy, which is supported by the GLOMCON Physician Scientist Scholarship received by Dr. Saili Thakre in the year 2024. Another ongoing trial is in collaboration with the Grace IgA Nephropathy Group in CMC Vellore. It's a multi-centric RCT, and KEM is one of the centers. And we are comparing the efficacy of the newer approved therapies of IgA nephropathy with standard of care. We also have a global phase 3 RCT of felzartamab in the pipeline. So this brings me to the end of my talk, and this is through this presentation, I, on the behalf of entire Department of Nephrology, would like to express our heartfelt gratitude to all senior alumni, because for carrying forward such a strong legacy of record keeping and patient follow-up by means of these pro formas. And this registry actually stands on the foundation that all of you have laid in the past years. So thank you.
So first of all, I'd like to congratulate the current team for keeping the flag flying high. It's just amazing to see the good work that continues to come out of KEM. My question to the registry team here is about the electron microscopy. How important it is, how have you all found it? And would you recommend, like we do it very often, so is it really required from your experience? And how do you manage if you don't have that data?
Sir, we have realized that electron microscopy is important. We get this test done for most of our patients. Of course, because it is not done in KEM, sometimes we are not able to do because of financial constraints. But in our experience, yes, for for treatment purposes, electron microscopy plays a very important role. Yes, sir.
Phenomenal initiative.
Thank you, sir.
My question is, for a registry, size matters.
Yes.
Why can't this be a city-wide registry? What is it that the city nephrologists can do to contribute all their patients into this registry?
So, sir, currently we have one center, Fortis Mulund, Dr. Vaibhav Keskar. He has, so what he has done is whenever he sees one of the patients who can be categorized in one of these cohorts, he sends across the patient, we have sent him the format of data entry. So he sends across his clinical notes, baseline investigations, and all follow-up records over WhatsApp to us. And we have entered, currently we have 4 patients from that institute in the registry as well. So yes, that can be done, and it should be done so that we have a wider database.
So I was not aware that nephrologists could contribute. Could we do this retrospectively?
Yes.
In retrospectively, it would be a little difficult because we need to have, then there will be a lot of selection bias, like people who have who are on dialysis or have not survived would be filtered out. So that's why we have restricted ourselves in time to 2019, where probably we will have a reliable forward follow-up and not a lot of attrition. So probably what major challenge a single nephrologist, like Vaibhav can tell his experience, what challenge he has faced, but probably one dedicated staff which will not be the secretary of the clinic would be important, who can be trained as to the data points to be captured and uploaded and archived. Probably I think that is the only thing that that participating center would be requiring to put in. Not a great challenge probably.
No, if there is a way in which, say you said 2019, I'll send you all my biopsies I've done from 2019 and an electronic health record of everything that was done. Would that help?
Yeah, that would help. But see, idea here was a reliable longitudinal follow-up. When we say that 15% of our IgA nephropathy are on dialysis, we want to know what is the denominator that we are talking about. So that would, if we go a lot of into the past, so what we have experienced is that most of these patients, IgA, MPGN, who are likely to progress or likely to get complications and die of the disease or treatment-related morbidity, mortality, are likely to get filtered out because we don't have their data after some time point. Like he has visited at, say, 22 February, and after that we don't know what has happened to him. He suddenly stopped coming. So that is the challenge that we thought. I think we can think about, like everybody will have a different depth and length.
I think the two of you need to sit down and talk, so we'll open it to the rest of the people. Yeah.
So Dr. Kolle, please. Yeah, one by one, I think. Yes, sir.
No, I think the same sentiments as expressed by wish that everybody, at least at the end of today's program, would wish that this registry could be broadened on to include TCT nephrologists, and maybe you will have to formulate some way in which to incorporate.
Yes, we should.
I think a problem with the private setup is that you will only get a point behavioral. The patients are not with us.
So I think it is not, it is simple but not easy. I think we'll have to put efforts, dedicated efforts, and that's why I said we want somebody who is not just a clinic secretary or dedicated staff who is ready to shoulder
Think
this
about it. Think about it. Lay down a good, solid
yes.
protocol.
It's
If
possible.
people can
It's
follow
not
it,
that easy.
accept it. Otherwise,
Yes, it is.
But
Yes,
it's a good thought.
possible.
It's an excellent thought.
Can we come to the presentation related questions?
Yeah, please, sir. Please.
Okay, so two things. One, you said about the progression of the disease, hypertension and the chronicity and the biopsy. Did you look at the degree of proteinuria to be targeted to prevent progression to kidney disease?
Yes, sir. We looked at degree of proteinuria, but did not have a very significant correlation. That is why we these were the two factors which had a significant correlation to.
The literature, right?
Yes.
Everybody says proteinuria is the
Probably that's true in the classic IgA nephropathy that comes in typically Caucasian patients, asymptomatic hematuria, some proteinuria, and we have started the train, boarded the train. But here probably we are boarding the train very late into the course. Whether it is a disease itself that is different and malignant, or it's patients coming differently late. But we looked at this. We were curious to know whether we can simply explain the bad outcomes based upon the late presentation. But then when we compared it, time to nephrology consult from the onset of symptom was not different in IgA and many other glomerular diseases. So probably there is something to do with the disease itself. We need to understand that better. Yes.
You know.
Yes, sir. Yes, we had.
So you made a point about our patients being different from the international data that is there for their patients. Is there any standout treatment-based difference that you've seen that we do differently and it works just as well compared to what the Western literature is suggesting?
Sir, as of now, I will not be able to say very confidently, but yes, we are looking
The
at
pipeline.
that aspect and
Sure.
we'll be.
The other thing is about the 5 cohorts you presented. You said MPGN. Now, what MPGN are we talking about? Are we sub-classifying that as per the letter? Because 99,
Yes.
2019 are a different,
maybe you're right.
classification. So how are we including that MPGN?
So, sir, our cohort have almost an equal distribution of patients with C3 glomerulopathy. We have infection-related glomerulonephritis. We have MGRS. And we have some, and we have a good chunk of patients who do not have any classified etiology yet. So we have a very diverse group of patients which we have kept under this blanket of MPGN.
So our Dhurandhar is threatening me from there to last question.
Yes, sir. One last question.
I think this is excellent work, to be honest. In England, we are trying to develop a community of practice for glomerulonephritis, but I think we all should appreciate the hard work which has gone into this. This is really, really good.
Thank you.
And I'm with Vishwanath here that we need to collaborate. You need to collaborate actually, because I'm not from this part of the world. But you need to collaborate to make sure that it has the city-wide, and you require the nephrohistopathologist to contribute to the glomerulonephritis registry. So, well done. Congratulations. Thank you.
Thank you. We should close the things, and the further discussion should be done on dinner table or anything. Thank you.
And it's a great tribute to Madam. It's a great tribute to Madam on behalf of the department. I think name in her, the registry in her name is a great tribute to Madam.
This next session needs no introduction. This is phenomenal original research, so stunning that the entire Indian and global nephrology community applauded it at the recent ISN Con at Lucknow. I call upon the chairpersons, Dr. Mihir Kulkarni, Dr. Bhavesh Vora, Dr. Pradeep KJ, and Dr. Vishwanath Billa, and to unravel the mystery that is primary distal RTA, I call upon the woman of the moment, Dr. Saili Thakre.
So, respected chairpersons, teachers, seniors, and my dear colleagues, I will be talking about a recently concluded study from our department, again carrying on the legacy of a great record keeping for more than 3 decades that we have seen for this particular rare disease. Most importantly, because it's a rare disease, this would never have been possible had it been any other setting apart from that we have in KEM. So a quick run through the basics of the disease. Distal RTA, as we know, is a single cell disorder. It arises from the alpha intercalated cells in the collecting tubule of the distal nephron. The alpha intercalated cells are one of the 4 major cell types in the distal collecting tubule, and along with the beta intercalated cells, the non-A, non-B intercalated cells, they carry on the function of acid-base homeostasis in that part of the nephron. The other important cell type is the principal cell, which is also indirectly involved in the pathophysiology of distal RTA. So the primary defect is an inability to secrete hydrogen ions into the urinary lumen. And the 2 major transporters that enable this, and they do not work in distal RTA, are the vacuolar type hydrogen ATPase at the basolateral membrane, at the apical membrane, and a complementary chloride bicarbonate exchanger, anion exchanger at the basolateral membrane that is responsible for generating a complementary current. So the cardinal metabolic features are normal anion gap metabolic acidosis, but at the same time, an inappropriately elevated urinary pH. And not only these, there are far-reaching effects on the system, and that lead to hypercalciuria due to the effect of acidosis on the skeleton, hypositraturia due to the effect of acidosis on the proximal tubular secretion of citrate, and effects on other distal epithelia and the principal cells, leading to salt wasting, hypokalemia, and polyuria. These signature abnormalities cause a typical picture of growth failure in childhood and a susceptibility to infections, dehydrations, intercurrent illnesses, oftentimes leading to episodes of acute kidney injury, and otherwise skeletal growth abnormalities in the form of rickets, deformities, and fractures, and nephrocalcinosis and nephrolithiasis. These all dysfunctions lead to an imminently preventable final adult picture of a stunted height, residual bony deformities, poor bone health, a predisposition to CKD, and need for a lifelong therapy. So this is how the typical disease course in primary distal RTA looks like. Onset somewhere in the childhood with features affecting growth, skeleton, and hypokalemic paralysis and AKI as episodic events in between, and further progression until the end of childhood. At the end of childhood, we have an adult who has stunted height, many bony deformities, and possibly also CKD at this moment itself. Being a rare disease, distal RTA has been reported mainly in case reports and case series with very few cohorts mentioned till date. Many of these are from the European countries and Southeast Asia, as you can see here, and recently now we have data coming from India. The incidence of distal RTA in the United States is so low or so sparsely reported that the National Organization for Rare Diseases, the NORD, reports its incidence as unknown. Best conservative estimates are 0.38 per lakh population. In the UK, the registry data quotes a prevalence of 1 in 1 lakh population. And there's some data to say that this is the most common tubular abnormality in Asian children. And it occurs at a higher prevalence it occurs at a higher incidence in Asians. This is to show you the largest study that we have for reference. This was from the European Distal RTA Consortium, recently published in 2019. And this has data from 29 countries. They could put together 340 patients. But let me tell you that this is a questionnaire-based study, so none of the investigators have really seen all the patients that they have really enrolled over here. Let me go through the genetic etiology of this disease. Till date, we have 5 genes which are known to be causative of distal RTA. Out of these, the first 3, SLC4A1, ATP6V1B1, and ATP6V0A4, are responsible for the 2 cardinal the ion transporters that are responsible for distal RTA. So the SLC4A1 codes for the anion exchanger, the ATP6V1B1 and V0A4 code for the vacuolar type H+ ATPase at the apical membrane, and these were known to us since more than 25 years. So a quick pathophysiology for the SLC4A1 distal RTA, because this is the most common type that we are going to see. The mutant SLC4A1 the protein gets either retained in the Golgi apparatus or the endoplasmic reticulum, or it gets destroyed early by the lysosomes, or it gets mistargeted to the apical membrane where it has no business of being. In any case, it impedes the proton transport. And ATP6V1B1 and V0A4 genes code for the actual vacuolar H-type ATPase that carries out the function of proton transport, and hence this is the one which causes the most severe type of dystallate A. There are two other novel genes which were discovered in 2018, and these are the WDR72 and the FOXY1. New candidate genes are being explored, and as we speak, new candidates are being added to this disease. So the WDR72, which is the fourth gene now known, is actually a protein which facilitates trafficking of the vesicles which carry various ion transporters to their respective membranes. And FOXY1 is it's a transcription factor which, when mutated, results in decreased production of target genes, many of which are these ion channels itself. Most of these studies which are existing at present show data only of the most three common genotypes, and we have hardly data for the novel genotypes. And this is to show that the largest study that we have also had no mention for the novel genotypes that we currently know. And intriguing fact about all of these is also that they all have typical extra-renal manifestations which help in identification of the disease, the underlying genetic defect. So for example, ATP6V1B1, V0A4 and FOXY1, all three of them have a common manifestation of sensory neural hearing loss. They have enlarged vestibular aqueduct or enlarged endolymphatic sac as another manifestation. Amelogenesis imperfecta or enamel dysplasia is a cardinal feature of WDR72 mutations, and anemia, hemolytic anemia, either with ovulocytosis or spherocytosis or stomatocytosis or xerocytosis, many phenotypes, is associated with the mutations with SLC4A1. So let me go to the study. The study was conducted at our own renal tubulopathy clinic over a duration of 4 years, and incident and prevalent patients were enrolled in this study. Their demography, clinical features, and laboratory features were noted. Consenting patients underwent whole exome sequencing, and further on, genotype-phenotype correlations were established. We excluded secondary causes of dystallate A, including autoimmunity, drugs, and many others. And this is how the final enrollment looks like. We were able to enroll 63 patients with a clinical diagnosis of dystallate A for this study, and out of which we excluded 11 patients upon discovery of some genetic defects which were not pertaining to dystallate A, primary dystallate A. So out of the 52 patients, 37 had a genotype positive for 5 of the genes that we just saw, the cardinal genes in dystallate A, and 10 others were genotype negative. There were 5 which had variants of unknown significance, which were not classically taken as genes causing dystallate A, so they were kept aside. And a total of 56 patients, along with their family members, were analyzed for genotype-phenotype correlations. So at the initial presentation, this was their phenotype. We had an equal gender distribution. Most of the patients at the onset of the disease were children, more than 90%, and there was a high rate of parental consanguinity in this cohort, up to 40%. Many of them, 80% had failure to thrive, 70% had polyuria, polydipsia, 70% had rickets. A few of them, 1/5 of them, had hypokalemic paralysis. And the age at onset of the first clinical symptom was 1 year. It was very homogeneously around 1 year and less than 5 years for most of the patients. The age at diagnosis, however, the age at clinical diagnosis, however, was 45 months, just 3 months short of 4 years. This gave us a metric of delay in diagnosis of around 17 months, which in the growth phase of a child is actually something to consider. A delay in diagnosis when the child is growing could actually have a significant impact on the further outcomes. We can see here that their mean height at their initial presentation was very poor. The standard deviation scores was -3.9. 80% of them had short stature, and 60%, as high as 60%, had a severe short stature with less than 3 standard deviation score for the height. They all had acidosis with serum bicarbonate averaging at around 12, urine pH high more than 7, hypokalemia in 86%, elevated calcium creat ratio in the urine for 70%. Most of them had hypocytraturia, a very typical manifestation, and hypophosphatemia was present in 64%. 5 of 10 patients who were evaluated for a concomitant proximal tubulopathy actually ended up having features of concomitant tubulopathy, which is also a very well-known feature of distal RTA. What about the renal function at initial presentation? We had a GFR averaging at 66, a very low GFR averaging at 66 at the initial presentation, with almost 37% patients having a GFR less than 60 to begin with. Most of them had nephrocalcinosis, nephrolithiasis right at the outset of the disease. And this, in the further few slides, I will be comparing the initial data at presentation with the other existing cohorts, including an Indian cohort from AIIMS New Delhi, which was described very recently last year. So as you can see here, none of these actually mentioned delay in diagnosis, which was something we could compute because we tried to make a distinction between the age at first clinical symptom and the actual age at diagnosis for all of our patients. Most of the parameters at initial presentation are not available for most of the cohorts, and we should thank the record keeping in our department for us to give an insight into the initial presentation for this particular aspect. These all patients were followed up for a mean duration of 15 years. This makes it the longest follow-up durations in distal RTA, and the closest being 10 years and 6 years for the Indian study. And how do they look like now at their last clinical visit? So most of them are now adults. More than 50% are adults with a mean age of around 21 years. More than 50% of the patients have a follow-up of 10 years, and more than 1/3 of them have a follow-up of 20 years. But we can still see that their final heights are very poor, -3 standard deviation scores. Only 42% of the children who had an onset in the childhood could attain their adult height. Almost 1/3 of them had bony deformities persisting into adulthood. Many of them required surgical correction. And they kept on getting hypokalemic paralysis later on during follow-up, some even multiple episodes during follow-up, and 1/3 of the cohort actually experienced bone fractures. And what about the growth on follow-up? So as we can see in this chart here, most of the European cohorts seem to have very less impediment of growth, which is not so for the Indian studies, including ours. And the kidney function on follow-up, the eGFR at the last visit was 88 ml per minute per 1.73. And the lowest eGFR that we recorded was 39 in a patient who was 53 years old and following up with us since 3 years of age. So 73% of the children had CKD stage 2, which is quite a lot to say. 40% of adults had CKD stage 2, and a significant number of children and adults also had CKD stage 3. I compare this with the SEEK study, which gives the incidence of CKD stages in the adult population in India. And you can see that CKD stage 2 is just 10.2% in the Indian population as compared to our cohort of distal RTA, where it is 40%, as high as 40%. This also echoes in comparison with the other European cohorts, where the CKD stages appear to be more advanced in our patients with distal RTA. Distal RTA and proteinuria was not really an association which was noticed or discussed. We found that 1/5 of our patients had persistent proteinuria more than 300 milligrams per deciliter, ranging to a maximum of even 1 gram per day in one particular patient. And metabolic control seems to be universally poor in our cohort as compared to even other cohorts. This seems to be a universal issue with patient follow-up. So now coming to the genetic testing, we had 71% yield of genetic testing in the cohort comparatively equal to most of the other cohorts. And most importantly, how do the negative patients actually look like, the 10 negative patients compared to the 10 genotype positive patients? So as you can see here, we have the genotype negative patients have less failure to thrive, they have less polyuria, they have less rickets, they have less bony deformities, but they present more so as hypokalemic paralysis, and they tend to have less episodes on further follow-up. They have a higher serum bicarbonate, they have a lower urine pH, they have a retained ability to possibly acidify the urine, and they have less incidence of medullary nephrocalcinosis. So most of the cardinal features are lacking in the genotype negative cohort, though they clinically come to us as a classic distal RTA. And this is the distribution that we found of the genotypes in our population. The most common one is SLC4A1. And as you can see here, there are two variants of this disease. One is a biallelic disease and one is a monoallelic disease. We found that novel mutations, the WDR and FOXC1, amounted to as high as 15% of the population. An intriguing point to note is the biallelic disease in India seems to be caused exclusively by only one variant, that is the alanine 858 aspartate variant. And all the 17 patients that we saw, without an exception, showed this one particular mutation. So little recap, we know that 3 of the 5 genotypes have hearing loss as a manifestation. The SLC4A1 has hemolytic anemia as the manifestation, and WDR has enamel defects as the manifestation. So SLC4A1, we know that hemolytic anemia is expected. And why is this so? This is because the SLC4A1 gene encodes for band 3, which is the most abundant protein in the RBC membrane. And you can see that it, along with the ankyrin and other cytoskeletal proteins, is very integral to maintaining the integrity of the base of the RBC membrane, the shape of the RBC membrane. This recessive form, this biallelic form, this autosomal recessive and homozygous form appears to be more common in Southeast Asia, as opposed to, in stark contrast to the one that is seen in Europeans, and that is the dominant form or the heterozygous form or the monoallelic form. This is the only paper that we have for reference for all of these cases put together. And if you see the map, the red cases are this mutation that we have recurrently found in our patient, the alanine 858 aspartase mutation. And the peripheral smear here shows spherocytosis or acanthocytosis. We were very fortunate to work with the team who pioneered research in this disease. This is the team from ICMR, Department of Hematogenetics, situated right in the KEM hospital campus with us. If the phenotype that you face is distal renal tubular acidosis and anemia, look for this mutation. And what do these patients show? You can see that there's a clinically variable anemia, which is not explained in an otherwise healthy young child. And even if you end up having hemoglobins 14 and 15, certainly most being normal, you still have a smear that shows spherocytes and acanthocytes. This team at ICMR employed a test called as eosin 5-malleamide test, which is erstwhile it was used for hereditary spherocytosis, and it was found that this is 100% positive predictive for this particular mutation in our population. So all the 17 patients that we had, you could just not do the genetic test and still come to the same conclusion that this patient has a hemolytic anemia variant of distal RTA. So all 100% of the patients ended up being positive for this test, and all of them showed spherocytes, acanthocytes, and they had a variable degree of anemia. We also came to know through our study that there seems to be a north and south divide, just like what happens in the globe with SLC4A1 mutations for distal RTA. The southern part of India mimics the Southeast Asian region, and the northern part of India, northwards of the Tropic of Cancer, mimics the Caucasian population. And the dominant disease is more common in North India, and the recessive disease, as we have seen, is more common in the southern parts of the country. This can be called as the founder variant, at least for the southern parts of our country. So if you see a patient who comes to you with a distal RTA, who has unexplained anemia, who has need for blood transfusion, because 1/3 of our patients also needed blood transfusions, which is also very surprising to us. They have, or they otherwise have varying hemoglobin levels, or sometimes even a frank hemolytic anemia, and they have a positive EMA testing for osmotic fragility, then invariably, almost 100% of the times, you are dealing with this variant of distal RTA, this genotype of distal RTA. And now the other novel mutation, which has enamel defects as the extrarenal feature. Yellow teeth, dramatic yellow teeth, are present in 100% of our patients. And this enamel defect starts right from the primary dentition itself, as we got to know from the interview with the parents. So apart from this very dramatic phenotypic manifestation, there's another very subtle phenotypic variability that this type of distal RTA seems to be showing. another study from AIMS New Delhi, and here they find that this actually, unlike the other RTAs, unlike the other recessive RTAs, has a very mild rate-dependent distal RTA and with a very variable metabolic acidosis. Now, we in our study were able to tease out the clinical evidence for this metabolic variability, and we found that as opposed to the other recessive forms, this form has a little later age of detection. The patients appear to report well-being without being on therapy for many years. Two of our relatives of our patients actually had enamel defects only without any manifestation of distal RTA. This indicates some period of metabolic quiescence in this disease which needs further evaluation and further follow-up. But the consequences are this disease seems to be a little unnoticed from the patients and more delay in presenting to the hospitals, leading to more poor growth rates. As you can see, the final height in this cohort is not really improved as much as we expect from the others. And more episodes of hypokalemic paralysis, more renal manifestations like nephrolithiasis, and more cysts in this population more than the other genotypes. You can see here that the citrate appears to be normal in few patients with WDR72 genotype, which is almost unheard of in many others in the other forms of distal RTA. So here again, you have a patient presenting typically a little later, not really early in infancy, a little later with enamel dysplasia, yellow teeth, need for dental consults early in life, or even a complete loss of dentition in adulthood to be replaced by dentures. And you have almost another phenotype which can give you 100% predictive value for the underlying genetic defect, that is WDR72. The most well-known forms, the ATP6V1B1, and the most severe forms affecting the hydrogen transport directly, with the enlarged endolymphatic sac and sensory neural hearing loss. The most important differentiator that we found for this genotype, which is not very well, which doesn't come across very well in the known literature, is that these seem to present invariably in the first or the second quarter of infancy, meaning to say in 3 or 6 months of infancy, these patients seem to be presenting with very severe metabolic disturbances compared to the other ones where the ages are much later. An intriguing finding also was many of these patients gave a history of early deaths of siblings in infancy, which also points out towards the severity of this disease. These come with a severe failure to thrive. They do not have hypokalemic paralysis because probably they come too young to us to even develop hypokalemic paralysis. There is a difference between the GFR at presentation in these patients. It is quite low, and this also indicates the severity of the metabolic defect, causing acute kidney injury, which recovers for almost all of them. But paradoxically, you can see here that these are the patients who gain heights the best. So if they start with an initial height of -5.5, they appear to have gained to a -2.2, and this reflects the phenomenon of preserved compliance, better compliance in the face of severe symptoms. If you don't take therapy, the patient would really not do well, and this means that the compliance in these groups reflects in the better growth for them. This is also echoed in some other cohorts where they have found this peculiar phenomenon of the highest height gains for this most severe genotype. So we have expanded the spectrum of this genotype in our country. We have found that it presents very, very early, often with a family history of previous deaths, which is not the case with the other genotypes. It's a very severe phenotype: early failure to thrive, early nephrocalcinosis. Almost all of them, more than 95% of them have nephrocalcinosis right at the presentation. Very low GFRs at the initial presentation, but they achieve the best heights. And there's something else that we are still working on. Certain heterozygotes in this recessive disease appear to be symptomatic, and we have at least one variant that shows this, and we have discussed this also in the paper that we have published. So this distal RTA is not very difficult to find, except that the ages at presentation are very early, a history of deaths, and a sensory neural hearing loss occurring in the first decade of life, more so for the V1B1 and less so for the V0A4, if there's to be a difference between them. And now the rarest of the rare cases, the FOXY1 case, this is also similar to the ATP6 mutations. However, This is the 4th reported case in the entire world, and this is the 2nd publication which gives a case of FOXY1 mutation. So this child was born of a non-consanguineous union. She had this mutation, arginine 213 leucine, and presented very early with a failure to thrive, rickets, delayed motor milestones, hearing loss at 8 years of age, nephrocalcinosis at 14 years of age, and now at 35 years of age, she actually has a fair height. She has no bony deformities, and her latest GFR is much better than the mean of the rest of the cohort. It's at 91. So she's followed up very well for more than 3 decades with us, and that's what's led to very good outcomes for this particular case, despite it being a very rare mutation. And of course, she has enlarged vestibular aqueducts on temporal bone imaging. So the key, we have a lot of medical and clinical takeaways from this study. A lot of expansion of the phenotype seen in the cardinal genes that are listed for distal RTA. But we got thinking that if an adult comes to us and transitions to us from pediatric care with a stunted height, with deformities, and with an already existing CKD, what is going to happen next? What about if the patient gets more episodes of unrelated AKI later? What if the patient gets diabetes, hypertension, and gets kidney involvement due to chronic disease later on in the life? He has a poor bone health, and all this while battling the manifestations of the extrarenal manifestations of hemolytic anemia, hearing loss, and the dental complications. And of course, what are the questions and what are the implications to the progeny? So there's a lot to do. So the key takeaways, very succinctly, will be early detection and adherence to therapy are surprisingly the most important factors in this rare tubulopathy, which can actually alter the outcomes of the patients. And this also told me a lot about the power of genetic testing in today's world, that most of the patients who I interacted with, they actually expected their children to die when they got the patients acutely in their episodes of severe electrolyte disturbance or hyperkalemic paralysis. Most of them expected their children to die, and the frequent repeated questions were, will my child live? Will my child get educated, get married, have a healthy progeny? These were the recurring questions in almost all of these patients, and I'm very thankful that they shared their life stories with me as I sought to understand their disease course in details for this study. So the power of genetic testing is not possibly in creating huge biobanks or creating some Nobel-winning projects or designing gene therapies. It is right there in our clinic where where I found that I could instill confidence in a parent about the prognosis of a child, and I could say that if you adhere to a therapy, your child can almost lead a normal life. So this was one of the most important takeaways for us as a team regarding this rare disease. I would pause for a moment and take this moment to pay a tribute to the great legacy that we are discussing since morning. And studies like these are not possible. We would all be lost like Alice's in the wonderland of nephrology had it not been for the vision and the work of all of us who have gathered here today. I have some acknowledgements to make. This was an entirely intramurally supported study. We had grants from various sources, which was also extremely difficult for us to get. And this is a photograph that I would like to show. This is from 1984. Many of you may remember this. This is Dr. Oliver Wrong, a giant in nephrology, a great clinician, a scientist extraordinaire, and a giant in the field of renal tubulopathy, who worked extensively on distal renal tubular acidosis. He had come to the department. He was sitting right here in the MLT for the inauguration of the 34A unit, the 34A unit that we have currently. And I would really say that this disease taught me that we must acknowledge that kidneys constitute the major foundation of our physiological freedom. A disease as simple as losing electrolytes in the urine can trap you into the disease for almost a lifetime. And our kidneys actually constitute the major foundation of this freedom that we have. So thank you so much.
I think I would ask the audience to go first.
Thank you so much.
Thank you, Saili, for such a beautiful presentation. I think very few again are odds pediatric nephrologists where we stand out. And I think this disease, meaning I tell all my patients when I see this, that if you, meaning apart from nephrotic syndrome, which is over a period of time going to get better, if any other disease which God may give to your child, and it is a distal RTA. And I think the take-home message for everyone sitting over here, and the 2-3 points I would highlight from Saili's talk is 40% was the, metabolic poor compliance in your data, and 40% was, the rate of stage 2 CKD in your cohort. And this is the most important thing. I think it is the compliance, and all my patients, I have the way you are expecting the life expectancy or adult height or, progeny, everything, meaning we have over a period of 25 years distal RTA followed up. If they have a hearing function, if they are getting the aid, their hearing improves, their speech improves. We have hepatosplenomegaly, and when we work them up, and we have seen spherocytosis. And, it is the simple soda bicarb, which is such a simple thing, and potassium citrate, which is, you just give them and they just grow in height. So it is such a simple thing to treat without any expenses, and when the child grows, I think the follow-up automatically improves. Once they are, given bicarbonate therapy, their bony deformity goes away. We have seen children who are, picked up early, meaning they come early, and the standing instructions to all the patients with tubulopathy is, if their child gets any loose motion, any vomiting, immediately go to the doctor, tell them to fix IV line if the loose motion vomiting is not controlled, so that we can prevent AKI. And no nephrotoxic drugs for them. So, and when they go for any surgery, start when they are NBM, start them on IV fluids. So these are the standing instructions given to all tubulopathies, and we have seen beautiful results. I think that is the take-home message. Poor compliance, poor outcome. And very simple therapy, only portrate they require. And again, so many people give pot chlor, meaning it is not the chloride containing solution we cannot give them. It is potassium citrate, and we have to give, again it contains MB6 also. So it is again magnesium also is going to help, and soda mint. Such a cheap thing. I think
Thank you, ma'am.
If God gives somebody some kidney disease, apart from nephrotic syndrome, I think renal, meaning distal tubular acidosis, and it is so easy to treat, and it is, very cheap, and it is autosomal recessive. So if, meaning we have girls who have got married, they have got pregnancy, and their children are normal, because it is autosomal recessive.
Yes, ma'am.
Thanks, Kamini.
Yeah, we had presented a case in the Indian Journal.
Yes, sir, yes.
SCL4.
Yes.
So 28-year-old girl, she has gone to multiple consultants, to the endocrinologist, to the bone specialist, to the nephrologist. And then finally we detected that she had this hemolytic anemia, and she was looking like a gnome, stunted and steroid faces and all that. And now in treatment she's turned out into a beautiful lady. She's married and she's had a child also. But she refused to do genetic testing of the child or the parents.
We've referred to your case, sir, and the therapy is actually transformative. If you look at their courses, we realize that the therapy in this disease is actually transformative for the patients.
There is a center of Central Institute for Education in Deafness. There is an institute run by the ENT, for the deafness and all those things. I was pleasantly surprised to know that they are conducting basic metabolic workup for all their deaf patients to figure out whether they have any associated illness. So we can probably pass on this message to our ENT colleagues also, that if they are seeing somebody deaf at an unusually younger age, please look for metabolic workup.
Sorry. All these patients were, anyone was having incomplete distal RTA. There is no clinically obvious metabolic acidosis. but maybe later in the age, they may present with just renal calculus disease. Whether they can manifest like that, this genetic disorder, people later in the age,
This was actually
incomplete distal RTA.
our starting point was a clinical diagnosis. An established disease was our starting point for inclusion into the study. So we have not really looked into the incomplete RTAs, though we have done quite a few acid loading tests as well. But this study was not pertaining to incomplete RTAs.
One last question. How often do you see proximal diseases
In distal
or
RTA,
registry? In your clinic, in your
Yeah, so-
tubular clinic? How often do you
Not
see
as often
proximal
as- yeah.
disease?
So now they come under the moniker of Fanconi renotubular syndromes, and there's a new classification to them. So we, in conjunction with endocrinology, because they tend to present to endocrinology for short stature more so. So we tend to get them lesser as a primary consult to nephrology, but we see a lot of patients between the two departments, between our two departments.
Yeah, it's one question. Congratulations for the amazing study. I just have one question about VUS. Is there any consistency? Did you find any consistency in the VUS, whether there were certain mutations that were common in the VUS?
No, sir. We had VUS, all the four genes, we had VUS. We had only one case of OXY1, but we had VUS distributed across all the genotypes. Yeah.
And that was done by whole exome, or MLPA was done?
No, whole exome, sir. This was a point mutation, so we didn't require to do a MLPA. Yeah.
Because I have VUS cases, and the lab has told me to get the MLPA done.
So for this disease, MLPA is maybe useful for ATP6 genotypes, but not the other ones. Yeah.
Thank you so much, Saili. I think that was wonderful.
Thank you.
Great work.
सर, मे जून मध्ये नेहमी क्रिएटिनिन वाढतं. कोल्हापूरला खूप गरमी असते ना. This statement made by a renal allograft recipient labeled loose and nonsense for a few years ultimately made us wonder, is there actually any truth to it? For this next session, I welcome chairpersons Dr. Partha Shetty, Ritesh Varnekar, Dr. Narendra Dhedia, and Arun Halankar, sir. And to present the impact of heat exposure on kidney allograft function, I welcome Dr. Ashwini Joga.
Okay, good morning. Today I'll be discussing a case, 44-year-old male who had undergone live-related kidney transplant with mother as a donor, no antibody induction, and after a transplant, his creatinine had come to a baseline of 1.4 to 1.5. This was in August 2016. 6 months post-transplant, this patient had presented with acute gastroenteritis, acute graft dysfunction with elevated TAC levels, for which he was treated. Tacrolimus doses were adjusted, and on follow-up, we found that his creatinine had only reached to a baseline of 1.7. And on further follow-up, his creatinine persisted to be at that same level with normal TAC levels and no other symptoms. At this point, we did a kidney biopsy, which was suggestive of mild acute tubular injury. On follow-up, this patient had presented in May 2018, that is 1.5 years post-transplant, with acute gastroenteritis, and at 6 years and 6.5 years post-transplant, he had again presented with acute gastroenteritis, which was effectively treated, and which with each episode his creatinine had reached to a baseline of 1.8 to 2 milligrams per deciliter. In May 2024, this patient had presented with complaints of malaise, easy fatigability, myalgia, oliguria. On evaluation, he was otherwise vitally stable but had relative hypotension. His usual blood pressure readings were around 130 to 145 systolic, which had dropped to 110. And there was no edema with a weight loss which was approximately 1 kg. His biochemical parameters were suggestive of a spike in his creatinine to 5.1. So electrolytes were normal. There was hyperuricemia, 15.1 milligrams per deciliter. Urine examination was showing mild albuminuria. Tacrolimus trough levels were within normal range. His USG graft kidney was also normal. On careful history, we found that he had exposure to increased temperatures while working for the last 4 to 5 days before presentation. And his temperature recorded at that place was 36 to 37 degrees Celsius, whereas the heat index, which is the temperature felt by the patient in those locations, was 39 to 40 degrees Celsius. This patient was only purely treated with IV infusion, IV fluids, and on IV fluid therapy, his symptoms had improved. There was gain in his weight, there was improvement in his blood pressure, his serum creatinine had reduced to 2.2 milligrams per deciliter, and uric acid has come down to 7.8. So we made a diagnosis that this acute graft dysfunction was mainly related to heat stress. We know that heat stress is very commonly associated with acute kidney injury and is also seen in literature. But this patient of kidney transplant was affected by it. The heat-related illnesses are increasing with the climate change and increasing temperatures, and AKI has been observed in 30 to 40% of the patients admitted for these illnesses. And the heat stress could be as mild as heat cramps to heat exhaustion to as severe as heat stroke. So heat stress usually causes dehydration by salt and water loss, which causes renal hypoperfusion, with further contributing mechanisms of renin-angiotensin-aldosterone activation, rhabdomyolysis, systemic inflammatory response, and direct thermal injury. All of these culminate and cause renal tubular damage, which further causes acute kidney injury. And we know that repeated episodes of acute kidney injury can cause chronic kidney disease. Who are the population at risk? We very well know that CKD patients, cardiovascular disease patients, elderly, children are at risk for this heat stress related acute kidney injury, but we also now know that kidney transplant recipients are also at risk for this disease. In our center, we have seen around 10 patients from May 2018 till June 2025 who have in total experienced 12 episodes of heat AKI. There were 12 episodes total of heat AKI. The median age in these patients was 31.5 years, with ranging from 15 to 44 years. The median peak temperature at the location of exposure was 39.5 degrees, ranging from 36 to 43. The patients were predominantly males with only 2 female patients. And we found that the nature of exposure was working in tin shade shops, working in farms, traveling in non-AC locals and buses and trains, and also walking and exposure to the sun. The symptoms and signs in these patients varied from fever, lethargia, relative hypotension, weight loss, and oliguria. We found that majority of them had experienced milder acute kidney injury, which is stage 1, and very few patients had experienced stage 3 AKI, which was only 2. The median weight loss seen in our patients was 1.6 kgs, but it was as high as 14 kgs as well. The mean MAP reduction was 6 millimeters of mercury from the baseline. Relative hypotension was observed in 7 episodes, and hyperuricemia was observed in 8 episodes. And the peak serum uric acid we could find was 26 milligrams per deciliter. Out of the 12 episodes, 5 episodes were treated with hospitalization, whereas 7 episodes were treated on outpatient basis. Only one case we had to do a graft biopsy in view of slow resolution of AKI, and features were consistent with acute tubular injury in this biopsy. Out of the 12 episodes, 10 had complete recovery, whereas 2 episodes had incomplete recovery, wherein the creatinine remained above 1.3 above the baseline. And we could not see other major complications, like there was no CNS involvement, there was no liver injury, no rhabdomyolysis. Kidney transplant recipients are vulnerable, but why? There, because of lack of autoregulation, immunosuppressive medications like CNI, tacrolimus, antihypertensives like diuretics, ACE inhibitors, ARVs, usually are involved in the lack of autoregulation and hemodynamics, and also reduced kidney function is one cause. So very few cases have been reported in literature supporting that kidney transplant recipients have an effect of heat on the graft function. So there is this data which has abstract which has been published in the NKF Spring Clinical Meeting 2025, wherein they have seen patients who have undergone transplant in hot environments, hot kidney transplant centers and cold kidney transplant centers, and they have found that the decrease in eGFR is more, and there are more increased major adverse kidney events in transplant recipients in the hot kidney transplant centers. So we need to mitigate this by some preventive measures to minimize the effect of heat on the patients and the kidney transplant recipients. Use of sun protective clothing, limitation of outdoor activities, monitoring of weight and blood pressure, and access to ample clean water. That's it. Thank you.
It's very common scenario. Post-transplant, we discharge the patient after few days to few weeks. Unexplained 1.2 creatinine is high in spite of normal TAC levels. In biopsy, as you showed, mild ATM. So after discharge, they are not accessible for any IV fluids. So do we have to go for a lesser TAC level in such situation? Because the biopsy is not typical of CNI-induced nephrotoxicity.
So, sir, in majority of the patients which we have seen, the TAC levels at that episode were within the normal range. So, sir, that we have usually not changed the tacrolimus doses in such cases.
Because very common. After discharge, for some reasons, 0.1, 0.2 will be rise, and ideally it remains the same. It doesn't go on increasing, but maybe it's increased muscle mass or some sort of dehydration.
I think it's little gray. Dehydration, systemic dehydration. So even if you have somebody who's losing 1 kilogram of weight because of dehydration, you will expect them to, have an AKI, and it's a gray area whether it's pertinent to the graft alone, having an exposure or systemic. It's hard to say that because the graft simply that I was wondering whether it was, an intraarticular graft cooling and heating versus systemic. Then I can say I have to go and check literature to find what's happening. So this is an interesting case.
Would it all be Thank you. Would it all be labeled under pre-renal element?
Yes, sir. Almost all patients, we have had patients who had responded to IV fluid. So probably it is pre-renal secondary to dehydration.
The idea of compiling these cases was that when we looked at the literature in kidney transplant recipient, whether there is any adverse impact of heat, we could not come across any literature in kidney transplants population specifically, except for the Spring Clinical Meeting abstract, where they compared the major adverse kidney event in centers located in hot environments versus those in the colder environments. Implication probably is that we are likely to have increased exposure to heat in coming times, and the relationship between such episodes and chronic kidney disease of uncertain etiology. So Mesoamerican nephropathy, one of the major contender they are considering is heat. And there, typically these episodes occur the damage, although they appear to have recovered, probably they may not have completely resolved histologically, or there may be some sublethal damage at the structural level persisting. And that probably is the mechanism of CKD of uncertain etiology in those sugarcane workers. So whether this would have a similar bearing in allograft, because our patients typically come from far and wide, and many of them engage into farming and activities in some. This one fellow though owns a tin shed shop just beside the roadside. and he felt acutely sick, and he had lost some 5-6 kg weight, and uric acid went high, and AKI. That fellow had a very poor baseline kidney function also, and his AKI was the severest of all AKI. But we understand that probably we need to appreciate this problem more and mitigate it by using various preventive measures. One thing that we realize that many of our patients are hesitant to drink water when they are outdoor because it probably may not be clean. Transplant recipient, they are exerting outdoor, and then for hours they did not drink the water because probably they will catch some infection. So they can be instructed. I think that is the implication, and that's why we put this together to convey. Yes, sir.
Do you do fractional excretion of sodium or any urinary biomarkers like NGAL or KEM or IgBP?
No, we didn't do. We would have had additional.
Thank you.
Number of hours of exposure also is important rather than only the heat, because people who are working for a longer time, they would definitely land up in renal failure because of dehydration. So calling it as a heat-related AKI is something not very correct, I feel.
So this was based upon no other etiology forthcoming, and other features like hyperuricemia and weight loss and relative hypotension. So that made us that heat is probably the major contender. Now this doesn't fit into any major serious heat illness. They don't have muscle injury. They don't have CNS involvement. So this was a lot of matter of discussion and debate with the reviewers. But then this doesn't fit into the classic heat stroke. These patients are young. They are not as morbid as usual diabetic, elderly people who have been described in the heat-related illnesses. So young patients with preserved baseline physiological reserve, only by the virtue of being a transplant recipient, are at an elevated risk. That was what the point we tried to make.
Because I am from Gulbarga, Raichur and all, where it is 43, 44.
Yes.
We do see a lot of patients in this
One of the mechanisms which has been noted for CKD, heat stress nephropathy. So maybe in the long run, these patients are again going to develop CKD. So that's what is the mechanism, one of the mechanisms postulated for CKD.
Yes. Thanks.
This is the last session before we break for lunch, but I'm sure you will all agree when I say that we have saved the best for the last. I welcome chairpersons Dr. Nitish Kolhe, Dr. Sandeep Chauhan, Dr. Satrupa Deb, and Dr. Dinesh Mahajan. Kidney disease in pregnancy presents one of the most diagnostically, prognostically, and therapeutically demanding scenarios in nephrology, requiring careful balancing act of maternal health and fetal well-being. And who better to guide us on this issue than someone who has emerged as a global authority in this field. I welcome Dr. Divya Bajpai to talk about the challenges in management of pregnant patients with CKD.
So thanks, Tapsi. While it's very unusual of a KEM nephrology phenotype, I will now, for this session at least, stick to very run-of-the-mill routine cases, nothing aha, nothing zebras, which we have been seeing since the day. So now I would like everyone to feel like you have come back to school. The way Khanna sir was telling me, he was figuring out where he would sit when he was during his MBBS days. You all have some little roll numbers written in front of you on your chairs also. So that's to give you a feel of back to school. And we'll have hand-raising questions. Everyone is free to answer in chorus. Some very simple, very basic things, challenges which we have faced, and then finally what we have done at KEM since last few years. So simple representative cases which you have been seeing in your day-to-day practice always. So this lady is a 31-year-old patient with chronic kidney disease of uncertain etiology with a dialysis vintage of 2 years. She's doing pretty well. Actually, her blood pressure is okay. Her hemoglobin is fine. She just presents with amenorrhea, only amenorrhea, nothing else, and everything looks okay. So now, how likely is this presentation to be actually consistent with the picture there? So amenorrhea of 10 weeks, 11 weeks in a lady on with a 2 years dialysis vintage.
Was she getting periods when she was on dialysis?
Very good question, madam. She was on regular periods and now she is amenorrheic since 11 weeks. Not very regular, she had irregular menses to begin with, but now it was irregular and now she is amenorrheic. So data helps us here, and it tells us that up to 30 to 35% of diagnosis of pregnancies in patients with kidney disease is actually false. So there are false alarms up to 30 to 35%. So there is actually where our challenge begins. The first and the foremost challenge is just to diagnose. Is it pregnancy, or is it ascites, or is it just inadequate dialysis? Everything can present as amenorrhea. So diagnosing pregnancy in this condition is challenging because we have lots of overlapping symptoms. These women are getting irregular menses all the time. There are overlapping symptoms of abdominal distension, bloating, nausea, vomiting, which can happen to anyone, men or women with on dialysis. There are the beta HCG tests are highly unreliable in this particular population. There are imaging difficulties, and dialysis can have confounders. This leads to a very significant delay in diagnosis of pregnancy in these women as late as 4th to 5th month of gestation. So that was one problem, but now we have seen so the gold standard is to do a transvaginal ultrasound and see a gestational sac there and then confirm pregnancy by that way. Now that one challenge is over. Now what is the next challenge, which is the very important decision to be taken by you as a nephrologist, whether you want to continue or not. So just to add an interesting parameter here, that this lady was actually being worked up for a living donor transplant with father as donor, but then it got delayed because father and mother had some marital dispute, and it got delayed for some reason. So we have a young lady who's doing otherwise okay on dialysis, 2-year dialysis vintage, is looking forward to get transplanted, and now is getting pregnant with 11 weeks of gestation. How many of you would like to not continue this and would proceed with transplant and then would like to then give her a fair chance to conceive? Primi gravida. Yeah. Show of hands. We are only at 11 weeks, sir. We need to make the decision now. Show of hands. Continue or... Great. No, discontinue. It's actually 50-50, which makes me very happy as the presenter here. That's so important. Yes, please, yes. So this is a very nice study, 2023 paper done by a friend, Andrea Olivero from Michigan. She actually studied 12 nephrologists and their practice patterns, and she found out that it was a qualitative study with patient interviews, with patient caregivers, the nursing staff, and nephrologists. And they found out that the major barrier in the patient-centric counseling, preconceptional or periconceptional, is a nephrologist's inherent bias and lack of training. So to do pregnancy or preconceptional counseling, there's a formal training which happens for 7 to 8 sessions in the University of Michigan, and then they are able to do the counseling. So this was a gap in practice which they found out in this particular study using qualitative methods. So something to think about. So, but here, as sir rightly said, that patient wanted to continue, we agreed to that, and now the challenge was, how do you give adequate dialysis in this condition? So this patient was currently on 10.5 hours of dialysis per week. Lots of seniors here are from the city of Mumbai and would agree that we really need to stretch a little bit too much when we need to give 20-30 hours of dialysis to these patients. Literature tells us unanimously that increased hours gives rise to increased better maternal fetal outcome. The chances of you holding a baby and the baby not sitting in an NICU is much, much more if you're giving good hours of dialysis. So much so that almost all patients with pregnancy in Canada, Australia are now dialyzed up to more than 30 to 36 hours, some even advocating around 40 hours a week of dialysis. So I had one patient who could not continue only because no center in Mumbai was ready to extend their dialysis time, and she also had financial constraints also. So now this brings us to a problem. So how many of you would be comfortable in accommodating few patients, more than one, in your center who required 36 to 40 hours of dialysis in a week? Show of hands. Wow, thank you. This particular patient was not getting a center with increased hours. So we had this question in our mind. The actual thing which we are trying to achieve by increasing the hours on dialysis is a reduction in BUN, because BUN, urea, is phytotoxic. So what if we achieve this target by some relatively lesser hours on dialysis? Majority of our patients are vegetarian, they have lower body mass, they have less urea generation. Whether it is okay if lesser hours of dialysis give rise to less BUN, but whether it is also possible that the BUN is not rising because they are uremic. So is BUN an accurate measure of uremia in these patients, or are we okay with the lower BUN with lesser number of dialysis? This was answered by this very nice study from Brazil, where they have seen shorter hours of dialysis, around 15, and the live birth rate and the maternal-fetal outcome was really good, even in patients who were on 15 hours but a lower BUN. So we were safe here. What we did was, we initially, when the patient was admitted in KEM, we could actually give her around 20 to 24 hours a week. Then subsequently she went to another center, and we could manage by around 17 hours a week. We maintained blood urea nitrogen, and a very, very important point here is that whether you're giving adequate dialysis or not is decided by very, very close monitoring of AFI and fetal growth. Now, what about chronic hypertension? She was on amlodipine, like we discussed, to begin with. So we switched it to Labet at 11 weeks. Aspirin was started around 15 weeks. We should always start it after the first transvaginal scan because of the bleeding tendency which can occur before that. And we targeted blood pressure like it is mentioned here. So everything was rosy. Everything was going as per plan till around 24 to 28 weeks, when her blood pressure requirement, antihypertensive requirement started increasing. Blood pressure started worsening, weight was increasing, albumin was okay, and BUN was okay. Whether this weight gain is okay for pregnancy. So it's important to understand that a normal pregnancy, we tend to get around 10 to 13 kg of weight. This is extremely important to take care in our patients who are on dialysis, and we have to readjust the dry weight every weekly according to this chart which we have. So when a pregnant patient comes to us, we make a chart of every week ka expected weight, and that is their dry weight, and not the actual dry weight which he has been assigned to. Similar goes to albumin. Albumin, it tends to remain low during pregnancy, and with each progressing trimester, serum albumin needs to be readjusted. So our patient was doing actually okay, apart from the blood pressure rising and a little bit increase in antihypertensive requirement. The weight was fine. We did whatever we could to maintain a stable hemodialysis prescription, which was able to give her a hemodynamic stability. We did everything we could to manage the anemia. These patients required double or triple the doses of erythropoietin. They required definite double doses of B complex vitamins. They do not require any phosphate binders of any sort. They require phosphate and magnesium supplements. And they definitely require 150 milligram of aspirin. Now the aspirin, there is lots of data comparing less than 100 milligram to more than 100 milligram. However, it is important to understand that the data is not in dialysis. So we need to individualize what is the patient's bleeding risk and accordingly decide the dose of aspirin in these patients. Another challenge for this patient was the fetal monitoring. it is very important to understand that the fetal monitoring biophysical profile and the AFI varies according to dialysis duration. So if you do a long session of dialysis and then do the ultrasound, vis-a-vis you do it before the dialysis session, the parameters might vary. So it is recommended that all these scans should always be done at similar time point, preferably always post-dialysis. So now there was some trouble in the Paradise at around 31 to 33 weeks. She came to us with increasing AFIs. This is the most common problem which our patients with chronic kidney disease experience. Increase in AFI was also accompanied by increase in weight, and now the weight was beyond the weight which they would gain in a normal pregnancy, with worsening of blood pressure and worsening of edema. So now what do we do? Do we terminate or do we go ahead? Show of hands, terminate. She's already at 32 weeks.
Neonatal care is very good nowadays. Rather than risking the mother.
Yes, ma'am, thank you for being here. This is again just to tell you that every week a fetus spends in the mother's uterus leads to 100 to 150 grams of additional weight gain. So we are looking at 100 to 150 grams of weight, which translates to survival and lifelong risk of low birth weight babies. So polyhydramnios is again a very, very important concept here. What happens is that the urea from mother transfers to the through placenta to the baby. It causes fetal diuresis, increased fetal urine, and they become and it is also incremented by some volume overload, which is usually present in these patients. What we should definitely do is to readjust the dry weight. We should not restrict fluids, and we should not label it as idiopathic. Every polyuria in these patients should be looked as either we are underdialyzing or not adjusting their dry weight adequately. So what we did here was that we then increased the dialysis duration to daily dialysis. We came to around 36 hours a week for the 32nd and 33rd week, and with increased ultrafiltration. There was slight up-titration in antihypertensive. We kept a very close watch of HELP DIC, because these parameters can also mean that the patient is developing a superimposed preeclampsia. With increased dialysis and ultrafiltration, the AFI and BP both stabilized. The routine housekeeping things were done to ensure the baby was now ready to come out. And patient underwent an elective cesarean section at 33 weeks of gestation. And these are the outcome. The bundle of joy is now in an ICU in very capable hands. And as madam said, this is 2.05 kg. Nowadays we have NICUs which can handle 700, 800 gram babies also. So just to give some perspective here, there's a paper published last week from Michelle Landowich from Canada, and who compare outcomes in pregnancy in women on dialysis versus those on transplant. Retrospective study, 46 women on dialysis, 60 on transplant. All parameters were absolutely same. Hypertensive disorders in pregnancy, live birth weight, growth of the baby post-delivery, SGA, everything was same. So if you do good quality dialysis, your outcomes are as good as what they would be during in a post-transplant period. So now the woman is started breastfeeding. The ultrafiltration is now decreased. She's on thrice a week dialysis. She definitely requires contraception, and she still needs 3 antihypertensive. We are waiting for them to come down. Quickly moving to the second case, which was a GLOM disease. This lady was 29 years, nephrotic syndrome, biopsy was membranous, ANA negative, plateau R negative, was treated outside with steroid and tacrolimus. She went into partial remission, proteinuria was around 1 gram, creat was 1.5, hypertension was well controlled on telmisartan. She came to us actually for this. We did a thorough preconceptional counseling. Almost waited for a period of 2 years on partial remission, and then she was switched to telmisartan from amlodipine, and tech and predni was stopped as the creatine proteinuria were quite stable. We were happy, patient was happy, she conceived. First trimester was a bliss. Everything went as planned, labate, aspirin, the way we always do. No change in proteinuria, no change in creatinine, no hypertension change. So then again, The trouble comes here when she was around 26 weeks. There was a slow progressive increase in creatinine. There was a definite increase in urine protein by creatinine ratio, worsening hypertension and edema. Now we have a 28-year weaker GN patient who had responded to TAC, now is not on TAC. What would you do? A, deliver her now. B, start TAC predni. C, just careful watch. How many for A? Deliver her stat. Yes, sir. Start TAC and predni because she has responded to. Yes, sir. Delivery, start. Book the OT. Call the obs gynac. Anyone to deliver now? No? Creat is increasing. Yes. Yes, ma'am. TAC and predni are absolutely safe in pregnancy. The only problem with tacrolimus is that we measure the whole blood TAC levels, which are invariably low in pregnancy, pseudo low. So the levels cannot be very easily used to monitor in pregnancy. The actual drug which is acting will not be reflected in the levels. That's the only problem with TAC in pregnancy. Otherwise, it's okay. In a patient with worsening creatinine, again, that might be a problem. So we have a patient with worsening hypertension, creatinine, proteinuria, whether it is so the decision here is based on this problem. Whether we are dealing with a superimposed preeclampsia, in that condition it's better to deliver, or whether we are dealing with worsening kidney disease, in that condition I would actually let her worsen, put her on dialysis, let the baby grow, and then deliver when at least it reaches 30 to 34 weeks. This not only has a implication with delivery timing, but it also definitely has implications for treatment of CKD. I will not give TAC predni to someone with preeclampsia, but I will give TAC predni to someone who does not have preeclampsia, and also for long-term management, like we'll see. So preeclampsia, as we all know, is a maternal syndrome which is progressive and multisystemic. It involves every single organ of the body which has blood vessels. Any organ which is not involved in preeclampsia, can anyone name? So bones, if you get a seizure and you fracture, then bones will be involved, otherwise they are not. And cornea, because it is avascular, but then corneal edema is again seen. Apart from bones and cornea, everything is very, very badly involved in preeclampsia. So, to distinguish between superimposed preeclampsia and worsening of kidney disease, we looked at these parameters. If there are any classical symptoms of preeclampsia, with investigation supporting hemolysis thrombocytopenia, with high uric acid level, with Doppler findings like high RI, high PI, with proper diastolic notching and fetal growth restriction asymmetrical, then we are dealing with superimposed preeclampsia. The Doppler findings don't help in a CKD because Doppler findings of preeclampsia can mimic in a hypertensive CKD. So Doppler based, you cannot differentiate preeclampsia from CKD. Of course, time is the best judge in these patients. So apart from the first 3 rows, everything else was almost okay. She was requiring EPO, which we were sure she'll require. She was not developing any hemolysis, no thrombocytopenia, no premonitory symptoms. Uric acid was raised, but it was stable, okay. Now what do? Do we deliver or do we wait? So we needed here someone to rescue us in this very difficult situation because patient was losing kidney function. Creatinine was daily rising, her proteinuria was worsening. She was on the verge of getting to dialysis. She was already on maximum doses of diuretics. So we use these angiogenic markers, which we know are a measure of preeclampsia. They mimic the vascular state, which is a increase in vasoconstrictors and reduction in vasodilators, which is the absolutely basic, simple pathophysiology of preeclampsia. These biomarkers are very important because they precede the onset of clinical preeclampsia by several weeks or months, at least 4 weeks. So if the marker is raised, you can be sure that after 4 weeks, by almost 90, if it is raised, if it is not raised, there is a 90% negative predictive value that your patient will not develop preeclampsia. It correlates with disease activity, the levels correlate, and they normalize within 3 to 4 days of delivery. So if your patient is having low platelet after 4 days, the marker is normal, it's not HELP and preeclampsia, it might be TMA. It answers these questions. Is it PE or any other HDP? Does the patient requires hospitalization? And what is the risk of patient progressing to severe preeclampsia, which means complications with the end organ damage? In short, if you have normal markers, you can be reassured that you have a prolonged period to stay and you can actually sleep well at night. The only thing which a nephrologist really craves for is a peaceful night's sleep. And they really are, this is the key for your peaceful night's sleep if you're a pregnant patient with hypertension, with suspected preeclampsia. So these are the ACOG and Society of Maternal Fetal Medicine recommendations. As per the cutoff, you can make a very strong decision. These are also mimicked by similar recommendations from NICE, and we can make clinical decisions based on these markers. We found them to be very high in our patient. The cutoff is same for Indian patients, and we did what we should be doing, but creat was rising and it was not helping. This was not only progression of kidney disease, it was superimposed preeclampsia, and the treatment here is delivery. So it was induced at 28 weeks. Patient delivered vaginally, small bachu, comes out easily, 860 grams, as madam said. This is a doable job for the neonatologist now. We really need to see this child for long-term impact. The parents need to be counseled. Proteinuria decreased in the mother to 1.2 grams, definitely higher than her pre-pregnancy level. Creatinine is still higher at 6 months of post-pregnancy period. It is a tightrope walk, whether to save maternal interest or to save fetal interest and buy time for something. This makes this tightrope walk little less glamorous, but much more safer. It's like a balancing rod. When you really need to take that walk, take it with a balancing rod and not blindly. Last case, very short case. So I need a show of hands. How many of you would think that this pregnancy will result in good maternal fetal outcome? Elderly elderly lady, hypertension since 3 years on 4 drugs. Tazloc, Trio plus Metexel, that's 4. CVA, CKD query cause bilateral small shrunken kidneys. Creatinine 2, proteinuria 1 gram with a BMI of 36.5, obese by any definition. Deliver, not deliver. Anyone who would be comfortable in letting this pregnancy progress? But patients don't listen to us. As such said, we should think of what patient feels and not what is our inherent judgment. So this patient has undergone 2 MTPs for medical indication. Doctors have told them that do not get pregnant. Still they got pregnant. Doctors told them that now terminate. But now again she was pregnant, and in her own words, she told me she feels that her kidney disease is progressing because she terminated 2 pregnancies. It's God's way of punishing her because she took life of a unborn fetus. But God is punishing her with a progressive kidney disease. So she was really not willing to wait. Actually, for this patient, we took turns. I counseled, Sir counseled, Saili counseled. We made sure that everyone in the department counseled to not let her continue, but she still continued. So she was switched to Labet and Nifedipine. We decreased torsemide. We could not stop it because she was edematous from day 0. Stopped dapagliflozin, clopidogrel and aspirin could not be stopped. Clopidogrel we took neurologist opinion also. We started her on erythropoietin, did APLA workup. The OBS gynac did not want to start her on LMWH, though some guidelines recommended here. There was some diastolic dysfunction. She also had borderline high OGTT. So this was how she fared. Creatinine did increase. She did require more antihypertensive. Proteinuria did increase. Hemoglobin was stable. Till 20 weeks of gestation, we were giving her this option of termination. Till 24 actually, she understood that her kidneys are dying, and she understood that this is her last attempt to have a child, and she was ready to let the kidneys die in that bargain. She was prepared for that. We made sure that she understood all the implications of the same. There was mild increase in OTPT, but no hemolysis, no decrease in platelet count, no DIC. We thought of doing biomarkers here also, but she would not let us even deliver prematurely. She was very headstrong on that. There were no premonitory symptoms. There was polyhydramnios, even on decreasing diuretics. And she went home 2 weeks back with a healthy baby who did not require any ICU stay. Birth weight was 2.5. The only problem she had was lactation failure because she was on 2 diuretics, torsemide and metolazone. So that will definitely affect lactation. And baby is healthy, gaining weight. This was expected. She was prepared. It was her shared conscious decision making that she was ready for this. We had to increase diuretics peri-delivery period to maintain her ejection fraction also little bit was 50-ish, and to maintain her out of failure, she required extensive diuresis. She was in a significant negative balance during delivery. She developed one fever spike also post-delivery. So there is some component of acute kidney injury here in this creatinine rise, which we see. It's only 2 weeks postpartum. So it's too early to understand where she will land up. But she accepts this. She was happy. You can see that with the smile she has, that she accepts this creatinine. She knows the creatinine while we were clicking the picture. So those were 3 quick cases representative of the problems with C, the challenges with C. This was a part of VNA-GNR because a significant amount of patients here were GN. This is an ambispective study starting from 2018 to till date. Around 48 patients were retrospective, rest all were prospective. We have 267 pregnancies in 218 patients. Majority of our patients were having chronic kidney disease of different etiologies. There were cystic kidney diseases, there was Kakut, there was reflux of various etiologies. A second big cohort was of lupus, and there were other GNs. We had 4 IgA, 2 MN, 2 undifferentiated RPGN, and 1 MPGN. Diabetic kidney disease, the most dreaded patient to get pregnant, was thankfully less in our cohort. It was unfortunate to know that CKD was first detected in pregnancy in approximately 25% of these individuals. 3 of those were end-stage kidney disease detected in pregnancy. We had to dialyze them from the day 0. CKD stage 3B is a significant number. Also, as CKD stage GFR less than 60 was seen in around 48% of our patients. The maternal outcomes are comparable to cohorts which have studied CKD, advanced CKD in pregnancy, as majority of our patients were having advanced CKD. There is a significant mortality reported here. There is some reporting bias because we got lots of referrals from everywhere in the country with really sick patients coming in, resulting in a higher mortality than reported in the literature. Approximately, there are 6 patients who progressed to end stage. 3 of them came with dialysis requiring renal failure. 3 of them were in around GFR 30 to 40, and they progressed to end stage around over a period of median follow-up of around 4 years. So one important thing which I wanted to point out is that the stage shift happening in these patients post-pregnancy. If we start from CKD stage 3B onwards, around 22% patients had a stage shift after pregnancy in a median follow-up of 4.5 years. And the patients who are stage 3B and less than stage 3B did not have a progression or significant stage shift. Fetal outcomes are relatively better in pregnancies who are viable, that is beyond 20 weeks. 87.5% of them ended up with live birth. And CKD stage 3B and preconceptional counseling independently predicts these fetal outcome. So as we have been seeing the legacy created by the department, it's not, we are seeing it here, but actually it's all there. Echoing with what every presenter and what sir has been is saying since morning, we should continue this legacy, and I really, from the bottom of my heart, hope that our institute, our department, under the able leadership of sir, is able to establish a very efficient high-risk maternal fetal counseling clinic, a high-risk obstetric clinic, where these women have a safe haven, they don't feel vulnerable, right from these stages of preconceptional counseling to postpartum period. So that is the need of the hour. I genuinely hope that this institute is able to do that, because this is the only institute where it is actually possible. My colleagues and my friends sitting there have helped me a lot in doing this rigorous data collection of these pregnant women. And I'm sure with this kind of support, we will be able to establish a very good high-risk obstetric clinic, which is there in every good program across the world. It's only not there in our country, and it's high time that we should start it. So what I learned from this was that pregnancy in CKD is associated with high risk of live birth rate, especially when coupled with a good preconception counseling. CKD stage at conception strongly predicts fetal outcome and maternal disease progression. And when we are forced to see hypertensive disorders in pregnancy, biomarkers can be a very useful tool. Thank you so much for your patient listening.
Why the third patient was on DAPA?
So patient was proteinuric, so it was started, and unknown etiology. So there is a building consensus that proteinuric CKD, which might progress, they might have, it's like a DAPA, IgA and other FSGS, there is evidence that DAPA might help in a proteinuric kidney disease, non-diabetic etiology also.
Proteinuria increased.
That is during pregnancy we stopped DAPA, sir. Also, there was some grade 2 diastolic dysfunction, so for cardiovascular benefit also it's better. Yes, so for that also. She did not have heart failure per se to start DAPA, but it would have helped.
Can anybody asking question put your hands up first so that we can give the mic to them? That corner.
If anybody wants to get pregnant and continue pregnancy, we'll send it to you.
Thank you so much, sir. I'll be waiting, sir.
But being a husband of a gynecologist, I think I congratulate you as well as your gynac team. And the gynac team must have the patience to go through all this. But I would warn all the gatherings which are elite gatherings here, but anything to do with pregnancy and any other disease, the morbidity, mortality is extremely high. And in our country, the laws are against doctors, and therefore we have to be very careful about asking somebody to get pregnant or continue pregnancy, because they must be aware of all these complications that come. Because at that particular time, around 10 weeks, 12 weeks, they are emotionally charged that they are pregnant. And if something goes wrong, it is from patient also you are going to be fired, but from the government, the local authorities, the maternal mortality, fetal mortality, everything is scrutinized so badly in this country that if you have, and even the postpartum deaths or even morbidity are scrutinized so badly by the local authorities that you need to be prepared to face that, and that is where your documentation is going to come into picture.
Absolutely.
So I'm not totally pessimistic, but after having seen some, fortunately I have not faced it, but I have seen others, people facing it. So I would really guard somebody asking a patient, especially with advanced renal insufficiency, to continue pregnancy.
Thank you. Dr.
Absolutely. Sir,
pregnancy has become a legally a very bad issue in this country, especially in Mumbai and Maharashtra, where everybody wants to go to court and get their decision. So, and the court is not going to look at your thing, they are going to go in favor of patients all the time.
So this is for a very, very important reason why we should be
Dr.
having a
Suratkar.
multidisciplinary OBS clinic, because there was a similar a court case kind of a situation in Europe when actually the decision of a multidisciplinary high-risk obstetric clinic helped the practitioner. So that actually adds on to our point that it's high time we set up such a clinic in the city of Mumbai.
And the costs involved
Dr. Suratkar.
and the further management.
I think to answer him, the key word is fait accompli. We try to discourage the patient as much as possible, but they go ahead, and then the outcomes are good.
So with the improving OBS, improving biomarkers, the discouragement can safely go down, sir.
Actually, in your last case,
Yes,
if
sir.
it was UK, the lady would have sued the obstetrician for giving wrong advice for the 2 MTPs.
I completely agree with you, sir.
Nitin, you said that what did the patient want? So over here what happens many times is the patient asks the doctor, so that is the main issue. So the whole responsibility is yours. And then as Dr. Divya said, it is really a need to have a clinic which will multidisciplinary thing. And you need to be cautious, as Gunzotikar says.
No, I completely agree, but I think in UK you take an MDT approach and document it as you
Yeah.
very rightly said, so that the blame doesn't fall on one person.
Yes. Also, medico-legally, the angiogenic biomarkers can save you. By 24 weeks, till now, we can do MTP, and 24 weeks is the time when it's recommended to use biomarkers. So I feel that we should be using them more often. It's like the plateau hour of membranous, or of kidney disease, pregnancy in kidney disease.
CKD and dialysis patient, pregnancy is very rare. And previously, if the patient becomes pregnant, and if he goes to obstetrician always advise the termination of the pregnancy. But after 2000, whichever patient had come to me with pregnancy, I had decided to continue their pregnancy and explaining them what is the risk. The majority of the patient, after 24th week, they were monitored every weekly by this radiologist with ultrasound and Doppler studies, and usually outcome was a good outcome. Only 2 patients had went into end-stage kidney disease, but they were ready for dialysis, worsening of the kidney function. So I think because of the development of the neonatal care and development in obstetric and pediatric care, we should not discourage the pregnancies in these ladies if they are explained properly and they are ready to follow up till the end, and if you take care, and their successful pregnancies are possible.
Yes, sir. Weekly. The trend is actually more important. So, in a suspected case of preeclampsia, we should start screening them from 24th weeks onward, and we should be doing it weekly. If it comes negative, we can stop doing that, and then again do it only if need arises. But if it is positive, we should be doing it weekly. Actually, in the first case, the dialysis one, it's more important we can start early, because dialysis are more likely to have preeclampsia, and there is some issue with renal excretion of these biomarkers, but the ratio still remains valid. So, madam, Lalpad does it for 1400 rupees. Metropolis, Lalpad does it for 2400 rupees. Metropolis does it for 5400 rupees. Turnaround time, if we send on Tuesday, Thursday, Saturday, it's on the same day. And on the other thing is the other day, like the coming day. Agilus is starting to do it, and they have promised us a cost of somewhere around 3,000. Yes, sir. So urea is fetotoxic. It's toxic for the fetal brain. It can give rise to polyhydramnios and it will hamper fetal growth. So the only cutoff is of urea, not of any other kidney toxin. We should keep the cutoff less than 35 and some people say less than 50. But we need to, once the urea goes beyond 35, the patient should be on dialysis.
Thank you, Diva, for excellent presentation and interesting discussions. Thank you. We can close the sessions.
I would now like to request for everyone to proceed for lunch. We will reconvene at 2 p.m. Thank you. We welcome you all after lunch. The true prestige of any institution and the department is reflected in the caliber, character, and commitment of its alumni. And each alumnus here is a chapter in our department's continuing story of excellence. This is our chance to see this excellence in action, to hear stalwarts talk about spheres of nephrology where they have become a household name. So I invite our panelists, Dr. Rajesh Kumar, Dr. Rajendra Gunjotikar, Dr. Dhananjay Okhalkar, Dr. Devdutt Shafikar, and our moderator, our beloved Dr. Umesh Khanna, to talk about dialysis in practice, balancing art, science, and commerce.
Thank you, friends. As she mentioned, the success of any institution, the success of any conference or meeting also depends on how many people attend the first post-lunch program. And I think we haven't done too badly. Somebody can the slides. Slides. So some disclosures. Yeah. I used to know the art, commerce, and science. Either hai beta. Art, science and commerce. इसमें already लिया है इसमें. Desktop. Art, science and commerce of dialysis. But then I shifted to knowing more of the art, science and commerce of doing general practice in nephrology, and maybe the next talk I would like to give on that. Hey, किधर है?
Modern.
Yes. Oh. Okay. Fortunately, Tukaram gave me a panel, and the panel consists of people who are very well versed with art, science, and commerce of dialysis. So we'll take their help. 30 minutes, 25 for us, 5 minutes for the question and answers. I was trying to find out there are 10 vexatious issues you face in your dialysis practice, which I thought there must be 10 more definitely, which all of you all must be facing. Number one is convincing for early or timely AV fistula, or in general, proper pre-dialysis follow-up, which we all face, at least I faced in my practice. 2, starting hemodialysis on time, which the patient always asks for more time. 3, and I was privy to listening to Vishwanath's talk in ISN, where he said that it is very difficult to shift from twice a week to 3 times a week, which means one of the issues which we all face is making patients either start 3 times a week dialysis or to shift, if they were on twice a week, to 3 times a week. The 4th issue which I face, because I do practice PD also, is to convince people to be on PD. And again, Vish alluded to this problem of interdialysis weight gain and ultrafiltration rate, and the issues of either too much ultrafiltration and hypotension, loss of fistula, or too little control of the ideal weight, and eventually getting admitted in fluid overload state. Of course, one of the big problems we all face in all the units across the city, maybe across the country, is infection control. And this is our problem, giving enough time in the dialysis unit. The caring of vascular access, theoretical, known to all of us. Similarly, preventing CVD deaths is known to all of us, but it does become an issue in dialysis, and that's why we face a poor quality of life or the quantity of life in dialysis. Managing poverty is the basis of a lot of it. So let's move on to question answer sessions. And I have I think all of them have owned or do own dialysis networks. So the first question to Rajendra is, should nephrologists own a dialysis unit? I'm aware you own it, but you should try and tell us the difference between metro people or people practicing in metro and big cities
versus those who are starting in tier 3 cities?
From pure science that we heard in the first sessions, we are back now to the day-to-day hardships of dialysis. The first question that Dr. Umesh is asking me whether any nephrologist should own a dialysis center. I think the identity of nephrologist is always, even now, is with a dialysis unit. So you need to have a dialysis unit. Whether should be your own or whether you should be attached to it is a question that you should answer yourself. The main thing that if some nephrologist has to have in him is to do that day-to-day management of a dialysis unit, which I think everybody who has got trained in nephrology in KEM would be already ready for it. With
Show of hands, how many people feel they should own a dialysis unit? The vote is in favor of owning. I think making it and then running it, you alluded to the fact that whether you have it in you to run it or you should outsource it with the available of dialysis chains, and with people sitting in the audience owning dialysis chains. What is your take on it if they are not listening? Whether to give it to dialysis chains or to run it yourself?
If you are owning a dialysis unit, I think you must run it because you are already doing that hard job for yourself and then hand it over to somebody else to run it. There are always advantages and disadvantages. I have not done it any time, but I think the dialysis cost goes up. The profit sharing happens, so your profit goes down. Then sometimes the transparency is lost in giving it, handing over to another person or to a company. And ultimately, there may be problems in the day-to-day management of the center.
Rajesh, do you agree with it because you owned a corporation? Should we or should we not? I know these are all off the syllabus questions, but it doesn't matter.
So I will say one thing that Dr. Umesh Khanna started with his own units, and after 12 to 14 years, we handed over to nephrologists. So he is the classical example why he has handed over, because a lot of stress associated with dialysis unit is there. When you are starting your own centers, you are focused in that area of practice. If you are in corporate hospital or if you are attached to some of the hospital, that's fine. But if you are at multiple locations going here and there and managing on your own center will be difficult. Making more of a protocolized care where the protocol is important, SOP is important, quality care is important, you have to maintain the quality matrix, then I feel that the chain will be a better option than the owning your own.
So yeah.
In the forthcoming issue of Indian Journal of Nephrology, there will be a trial which will be published, and it has come up with shocking results. This trial was a survey of dialysis facilities in West India, Central India, and South India. The survival at 3 months is only 3 years is only 47%, and many of the centers which were run by corporates and for profit chains showed the most dismal survival and quality of life. So you read it in the journal and take a call yourself whether handing over your unit leads to a deterioration in quality of care.
I'll tell you my take on it. I shifted, as he rightly said, because I was earning 100 rupees extra with a lot of headaches. So I traded headache with 100 rupees and therefore I shifted. Vishwanath.
So I think your figures cannot be generalized. We looked at our data over 17 years. Our 5-year survival is 58.2% in 5 years, right? And even some of our competitors don't come as close to this figure as well.
We'll shift to the fight in the later on session, post-tea session. Raju, just a rough costing of making a 15-bedded dialysis unit in very short time, and per dialysis cost if you want to make.
The basic cost that is involved is the premises, which you either own or you rent it out, take it on a lease. Approximate costing for a premises we required for 10 to 12 bedded or 15 bedded unit is roughly about 2,000 to 2,500 carpet. That includes the waiting area, one consulting room, and a place for chemist and everything. That works out to almost 15 plus machines, plus other equipment. The total cost of establishing a unit, initial cost goes to 15 crores. Out of which, if you want to take loan, it will be 20% you will have to contribute. So 3 crores you will have to contribute. Loan of 12 crores, 5 years costs about 24 lakhs per month. 7 years costs about 16 to 20 lakhs per, and 10 years loan some bank gives you, then it costs you about 15 lakhs per month. That is the EMI.
Okay.
This actually, if it is within a hospital, then lot of costs do come down, and there are earnings of in-hospital dialysis are much better than a standalone dialysis. At the same time, a standalone dialysis will need a much better backup which is provided by a hospital. So a hospital-based unit is always, I would prefer hospital-based.
So you touched a different question, standalone unit versus having a unit inside a hospital. Obviously, medico-legally and otherwise, it's much better. I think we move on to the
day-to-day.
Okay.
Day-to-day.
Costing. Your unit, what is the per dialysis cost of treatment?
1,500 units we charge. The costing for a standalone unit goes higher. It is around, what I estimate is around 1,000 per dialysis.
Right.
But that ultimately the property cost and everything will depend on all those factors. Pardon?
No, I think without dialyzer tubing costs. You are talking without
excluding dialyzer tubing and heparin that you need for a catheter.
So I think when we talk of costing of dialysis, there will be many issues involved, which city you are, whether it's your own, whether you're renting, whether dialyzer tubing cost is separate, what is the rent in that area where you are, how much do you pay to your healthcare workers, all this will vary. But I think the rough estimate is what I wanted to.
First 3 years of any dialysis unit, when you start...
Mike.
When you start your own center, first 3 years, it will not be run in a full capacity. After third years, it is going to be 75 to 80%. So if you calculate first year 30%, and every year increasing by 30%, your cost will go up to 1,800, 1,900 because rent cost, machine investment, depreciation, all this cost will go up in first 2 years. So you are going to make some money after third years of your dialysis.
I see many hands to be raised, but I think we'll go on to all these question answers at the end. Question number 2, Rajesh is bored of practicing in Mumbai, wants to shift to Muzaffarnagar. Is it Muzaffarnagar? In Bihar. And so, Muzaffarpur, not Muzaffarnagar. Muzaffarnagar is close to Meerut in UP, right? Muzaffarpur. So, hey, 1 second. So, we are not including that in the costing of the dialysis unit. So, if you have to make a dialysis unit, in short, tell us what would be the ingredients of a good dialysis unit. How would you make it in 2 minutes?
So there are 3 pillars to make a good dialysis unit. The backbone or the heart of the unit is the dialysis machine and the water treatment plant. And you have got a soul, which is a hardware, where the HR, human resources like a dialysis technician, the doctors, the dietitian, the other part will take care. And the third part is the software where you are making a quality or protocolized care which will come in the software of the units. So these 3 are very important. Dialysis machine and the water treatment plant is the most important determinant of the patient safety. So you should have major investment also and major time also spending on these things. Water treatment plant, when you are designing, you should look for the water quality locally and how much water you are going to get it, because ultimately good quality water makes your dialysis unit best. So if you have got a very good quantity of water, you can make an online dialysis unit, online water treatment plant. But if you are not having enough supply, you can make an offline, which include a water tank in between after the RO plant. So water treatment plant, if you have got a highly chlorinated water, you can have a double carbon filter. If you have got a hardness of water more, then you can have a double softener. If you want to have, suppose you are not starting a SDF, but you wanted to have a single use high flux dialysis, or you can have a expanded dialysis, the new dialyzer has come. You can have a double pass RO membrane so that you can get ultra pure water. So water treatment plant is very important. After water treatment plant, you have to look for the distribution piping. the piping material should be best enough, non-corrosive, and you should have a heat disinfection or ozone, which is the cheapest disinfection available in the country. So distribution piping is also very important. Next is the water machine. For dialysis machine, the most important is not the machine, what quality you are getting. The service available locally is very important, because if you are not getting a good service, then the machine will be standing. Okay. So machine is also very important. Now comes the technician part. You should invest more money on technician, because technician is the main backbone of your dialysis unit. And one staff should handle the 6 dialysis in a day at least, or 3 to 4 machines in a unit. If you have got a 10-bedded dialysis unit, one machine should be a standby. Not in the initial phase, but once your capacity is full, you can have a standby machine. And apart from that, the protocolized care and all, you can expect.
Yeah. So I think the chief technician and the dialysis doctor is your alter ego sitting inside, because as a nephrologist, we do not put in the efforts required to be with the patients. And hence it's important that they do whatever you have already taught them to look after it. Protocols are good, but auditing those protocols, whether they are followed, is one of the major issues. So Dr. Chafikar, you have got a ready-made good dialysis center, or you have made it. How to successfully run your dialysis unit in the face of competition of other centers? This Apex group is already there, NephroPlus chains are there, corporate hospitals are there, and to top it all, there is MJ-PJY free dialysis units all across. So if
Hello.
Yeah.
Yeah, so I have seen it all actually. I have seen hospital-based units being run by me, standalone center run by me, associating with companies also I have done. Now, my opinion is that if you have to have a competition, I mean the specific question if I have to answer, then if you look at the corporate dialysis center as a competitor, I think that personalized care is slightly lacking at the corporate level. So if you offer a personalized care to your patients in your standalone center, probably that is the key where you can compete with corporate hospitals along with competitive pricing. So as far as comparison with corporate hospitals is concerned, one is look at the pricing, and second is the personalized care which you can give, which is probably absent in the corporate hospitals. As far as the MJ-PJY scheme is concerned, which is now universally there everywhere, so there I feel that, they have got a lot of rigid sort of timings and protocols and all that. So there you can offer the patient some alternative timings or some flexible timings as far as the dialysis is concerned, and then probably you can still go ahead with your own center.
Good patient counseling as far as comparing trust hospital offered dialysis versus corporate hospital offered dialysis versus your own standalone center. All these things you can have a comparison and then put it to the patient that what are the advantages. But I think the key is that if you are running a standalone center, it has to be a personal touch with the patient.
Right, and you could probably take insurances packages for your own center also, which would probably compete with, the tendency for people to go into big corporate hospitals. Ukhalkar, you have that, offbeat kind of approach many times, and do you have any cost-cutting measures, or do you have any specific points, Vishesh Tippaniya, from based on all these questions which we have asked?
Give me 2 minutes, I'll answer. The first concept that we need to understand is the concept of value. What is value in dialysis? Value is equal to the patient comfort that we give and patient survival that we give, divided by the cost, and cost is measured in rupees. But cost is measured only in the rupee terms for the real estate, for your consumables. Who costs the mental agony to the patient and his relatives when they come to the dialysis facilities? Who bears the cost of lost hours, manpower, Monday of the person who accompanies it? All this needs to be put into a cost analysis, and this is best done by a cost accountant and not by a nephrologist. And then you would really know what is the cost and where cost can be cut. The cost can be cut on two heads. One is the fixed cost, and the second is the variable cost. What is the fixed cost? The fixed cost is the cost that you end up with taking a space or buying machines more than what are required and they're sitting idle. So such fixed costs can be cut down. Consumable costs can be cut down by good Kaizen and by good housekeeping. I mean, you go to any dialysis facility and you see the stock management which they are doing, many of those and the kind of value which is getting depleted and destroyed by just poor stock management. HR is another cost head which needs to be controlled, and there are so many people in the dialysis unit, nobody knows what that chap is doing, and he's just whiling away his time. At the end of the month, you pay him.
While discussing many other things, we forgot what the patient likes, and that is how he is treated when he approaches the dialysis unit. And the guy who punctures his fistula, that technician is one of the most important reasons why he will switch from my center to your center, because your technician has the ability to puncture that fistula needle very well. So these are the art of your dialysis unit being preferred by the other. This is another area which I also struggled a lot. And Raju, what is the art of convincing a patient for making an early AV fistula, to timely start dialysis, or to come for 3 times a week? And if he's coming for 2 times a week, how do you shift to 3 times a week? What's the art?
The 3 questions is only one: Sam, Dam, Danda, or Ved. So you first try to counsel the patient patiently that you are likely to need. First of all, breaking the news that you have chronic kidney disease, it is progressing, and you are like going for dialysis. To break that news is very difficult. So it starts with Sam that something is coming. So you, in your body language, how you face the patient, how you talk to the patient, or you just make patient sit outside and explain to the relative. All these things we'll have to really think. Sometimes it is urgently required, so you have to tell them that if you don't do a fistula early, then you will have to go through all these ICU admissions, humoral catheter, jugular catheter, pump cath, then fistula. So all those again add to the cost. So next is dam. So the cost increases. So and that is how you can put it to them, that if you don't do things, the costing is going to be high, expenses are going to be high. The advantages of doing early fistula, disadvantages of not doing it, disadvantages of going on dialysis through a catheter as far as your health, as well as longevity, as well as while you are going for transplant, your general condition is likely to be better. And then done.
So Raju, the practical issue we face is when somebody's GFR is around 30, and when you start talking about fistula.
Even asking them to preserve the vessels.
Right. And most ISN guidelines or any guidelines will tell you that at 15 GFR you will have to make a fistula, at which time is creatinine somewhere around 4 based on our weight and other things. And it is an art to convince him at that time to make an AV fistula. This is the point which I am trying to make.
And then bathing, you are trying to show one patient who is doing well with dialysis through the fistula and somebody who is not doing well with catheter dialysis. So all these Chanakya nitis you will have to really try and work hard.
I think you need a good counselor or a dialysis nurse, as they have it outside, or somebody who can devote more time to explain all this, given the time constraints which a nephrologist faces. And I think the patient ambassador is a great one. If in your busy practice, if you see somebody coming with a jugular catheter, the other guy, he is very scared of that person. And then that patient is very easily, it's possible to convince him for an AV fistula. So a patient ambassador is a good idea. This I use it for CAPD convincing. My CAPD patient is generally the patient advocate who convinces the other patient.
Asking them to go to dialysis unit, see the patient, but 99% nobody goes and sees.
Yeah, bhai.
Really, this is the dialogue. Zindagi badi honi chahiye, lambi nahi. But the dialysis patient must realize that if everything is done early, it has to be a lambi zindagi also. So maybe some philosophical statements like this, or some events, some patients, earlier patients' problems, they can probably motivate them to go for early fistula, early dialysis, 2 times a week, 3 times a week.
I think time is running short because we have hardly 15 minutes to go. And Rajesh, your favorite topic is sepsis or care of infection. And I think 2 of us have been in the panel multiple times trying to explain the technicians how to look after infection in that. So how do you manage to do? You have multiple types of dialysis setups, from PMJY, from those who are extremely poor class patients to the corporate. So what's your Chanakya Niti?
So infection is omnipresent in our dialysis. And we all know that apart from cardiac, infection is the second most common. But what I feel is the infection is one of the most common region for hospitalization, non-mortality or morbidity. So if you see in the dialysis unit, our problem is apart from catheter infection, we have also infection related to dialysis contamination, which is a very important and critical issue because our dialysis water treatment plant is not well maintained. And water treatment plant, even if well maintained, in the rainy season you can get a feed water which is of variable quality. Like if you have got a high bacterial load water at that time, and which override the capacity of the RO membrane, then you can get a rigors in the dialysis unit. So in that part, if you have got any change in the feed water, you have to think about that. Then after that, you have got an ineffective RO membrane, or if you have got a distribution pipe, you have got a very good RO water treatment plant, but you are not having a good distribution piping. Suppose you have got a dead end, or suppose you have got a long, you can see behind the dialysis machine, you have got a long pipe connecting from the distribution piping to the dialysis machine. There the water stagnation is happening. And in that water stagnation, the bacteria or slim layer or that endotoxin start making there, and it can cause infection. So that is one area, stagnation in the dialysis machine. Suppose machine is lying in the ICU for 5 days and not starting, and suddenly you go there and start one dialysis machine without doing a thermal disinfection, then you can get an infection. Apart from that, inadequate or improper dialyzer reprocessing is another area where the infection can take place. And the bicarbonate, what you are making it, if it is long standing, then that can also cause
long standing. And of course, if the patient's gone to village and he comes back and after 8 days you are using the same dialyzer tubing, those are other issues. One area which I think is important here, which I think Dhananjay can put some light on, is these technicians are taught about hand washing, or whatever sepsis protocol management, etc. How do you bring in that feeling in the technician's mind that he is the person who will make a difference between life and death of the patient?
I think there is no such thing as feeling which motivates human action. It is only punishment, penalty, and reward system. So the WHO has come up with hand hygiene supervision checklist. So you give one fellow the supervisor's responsibility. He will see in the unit who is doing hand washing, how many times hand washing has been missed out, and on the WHO scorecard he will make a mark, and then before the end of the shift there has to be a meeting with the supervisor or controller, and that result has to be shown to them, and some kind of penalty has to be established for his behavior to be changed.
Carrot and stick policy. I think Vishwanath talked about the BCM machine, and I think it's a very important area to be discussed as to how to handle dry weight of the patient. And I think that's what makes a difference between the number of hospitalization of that patient, either with fluid overload or due to hypertension, fistula, band ho gaya. Your take on it. So there is art and science in it, so therefore.
There are two issues here. Let's take an example of a new patient who is entering the dialysis unit, and you have to fix the dry weight. So there, of course, you have to give personal attention to the patient. You have to see the patient regularly, pre and post dialysis, and then take a call what dry weight you want to advise. Often we see that we don't monitor the data on dialysis. So for example, number of hypotensive episodes or the vascular access monitoring which needs to be done before dialysis, or the KT by V at the end of dialysis, or the patient's recovery time after the dialysis. So all these are important clinical features which you need to look into as far as the deciding the dry weight is concerned. So that's for a new patient. Now for a patient who is coming regularly for dialysis for months or years together, they usually come and tell the technician that mera 4 liter nikalo ya 5 kilo nikalo or something like that. Now I think the control of this should never be given to the technician. If you ignore this, then there are disasters. Because many times the technicians play to the gallery and they obey the orders of the patient, and then there is a disaster. So I feel that you have to supervise yourself. Once the patient has achieved the dry weight and is pretty stable, and insist that you see the patient clinically at least once in a month and assess the cardiac function, because cardiac functional deterioration also adds to the ultrafiltration related problems. So a new patient gets a different treatment as compared to an older patient with ultrafiltration related issues. And here I have also seen that the data which you collect on the machine, you buy a machine which gives you the data. And that data, that means the trends of blood pressure on dialysis, the trends of fluid removal on dialysis, and the feel-good feeling of the patient. All these things put together will prevent ultrafiltration related issues.
So again, carrot and stick policy with the technician, and two, spending more time, either yourself or your clone.
What we should have mentioned, use technology as far as the
BCM.
BCM and the other online volume monitoring systems which could be available in the sophisticated machines. So that also can be used in case you are having the problem of deciding the dry weight itself.
We have 2-3 minutes spending, and therefore I want to ask Dhananjay, who is quite an expert in these areas. How do you manage to add value-added services like nutrition, exercise, counseling services, a social worker to look after the cost issues, or the caregiver issues which come up with a long-term dialysis?
I think the short answer is train the dialysis technicians. The senior dialysis technician can be trained into all this.
Yeah. So I think this makes a huge difference.
Add to the previous discussion by Nathan, we need to use information technology to analyze data. Data just collected and not analyzed is of no use to anybody. You can use Google Studio, and nowadays it is called as Look Studio, and put all these Excel sheets there and create limits. Once you create limits, you need not look at each data entry. You just look at the deviation or variations in the data of each parameter or each outcome that you want to monitor.
Right. So it is ideal to have all these people on board.
Best it is free.
Yeah. The nutrition, the exercise, the physiotherapy guy, the counselor, and the social worker, but it becomes difficult. So as he mentioned, that either your dialysis doctor or your senior technician should be well versed in looking into all these things. I think the floor is open for questions. Narendra.
I think I wanted to pass one comment. Like, we all know that dialysis is never a profit-making thing for any hospital or any standalone. So one should understand, whoever is practicing nephrology, they should have a dialysis unit. Whether it is a own unit run by the corporate, run by the multiple center owner or so on. And see that you are not making money on the dialysis, that is also fine. But it brings the patient. So when we are looking as a business, when we are looking as a commercial value, then getting the patient will be also important, getting the people, getting the footfall will be important. And that the dialysis unit can give. Thank you.
Right. So I think there are few questions only, because I think the brains are saturated with such extensive program. of academics. So let me close this with the...
Make a comment.
Yeah.
I think you have to prevent your physical and mental fatigue as you get more and more into handling this dialysis unit. You tend to feel that nothing more can be done, and that ultimately makes you more fatigued while handling the dialysis unit. So some way or the other, you have to find out a way in which you prevent that from happening to yourself, so that only you can manage the dialysis unit.
Right. So I will close the session with a boring and simple gyan, because this whole session is about 10 lessons from the experts sitting here. So number one, spend time in dialysis unit. It defines you as a nephrologist. You need an excellent senior dialysis technician or a dialysis nurse or a dialysis doctor who is the heart and soul of a dialysis unit. Invest in them. Invest in pre-dialysis care for better dialysis outcomes. Again, you need a person to help you to talk to the person so that you can give enough time for all that. Give full respect and care to vascular access. All of you all know it. Sepsis control protocols in place, but more importantly, reward and punishment for people who can monitor it. As Rajesh said, invest in water treatment plant, maintenance protocols of all machines, dry weight, ultrafiltration rate, as mentioned by both Vishwanath and don't grow old so fast, yaar. Anyway, adequacy protocols should be regularly audited and aligned with patient-centric care, as was discussed earlier, and value-added services like nutrition, exercise counselor, and social worker will really add value to your unit, which is what we are discussing. Thank you so much for the patient hearing.
हेलो हेलो करो अनाउंस कर लास्ट माइक चालू है चलो
Check. I'm sure the stage setup has invited a lot of curiosity as to our next session. We now have a Gram Panchayat in order, interventional nephrology in GP with our Panch, Dr. Vidya Shankar Panchangam, Dr. Ravindra Madraki, Dr. Amar Sultan and Dr. Vilas Nayak. And our Sarpanch, Dr. Hemant Mehta. Over to you, Sarpanchji.
नमस्कार गांव वालों डोंट वरी इधर कोई बसंती नहीं है मौसी नहीं है ये हमारा छोटा सा गांव है गांव का नाम है नेफ्रो गांव आप सोचेंगे नेफ्रो गांव अरे आपने सुना है ना वो बाजू में बड़ा गांव नाई गांव नाई गांव के बाजू का छोटा नेबर है नाई गांव और ये है हमारी ग्राम पंचायत आमतौर पे ये ग्राम पंचायत खुले में होती है खुले का मतलब दूसरा कुछ मत समझना हम पेड़ के नीचे बैठते हैं गांव के एक जगह पे और ये हमारे ग्राम पंचायत के मेंबर होते हैं जो बैठते हैं जब भी कोई कंप्लेंट्स होती है कानूनन ग्राम पंचायत 7 से 17 लोगों की होनी चाहिए लेकिन गवर्नमेंट ऑफ इंडिया ने हमको परमिशन दी है कि छोटा गांव है तो 5 लोगों की ग्राम पंचायत भी ठीक है इसलिए हम 5 लोगों की ग्राम पंचायत आज बैठी है तो पहले मैं मेरे ग्राम पंचायत के मेंबर्स को इंट्रोड्यूस करूं उसके पहले मैं इंट्रोड्यूस करता हूं मेरे आप जैसे मैंने कहा हम खुले में बैठते हैं पेड़ के नीचे बैठते हैं मैं सरपंच पेड़ के थड़ के पास बैठता हूं इसलिए मेरा नाम है जेरी बी थड़ जेरी बेथर्ड के नाम से ये मेरा नाम इंस्पायर्ड है जेरी पी थर्ड और ये हमारे सब मेंबर्स है तो अमर सुल्तान है ही इज इंस्पायर्ड बाय ट्रू कट नीडल सो वील कॉल हिम डॉक्टर क्रू कट दूसरे हैं हमारे डॉक्टर विलास नायक जो पंप कैच से प्रेरित है तो उसको हम कहेंगे डॉक्टर प्रेम ए कैथ फिर हमारे डॉक्टर रविंद्र मद्राकी साहब है जो कैनेथ एप्पल से प्रेरित है एप्पल जिसने पहला सिमिनोब्रेसिया फिस्टुला बनाया तो एप्पल सेब तो कैन सेब और यह है डॉक्टर विद्याशंकर जो हेनरी टेनकॉफ से बहुत प्रेरित है तो इनको हम बोलेंगे डॉक्टर हैरी टेनकॉफ ओके सो अभी जैसे मैंने कहा कि कंप्लेंट्स होती है तभी हम बैठते हैं तो आज कंप्लेंट्स आई है द फर्स्ट कंप्लेंट इज फ्रॉम मिस हेनली तो उसका कहना है कि शी अंडरवेंट प्री एम्प्लॉयमेंट चेकअप एंड दे सेड देयर इज प्रोटीन इन हर यूरिन शी वाज एडवाइज्ड टू अंडरगो किडनी बायोप्सी शी कंसल्टेड हर फ्रेंडली नेबर वी सेल्वर मैन so he said he can arrange it with blind static imaging technique Henley was not convinced she has come to us for solution so Dr. Krukat please address this issue and come to an amicable solution अब बताइए कि ये करना चाहिए ब्लाइंडली कि आजकल क्या नया चल रहा है किडनी बायोप्सी में
सरपंच जी मैं एक बात बोलूं वो सिल्वर मैन है ना आज भी उसका चूल्हा पत्थर रगड़ के करता है अभी अपन बड़े हो गए अपन इलेक्ट्रिसिटी जमाना एआई का जमाना है ब्लाइंड प्रोसीजर में क्या विश्वास है मैं सोचता हूं अभी नए नए टेक्निक है कोएक्शियल टेक्निक है रियल टाइम में मेरे पास देख लो हां फोटोग्राफी गाइडेड अपन कर लेंगे
तो ये जो बोल रहे हैं उसका नाम है साइन टेक्निक राइट हाँ ठीक है सो ये कोएक्शियल मेथड तो है उसके भी एडवांटेजेस है और ये दूसरा कुछ बड़े लोग होते हैं तो उसको साल्व पोजीशनिंग क्या होता है
अपनी जो मैडम जी आई है वो तो काफी अच्छे शेप में अपन तो कन्वेंशनल फ्लोर पोजीशन में करेंगे लेकिन अगर कोई ओबेस है, प्रेग्नेंट है, तो यस अपन सुपाइन लैटरल पोजीशन में कर सकते हैं कॉम्प्लिकेशन।
सो ये हेनली ने एक सवाल ये भी पूछा है कि कैन आई अवॉइड बायोप्सी, कुछ अल्टरनेटिव मेथड है क्या? तो ये क्या लिक्विड बायोप्सी आजकल बायोमार्कर ये क्या चल रहा है?
हमें हमेशा बोलते थे कि अगर गरीब पेशेंट meticulously done urine routine microscopy is a poor man's kidney biopsy, यहाँ से सर हमेशा हमें कहते थे। पर ठीक है, अभी रिसेंट एडवांसेस की वजह से यूरिन में जो माइक्रो आरएनए है, मिथाइलेशन प्रोडक्ट्स है, प्रोटीन सीरीन प्रोटीन कर सकते हैं, लेकिन अपने नेफ्रोग्राम में अभी तक अच्छे से आया नहीं हो, तो मैं सोचूंगा कि रिस्क ना ले।
ठीक है, गुड। सो बिफोर वी मूव टू द नेक्स्ट वन, एक एनेक्डोट बताना चाहता हूँ। जब भी मैं रजिस्ट्रार था, मैडम थी, वो वार्ड 34 के बाजू में वो बड़ा टेबल ओपीडी में न्यूरो सर्जरी के साइड में हम बैठते थे। तो एक दिन ओपीडी चल रहा था, वही मंडे थर्सडे वाला। मैडम सामने बैठी थी, मैं एग्जैक्ट अपोजिट में था। मैडम ने अचानक मुझे बोला, हेमन ये मेरा कजिन है, उसका बायोप्सी करना है, तू करेगा। उधर ही मेरे तो पसीने छूट गए। मैं बोला अभी का भी अपॉइंटमेंट दे दे। सो अपॉइंटमेंट यूज्ड टू बी गिवन इन वार्ड 34A। सिस्टर के पास डायरी रहती थी अपॉइंटमेंट की। अब भी जा तू ओपीडी छोड़ के। मैं गया ऊपर, तो मैंने क्या कहा, सिस्टर मैडम की अपॉइंटमेंट डायरी लाओ। बोलते मैडम यहाँ, बोले दिखाओ तो सही। मैडम का कभी अपॉइंटमेंट मीटिंग वगैरह? बोल रहा बुधवार को 2 बजे मैडम का डीन के साथ मीटिंग है। मतलब ये पेशेंट को 2 बजे बुधवार का अपॉइंटमेंट दे दो। मैं बोला अगर मैडम के कजिन की बायोप्सी फेल हो गई, देन मेरी तो डीएम उधर ही चली गई। एज अ फर्स्ट डीएम कैंडिडेट उधर ही 0% रिजल्ट आ जाएगा। सो आई के अल्ट्रासाउंड मार्किंग करा लिया 1 बजे, सब पर्सनलाइज्ड ना। 2 बजे मैडम गई मीटिंग में, मैंने प्रीपेड रैप किया। तो ऐसा आई जस्ट टर्न अराउंड, सिस्टर, ऐसा आई थॉट सिस्टर इज स्टैंडिंग है, मैडम खड़ी थी उधर। एनीवे टचवुड वही विम सिल्वरमन नीडल से बायोप्सी किया, अच्छा रिजल्ट आया, जान में जान आ गई, वो बच गए, पास हो गए, पप्पू पास हो गए। ओके, सो लेट्स मूव टू द नेक्स्ट कंप्लेंट। एंड नेक्स्ट कंप्लेनेंट इज मिस्टर टैल। ओके, टैल माइकल टैल, पैलिंड्रोम कैथेटर का इंस्पायर्ड टैल। He says he needs to be started on hemodialysis. He does not have a AV fistula in place. So he went to his friendly neighbor, Sakhya Mahurkar. Apna Sakharam Mahurkar, you all know him. Okay. So he said that he has his own innovative oval double D configured catheter which he is willing to provide for free. But Tal is not convinced. So let me ask Dr. Prem Akath, what are the material innovations in HD catheter?
सरपंच जी आप गुस्सा हो जाओगे, मैं तो टॉपिक छोड़ के थोड़ा सा भागने वाला हूँ। यार ये सब बड़े बड़े पढ़ाई लिखाई किए हुए लोग हैं, आपका कोई नेबर हो और उस घर में 4 लोग हैं और सारे ग्रेजुएट हैं, तो इन लोगों ने तो इतनी पढ़ाई की है कि उनको 2 गुना से मल्टीप्लाई कर दो, फिर भी हमें अकेले की पढ़ाई उनसे ज़्यादा हो जाती है। तो इनको परम क्या तो मटेरियल इम्प्रेग्नेटर सब पता है। मैं थोड़ा सा चुटकुला सा सुना देता हूँ सर जी। आई वॉज माई सुपर सीनियर्स वेयर Ismail and Swapnil. So working after them was like talking on PD after Dr. Ramesh Khanna sir. Sir's expectation was like there, and we came, and with such expectations we were like half dead, but we still had some solace. After them followed was a Sachin Tendulkar. Dr. Sheetal Lingde, he's a great nephrologist. But when he received a call after 12 o'clock from medicine department, the words were, "Abe, 3.5 creatinine ko emergency kya hai?" The medicine sometimes kept the phone. Sometimes again someone dared to. Potassium kya hai? Sir 3.2. ABG? Sir machine बंद है. तो फोन रख. 8 के बाद फोन next call भेजना, मेरे को नहीं. So okay, we had some solace and comparison. Then came my dear friend Ravindra and another guy called Subhash Chandra. Subhash Chandra was a Kerala Express. He walked fast, he talked fast. 20 calls, 2 hours, done, finished, sleeping at 12 o'clock. डायलिसिस होने के बाद भी पेशेंट को पता नहीं रहता था कि हुआ क्या है. हाँ ठीक है, किडनी फेल है, चल साइन कर. दूसरे दिन साइन कर. समझाया था ना, पता नहीं चला, चल हाँ ठीक है. अरे आपका डायलिसिस हुआ, किडनी फेल है. सर हमको पता ही नहीं चला, वो सर क्या बोल के चले गए, मल्लू टोन में हिंदी बोल रहे थे. देन केम आर राहुल द्रविड़. 31 runs in 100 balls, 20 calls, 10 remaining for the next day. So all of them knew very well what has happened. Patient has clear idea, but Ravi had one problem. He used to fall asleep anywhere, even during singing calls. So I had some hope. Yes, kuch to comparison theek thak hai. And then we started our SRship and we enjoyed a lot. I worked with Alameda sir, I worked with Hasi sir, Halankar sir. I was followed by Praveen and Harshal and Vidyashankar and Dilip and also Hemal. Sir, some comment? Thank you.
Okay.
Diverted from the topic.
He is very smart. He has not answered any question about material, catheter tip design, infection, clot control. So, jane do. I'll give you a now anecdote. Okay. So, I'm sure sabko malum hai Dr. Robert Uldal. Okay. He was the person who actually pioneered nocturnal hemodialysis. And for that, he wanted to be sure that there is a reliable vascular access. And that's how he developed his own technique of putting double Newman subclavian dialysis catheter. So I knew that I was registrar. I'm talking about 87, 88. Madam used to have one cupboard with lot of books. She used to keep the key. If she wanted some book, she will give the key. Hemant, go and get that book. So you have to open that, bring that book and lock it and give it back to her. So while one of those matters, I saw one Terimo 20 centimeter double lumen catheter. Now that was the first time I was seeing a double lumen catheter, which is now a routine. Dekh liya, fir padh liya. And then I found out that Robert Uldal is the person who's going to come to attend the annual meeting of API COM. In those days, ISN, Indian Society of Nephrology, annual meetings used to be held with Association of Physicians of India. Okay. So I was registrar, Madam was going, Alan was going, Umesh was going. So I told Madam, please bring Robert Uldal here. We have 2 catheters. I will make sure I keep 2 patients ready. So that was done. He came, he did the first catheter. He did subclavian catheter. He had a technique where even non-cuff catheter, he would do it with a tunnel. And then when he was doing it with that, we did the procedure in that transplant room, isolation room inside. The whole room was surrounded by, so I was like in the middle of Madam to somewhere here and then people below me. When he finished the first case, he turned, looked at Madam, ask one of your boys to wash up. I will teach him. मैं सोचा मेरा नंबर कहाँ आएगा, मेरे आगे इतने बड़े बड़े लोग हैं. Madam looked at me, Hemant, wash up. So उसने मेरे हाथ पकड़ के सिखाया. I thought I have learned subclavian catheter. We started doing it. Problem starts. First 10 case of subclavian catheter done by Hemant Mehta. 9 cases blood culture positive sepsis. 1 death because of hemothorax. मर गए. पोस्टमार्टम हो गया. सेमिनार हॉल में मीटिंग हो गई. मैडम का गुस्सा. You guys are useless. No more subclavian. Go back to femoral. मर गए. अभी तो 3-4 दिन तो मैं भी बहुत अपसेट रहा. फिर दिमाग में आइडिया आया. अपना सेवियर तो एक ही होता था, एलन. तुम बिन हमरो कौन नहीं. वो आमिर खान के पिक्चर में वो गाना तो बाद में आया. हम तो तभी से यही गाना गाते थे, तुम बिन हमरो कौन नहीं. सो एलन को बोला, पटाया. फिर एलन ने मैडम को पटाया. And then we restarted the thing. And then down the line, I was going to Bangalore along with madam for a conference. That time Alan had already left for USA. So there madam arranged for me to train for the IJV. So first subclavian, first IJV double human catheters were done in KEM in the city of Mumbai by us. So this is the anecdote. Okay, so I hope with your explanation, Talpal is convinced. We hope so. So let's have the next complainant. The next complainant is Mr. Saldinkar. He says that he has been advised to undergo fistula for need of HD in future. So his friendly neighbor, Miss Simini. Okay, so you know Seminobrescia. Okay, so they were the first nephrologist who arranged to do the first AV fistula with Dr. Kenneth Apple in Bronx Veteran Administration Hospital. So our Miss Simini comes from nearby village, Bronx. Okay, Bronx, this Suzuki has brought a model no, that is manufactured in village Bronx. So she says that she can arrange for a fistula, but Sal Dinkar has a question. Has anything changed since 1966? So let me ask Dr. Kensab to address the matter. By the way, Sal Dinkar is aware that there has been enough needling into the matter and he doesn't want to counter it. Okay? So now you please answer this question.
Yes. Thank you, Sarpan Saab. But I want to add one thing before giving solution for AV fistula to my patient. I used to see next day also calls. Next day evening I used to finish and go and sleep. And I used to get traction injection from Almeida sir in afternoon 1:30 OPDs. Because I used to eat and run to OPD. I was slow. And I used to sleep beside him. He's OPD. Somehow escaped. I think fistula...
Just to add one thing, Ravi is about to open a new medical college.
Thank you. I need your wishes. No, because I think from 1966 to 2004, I don't think there was any change because we used to struggle getting AV fistula from urology department, from CVTS PGs only. I don't think no boss used to do. Kabhi Almeida Salva patient ko the phone, and he used to call and tell only. But वो भी fail ही होता था. तो especially sir phone किया और boss लोग किया तो fail हमेशा होता था. कभी PG लोग किया तो वो भी night. All fistulas used to be done in the night after their duty hours. CVTS PGs. And same like what happened is I went to Bijapur, the first nephrologist, no nephrology concept, first dialysis unit, and forget about the fistula. Like I used to send to Solapur on CVTS surgeon or else Hyderabad or Bangalore. I struggled for 5 years. What happened is like 66 to what? But I started cruising the fistula. Because from 500 kilometers, 100 kilometers, they used to get fistula and come back. But night when they start bleeding, they never used to go there because otherwise they used to die. They used to rush to my hospital. And I have to do something. And no surgeon used to come in the night 1:30. I started holding, first compressing. I was not knowing how to put tourniquet also that time because nothing we have learned in KEM that time about fistula. I used to like proximal ligation, then distal ligation and then close the fistula. First 8 cases, just my presentation in 2014 Nephrology Association of Karnataka in Chikmagalur was like my 8th fistula closure. Then we started doing it. That is why from 1966 BC fistula started, but it was side to side and then became, because of the venous hypertension, it became end to side. But what last 20 years has been changed a lot in nephrology practice. Because when 2005 I started in Bijapur, the practice of nephrology was really very simple because we were dons in glomerular disease. So patient अच्छा ही होता था. But now when we see 20 years of OPD outside, all bad patients only we sitting. Like beginning, like after going from KEM, like at the Saturday nephropathology meeting, like we used to be very happy to treat all glomerular disease. But over a period of last 20 years, the CKD population has increased. And need for the access is very important because in KEM, temporary catheter we used to put ज्यादातर पिछला करता था नहीं तो बाहर भेजता था. बाहर कब पिछला होता है किधर डायलिस करता था, we never used to bother. Only patient used to prepare for the transplant used to be, we used to worry about the access. Otherwise, I never felt that there is a need. Only after going to private practice we realized it, and especially last 20 years the number of CKD and dialysis really increased. Like when 2005-6 dialysis rounds used to be nothing, just that. When you go to dialysis rounds now, the access is a big fistulas, big aneurysms, and that is why it has evolved a lot now. Nephrologists are in the forefront, and I am in the mission to empower all nephrologists to do fistulas, access planning. If not doing fistula, access planning, because mapping is very important, and now to the endovascular, but still surgical technique is the best, and planning by nephrologist is the best suggestion for my patient.
Thank you. So basically we have moved from the concept of one size fits all to the right access in the right patient at the right time. That's what has evolved. And of course, there are some further changes in the surgical technique, like radar technique, and there is a P-slot technique where you piggyback the artery on the vein and stuff like that. And then, of course, endovascular fistulas have come in. One company has already closed down before it has ever entered into the market, so we'll have to wait and watch for the future. So I hope Mr. Dinkar is satisfied with the answer. So next we move to the CAPD, and the complainant is Miss PT Mem, peritoneal membrane. And let's ask Dr. Henry Tenkov. PT Mem says that she needs dialysis, and her friendly neighbor, Ram Gokal, from Dr. Ram Gokal, says to prefer peritoneal dialysis over hemodialysis. She says her dialysis will not be supported unless she goes for PD first policy. So, Dr. Henry Tenkov, what's happening about this PD first policy? If you can just inform the Gaonwalas.
Yeah. So the PD, as you know, we had a PD clinic in KEM, and we had a cycler which was like an old IBM computer, which was like a, nobody used to understand what is this. And ultimately this was a cycler which was placed. Now there is a lot of evolvement has happened, and it has become so compact. And PD is picking up, of course, it was at the peak, and now it has come down. So definitely the government, some of the states actually approved the PD first policy, but I think once if they have a good patient selection, the PD first policy definitely is great advantage for a patient.
So whom should she go to? General surgeon, laparoscopic surgeon, radiologist, interventional radiologist, nephrologist? Who will be the right person?
So actually I started putting PD catheter because it happened. So we used to refer patients to surgeons. So one great surgeon has put a PD catheter ulta, that's a reverse. The ports were outside, and when we started flushing, the fluid was coming from. He has put the cuff part outside and the external part inside. So then we decided, no, this is the disaster. So definitely the nephrologist-driven program is the best, and it will run longer.
And any technologies in the change of PD catheter design?
Now we are putting under ultrasound guided, so that can be bedside, we can put, and it's very simple. And in fact, we can, if we go a little further, we can in fact open the peritoneum and put it under vision. We can give a pararectal blocks, and it works like a GA, and it is very good.
So the first PD catheter insertion, let me give you another story. So we had a honorary psychiatrist. His mother needed dialysis. She was 86 years old. And we all know madam's policy, no maintenance dialysis, no maintenance dialysis. So she somehow convinced him that she should go for PD. And I don't know, for whatever reason. So at that time, madam procured one disc column catheter for PD. Okay, it used to be also called shower head catheter. It used to come like a sandwich, 2 layers with pores there, which will sit just below the peritoneum, flushed with the internal peritoneum. And So Dr. Samsis unit, Dr. Supe, who was the dean afterwards, so we were good friends. So madam contacted them. They agreed to put the PD catheter. I took the permission from the madam that can I go and see that procedure. All my contemporaries laughed at me. You are going to study kar DM ke liye, going to go and waste your time in a procedure which is never going to come to India. Okay. So anyway, it was done. Everybody thrilled, flush in, out, okay. Patient was shifted. In those days, Ward 34 was under renovation, so we were temporarily moved to new building, some 13th floor or somewhere in the new building. So patient was shifted there, and immediately it was told, start PD. So we started PD. I was standing there, fluid pushed in, nothing coming out. Fluid pushed in, nothing, and then pain increased. We don't know what is happening. We have no concept what is this this column catheter and stuff like that. So ultimately, we contacted madam. It was Saturday afternoon by that time. So madam said, stop it, put the femoral, start the dialysis, we'll see what to happen. Ultimately, we arranged to get it surgically removed. And lo and behold, the peritoneum had gone and got sandwiched between the two sandwich layers of that catheter. That was the first and last experience with that catheter. So this was introduced somewhere in 86, 87, and 1990, a paper was published comparing the Tankov catheter with this catheter. And this catheter was found to be inferior with increased incidence of peritonitis and stuff like that. So that catheter was not useful anyways. So our PD program ended at that time for CAPD program. And then, of course, it was revived with Dr. Almeida after having come back from Missouri, Columbia, having trained in CAPD, and then we revived the CAPD program. So that's how the whole story is. So I think we have addressed all the complaints today. So we call off the Gram Panchayat session, but before that, I would like to all the members, whether you have one line message for the Gaonwalos in the field of intervention nephrology. One. Yes, we'll start with Dr. Krukat.
My message would be do as much intervention as possible.
Do as much intervention as possible because we need of time.
Yes, we should be active planner if not doing it. We should plan, especially access.
So I think for intervention, I think every day we should aim at one procedure per day. That is for a nephrologist. So at least a PD insertion or IGs, whatever, that has to be with us. Yeah.
As we all know, the number of nephrologists has really gone up, doubling, tripling in last few years. And I think this is for survival. I would suggest that if our PG program hasn't taught us adequate numbers, we have got good number of fellowship programs, short ones, 3 months, 6 months, who train us in interventional nephrology. 3 or 6 months is not a big part of life. I think everyone should get one of those if they feel not so confident, because doing it perfectly is the way to go.
Okay, so we hope all the nephro Gaonwalos have enjoyed interventional nephrology ki Gram Panchayat as much as we all enjoyed presenting it, and we thank all the nephro Gaonwalos to have been present. Thank you very much. Thank you. निखिल ये ले ले सर मैं हाँ अच्छा हो गया ना
For our next session, I call upon the chairpersons Dr. N.K. Hase, Dr. Arun Shah, Dr. Mahindra Merchant, and Dr. Kamlesh Punk. We now have an absolute treat in store. This man needs no introduction. He's a world leader in the field of peritoneal dialysis and gives us all deep sense of pride to call him a fellow alumnus. Yet, if there is one thing greater than his clinical and academic excellence, it is his humility. Over the past year or so, Sir has been taking weekly lectures for us on Zoom at 3 p.m. Indian Standard Time, or for him 3:30 a.m. local time. He even visited the department last year and taught us all about peritoneal dialysis in a peritoneal dialysis masterclass. I know for a fact that he was thrilled to be here for the centenary meet in person, but that could not happen due to unavoidable circumstances. Nevertheless, we have him here on Zoom. I welcome Dr. Ramesh Khanna sir and invite him to talk about top 10 PD basics.
Thank you very much for a kind introduction. A topic that is given to me today for presentation is what are the 10 things that a practitioner who practices peritoneal dialysis should know. Essentially, what I'm going to do is present to you what is the current state of the art as far as practicing peritoneal dialysis is concerned. In the next 30 minutes, I will go through some of these things that everybody should know what is expected and what is the expected outcome when you perform a certain procedure or something in related to peritoneal dialysis. So I'll go through the basic technique, what is the current practice, which patient should be offered to do peritoneal dialysis, and which modality of PD should be given to this patient, and which catheter should be used. PD prescription, what PD prescription is appropriate for a given patient based on his medical condition. And while PD prescription is done, how do you manage the sodium balance? Infection control is very, very important, that if there is an infection, the chances are that person might lose his peritoneal membrane. So what are the things that you do to prevent peritonitis? Nutrition. Everybody says that PD patients' protein tends to be low, but there is a technique that you can use so that you can give adequate protein and maintain as good a serum albumin and total protein as a patient on hemodialysis. Managing long-term complications. I'll mention some of those things. Monitoring adequacy beyond KT/V. KT/V is a number, but what is called adequate peritoneal dialysis? And lastly, peritoneal dialysis is a teamwork, and it is a treatment that provides empowerment of the patient. We have to provide treatment that patient wants. Just as a briefly, milestones in peritoneal dialysis, I'll just briefly mention that. In 1923, first clinical human peritoneal dialysis was done by Ganter in Germany. 1964, first PD was performed in India, Postgraduate Institute of Medical Research in Chandigarh. In 1968, the first Tenkoff catheter was used by Henry Tenkoff in Seattle, Washington. 1976-78, the current CAPD and its other modality came into discussion, and by 1978, Oriopoulos, Nolf put that into practice, and that's what we are practicing now. In 1980s, the technique refinement happened so that the improvement in peritonitis occurred such that the current standard for acquiring, performing PD is 1 episode every 3 years to 6 years. And this is just to show you how the PD is done. Through the takeoff catheter or whichever catheter you use, that is inserted into the peritoneal cavity and is connected to a PD fluid containing, a bag containing PD fluid, and running the entire 2 liters of fluid. It stays in the peritoneal cavity for anywhere from 4 to 6 hours if you are doing CAPD. And at the end of prescribed duration, you drain the fluid out by gravity. Here no machines are involved. Inflow of fluid is through gravity, through a hanging pole, and when the drainage is required, put the bag on the floor. Again, the gravity will drain the fluid out. When initial PD was started, existing PD fluid in the bottle was used. Now, most of you may or may not know that this is not airtight or fully septic, aseptic. There are a lot of air leaks in during the fluid goes in, and this in the first 1 or 2 years of PD, there was very high incidence of peritonitis, such that every 2 months, every 2 months, patient used to be in with the peritonitis. When I used to make round in a ward, I may have a patients, 8 to 10 patients with the peritonitis admitted for treatment. Then, as a modification of this technique, PD fluid in the plastic bag came in, and this was fairly tight, and in an aseptic condition, fluid could be introduced. This simple technique change provided improvement in peritonitis from 1 episode every 2 months to 1 episode every year. That was not good enough. So a further modification was made, what was called a vice system, in which the contamination that could occur while you make the connection is flushed out of the system before PD fluid is inserted into the peritoneal cavity. That means if you made a connection here, if there was a contamination, the fluid would be drained out into the drain bag, and after an initial maybe small amount of fluid, run the entire 2 liters of fluid into the peritoneal cavity, which is free of any contaminated germs. So this technique changed the peritonitis rate from 1 episode every 1 year, 1 to 2 years, to 1 episode every 3 to 6 years. The centers of excellence now get a peritonitis rate of anywhere from 1 episode every 3 to 6 years. Now this is simply, I'll just run through. Wash hand before starting the PD connection. This is the table with the septic solution, clean it up, and once the connection is made, the person is running the PD fluid into the peritoneal cavity. During that time, person is free to do, read, eat, whatever the person wants to do. It's a time that can be well used while the infusion is going on. Now when the time comes for draining, again put the bag down on the floor and drain it out. So it takes on an average about 30 minutes for each steps to take. Inflow about 20 minutes and drainage about another 20 minutes. So overall about one exchange, inflow, outflow, takes roughly about 30 to 40 minutes if the catheter is working well. Then came the machine. Some people said doing manual during the day, 3 or 4 times a day, I spend a lot of time doing the exchanges only. And they don't want to spend that much time. So this machine was introduced which would do the exchange, inflow, outflow, through a pump, pushing the fluid in and draining through the gravity. Machine became very popular so that patients who wanted free time while sleeping, the dialysis exchange can go on. When you wake up, most of the dialysis is done. Then you run the fluid in for remaining 10 to 12 hours and you are free to do what you want. So a very small amount of time is taken with the help of machine. And this became very popular. And many, now the current around, I would say about 70% of the patients are using cycler to do their exchange. However, there are special indications for doing manual exchanges of CAPD. We'll talk about that in the next few slides. This machine is portable. If you want to travel, you want to go from one city to another for a vacation, for a week or two, you carry the machine and the dialysis fluid suppliers will deliver the fluid where you want to spend your vacation. And this is a bag which you can see very clearly. Fluid is very clear. You can read through the letters through this transparent plastic bag. As opposed to that, you can see this fluid is cloudy. The patient can look at this and say, hey, this is not normal fluid. This suggests there is an infection. And very quickly, a person will call the unit and get hold of the nurse so that the treatment can be done. And so there's a clear difference between a clear fluid versus infected PD fluid. Now, there is a complication where you see this very much more stronger cloudy fluid. This is not an infection. This is the chylous fluid leaking into the peritoneal cavity. You don't see this intense pussy looking fluid after peritonitis. This is the graph that shows the rate of peritonitis used to be one episode every 2 months, improved over time with the change in technology, improvement in catheter technology, and the way the fluid is infused. Now the current standard is 1 episode every, as I said, every 3 years, up to 6 years is being achieved. Now, when you perform PD, there are several different ways how you do the PD. You should know what are those, it's called modality, PD modality, CAPD, CCPD, and DAPD, NIPD, and APD. I'll explain to you what are these. Now, when you are doing CAPD, it's a manual exchange. You do typically 4 exchanges during a day. This is 1 day, and 4 exchanges are, you infuse the fluid, it stays in the peritoneal cavity for 4 to 6 hours, then you drain out. Then you do the next exchange, takes about 30 minutes. Infuse again, second exchange, then third exchange. Before going to bed, you do the 4th exchange, what we call as long dwell exchange at night, which is about 8 to 10 hours, so that the person can sleep uninterrupted. So this is 1 exchange, 1 day, 4 exchanges are done, and a person completes 1 day of treatment. Next day, same cycles is repeated. This is CAPD. Typically, you run 2 liters of fluid in and drain out, maybe depending on the fluid, anywhere from 2 to 400, 500 ultrafiltration. Now, many people don't want to do it. It's too cumbersome. In there, you introduce the machine. So with the manual exchange, CAPD, you do manually by gravity. But when you introduce the machine, when the person is sleeping, during the night time, machine does the exchange. But the time a person sleeps is around 8 to 10 hours. maximum maybe 12 hours. So during that 8 to 10 hours, person is sleeping, the machine will do the 3 exchange, which otherwise he would have done during the daytime manually. And before waking up, put in a fluid and leave the fluid in for about 8 to 10 hours. So that completes one cycle. So this is called CCPD, continuous cycler PD, continuous ambulatory PD. Now there are a few other modifications. DAPD, you do only daytime ambulatory peritoneal dialysis. That means person has the residual function and there is no need to do dialysis during the night because the residual kidney function do contribute to the PD. So therefore, during the daytime, either 3 to 4 exchanges are given. Now there are some patients who has a very fast transport rates. They are not able to achieve adequate ultrafiltration because of the nature of the peritoneal membrane. They are also specially indicated, they do short exchanges during the daytime and they can take a break at night. So this is called daytime ambulatory peritoneal dialysis. Nightly cycler dialysis, again, you run very short cycles during the night, 4, 5, 6 exchanges during the night, 8 to 10 hours, and then you achieve ultrafiltration and the clearance required. And the daytime is given free to this patient. Again, this is useful only if the patient has residual kidney function. Now, when you put the PD fluid in, what happens? Due to diffusion, this is the blood concentration of urea, and you infuse the fluid in. During the 4 to 6 hours, when the fluid is left in the cavity, slow diffusion of urea takes place from being a very low level. It slowly increases and the dialysis continues or the diffusion continues until the concentration of the PD fluid concentration and the blood concentration equilibrate. At that time, the diffusion stops and you need to do the second exchange. So therefore, that's why it's required 4 to 6 hours of exchange is done. You achieve equilibration and go to the next cycle. Now this is urea is the smallest solute that we measure, but creatinine is slightly larger than creatinine is slightly larger, so the equilibration takes longer. Here urea equilibrates in 4 to 6 hours, creatinine may take about 8 to 10 hours. So depending on the membrane type, it may take longer to equilibrate or shorter depending on the molecular size of the solid that we are talking about. Now the question is, who should be doing the PD? There is absolute contraindication is you cannot do PD is when the abdominal or peritoneal cavity is not intact. There is incision, there is when you put the fluid in, it will leak, so you cannot do it. That's the absolute contraindication. Now there are some other relative contraindication where either because of the hernia or obesity, there are certain reasons why it cannot be done. You overcome those barriers through surgery and make them fit for so that the PD fluid can be maintained in the cavity. Those, once you remove it, then you can put them back on silos. But the only absolute contraindication is that because of the lack of intact peritoneal cavity, you may not be able to put the fluid in that promote infection and you will not be able to do. Otherwise, in most of the instances, if the patient wants to do it, you should be able to do the peritoneal dialysis. Now, there are catheters. We talk about which catheter is the best. And my personal opinion is there is Tenkoff catheter is currently the most used catheter and it can be used in every situation. But what you require is a surgeon who is experienced and should be able to insert the catheter in the manner it is supposed to be, and you should be able to get it. There are other catheters which have been designed. They are more expensive with a special indication, but for an experienced surgeon, one should be able to put the catheter in all circumstances. So have a surgeon who knows how well to insert the catheter and stay with them rather than going after all the special catheters. Now, when a PD fluid is inserted into infused into the peritoneal cavity, not all solids come out equally. They're at a different rate, and there are different pores. Now, there are 3 pores which are in the peritoneal cavity: large pores, and there is a small pores, and the third one is ultra small pore, or what we now recognize as aquaporin 1. Now, aquaporin they are specialized water channels. So when there is an ultrafiltration and the fluid is taken out through the osmotic force due to glucose, through the aquaporin only water comes out. Small pores allow both water and solid to come out, whereas large pores, they are not very many. Convectively, the entire thing goes through, but they do not contribute significant to dialysis in PD. So when aquaporin causes ultrafiltration, sodium is held back, and that process is called sodium sieving. Like you are filtering out sodium, only the water comes out. That has impact on the ultrafiltration. I'll talk about that in the next few slides. When you write a PD prescription, in your mind, you should have an idea what you are prescribing. What are you going to prescribe for? Every patient has a need for certain prescription. But the basic principle is removing the solutes so that sufficient toxic solutes are removed and the patient becomes asymptomatic in terms of uremic symptoms. During the prescription, electrolytes will come out, potassium will be removed, sodium will be removed, bicarbonate will go inside, calcium will be equilibrated. So there are electrolytes and toxic solutes equilibrate and achieve the concentration that you typically see in the plasma. Now, next important function that we do during dialysis is ultrafiltration. Remove toxin is one part of the dialysis. Second part is you have to maintain fluid balance. Person has no urine output, is anuric, does not put out, but daily intake of fluid accumulates. So you have to remove the fluid along with the toxins. Now, this is the work that we did several years ago. I'll just explain to you what we are seeing here. This is the 0 time when the PD fluid is inserted into the cavity. That fluid contains very high concentration of glucose. It induces crystalline osmotic pressure. And so at the time, immediately after the fluid insertion, there is a very high rate of ultrafiltration. That high rate of ultrafiltration continues. While this is going on, the glucose is being absorbed. So the osmotic pressure induced by the glucose gradually reduces and ultrafiltration rate diminishes. So very high ultrafiltration rate diminishes the ultrafiltration as the time goes by, and eventually the glucose equilibrates that with plasma and the ultrafiltration stops. While this process is going on, remember I mentioned earlier, there are two types of pores which are involved in the removing fluid. One removes through aquaporin water only. The other one removes water and solutes depending on the size. So now here you see in the background there's a blue color. Imagine this being a peritoneal cavity. Imagine this is a peritoneal cavity. There is ultrafiltration is going on at a very high rate. Now the ultrafiltration occurring through aquaporin and through the small pores, roughly approximately about 50% through aquaporin, 50% through small pores. Now the fluid, water that is coming out without solute will dilute the solute in the PD fluid. Now PD fluid has the sodium, it has some glucose and other electrolytes. So the net ultrafiltration that comes out in the beginning is a combination of hypotonic or water plus isoosmolar ultrafiltration. So net effect is hypotonic ultrafiltration during the first few hours. Now as the ultrafiltration rate diminishes, there is a diffusion of sodium by concentration gradient will come out. So now you'll see there's a very light blue color here. As the dwell time continues, as the sodium comes in, here the ultrafiltration, net ultrafiltration is hypotonic to the plasma. Hypotonic. Not hypoosmolar, hypotonic, hyponatric. Due to water only ultrafiltration, it causes hyponatric ultrafiltration during the first 2 hours. So you see the light color gradually increases as more and more sodium is coming out. By the time the equilibration takes place, this is now isonatric. So by 4th, 5th, 6th hour, the PD fluid, if you drain out, would be isonatric, but depending on the concentration, osmolarity will not be same. So you have to remember here, how many hours you are keeping the fluid in the peritoneal cavity. First 2-3 hours, hyponatric fluid. As the time goes by, it slowly equilibrates, and by the time you reach 4, 5, 6 hours, it becomes isonatric. So therefore, it is very important that you need to know the fluid that you are removing here based on the ultrafiltration. You are putting 2 liters of fluid in, you are draining out say 2500. There is a 500 ultrafiltration. That ultrafiltration in the beginning 2-3 hours is hypotonic. That means more water came out than the solute. So the sodium in the plasma becomes increases the concentration, and that also in the subsequent 2-3 hours slowly diffuses back, and the fluid here is isonatric. So the 500 cc's of fluid ultrafiltration that you generate here has about 50% of the concentration of plasma sodium. So you are removing here, when you drain out, water plus sodium. Here water but less sodium. Here very less sodium, so the body is retaining sodium. So this is very important to know what is the duration of dwell that gives you the amount of fluid removed with isonatric or hyponatric fluid. So this is an important concept that you remember. Now, based on the peritoneal equilibration test that we introduced almost 30 years ago, we were able to divide the peritoneal membrane into 4 different types: fast transporter or high transporters,
average transporters within that high and low, and very low transporters. So it classifies patients into 4 different types. Fast transporters will exchange solids much faster than other 3 types membrane. Low transporters will transport very low. Now remember, when solid is coming out, like creatinine, urea, at a faster rate, the glucose is going back into the system at a faster rate. So the ultrafiltration generated would be lower for a duration of say 6 hours compared to a person who has a low transporter. His glucose stays in the cavity for a longer period of time. Aseptic way of performing PD is the key thing, and based on all the technology that has been improved, improvement in the peritonitis rate from as I mentioned earlier, 1 episode every 2 months to 1 episode every 3 years. So that has made peritonitis now pretty safe as far as doing the dialysis. At one time, infection was the major problem, and we still called it Achilles heel of PD. Nutrition, allowing the patient to take sufficient nutrition, protein. At the same time, when you take more protein, there are more phosphorus is generated, and the phosphorus will go high. So combination of good nutritious food with phosphate binders will allow a person to have a near normal protein and good phosphorus control. This has to be every clinic visit they come in, you have to review it, make sure the patient is compliant with your prescription and taking the protein you are prescribing, and the phosphate control is maintained. Monitoring adequacy of dialysis is very important. Don't focus only on KT over V. KT over V will tell you what is the quantity of dialysis or the efficiency of dialysis you're giving. It's the KT over V is the notation for clearance over a period of time, over one day, 1 week, whatever it is. But focusing on that alone, you lose track of other things. You have to control the blood pressure. You have to control the blood pressure control, salt removal. You need to be concerned about the calcium phosphorus metabolism and the mineral bone problem in dialysis patients. So adequacy includes not only removing the toxic solutes, controlling the water, maintaining blood pressure, taking care of the mineral calcium bone issues, and overall patient's well-being. So when you talk about adequacy of dialysis, it does not stop at KT over V. That's only one of the parameters that you have to be concerned about. Now there are some practical considerations that I will tell you based on the experience. When you want to increase the dialysis volume or increase the ultrafiltration, what are some principles that you should remember? In an adult patient, about 30% of the patients may tolerate up to 3 liters of fill volume during CAPD. Standard is 2 liters, but if you want to increase the clearance, you want to infuse 3 liters, approximately about 30% of the patient will tolerate 3 liters. But there is a price to pay for when you increase the volume. Higher the volume, more chances of hernia development or fluid leaking at weak sites. Like if a person had a prior incision, the fluid may leak through the incision. So the higher volume will increase the risk of hernia formation and fluid leak. More than half will tolerate 3 liter fill volume during supine position. A person is lying down, increase in intra-abdominal pressure
is lower than when the person is upright and walking around. So if you are using a cycler and giving with the cycler you want to increase the dialysis clearance, you can increase the volume up to liters. There, in a supine position, more people will be able to tolerate higher volume compared to a person in an upright position. Patients do not like 5 exchanges. Now you have a patient who is doing 4 exchange and he's not meeting the clearance standard. You want to increase the dialysis, you can increase the number of exchanges to 5 exchanges per day. But generally, patients don't like it because you can imagine a person is doing 3 exchanges while awake and before going to bed, they do the 4th exchange. Many patients come and say, "Hey doc, I cannot keep on doing exchanges all the time." So they want some free time, the quality time. You want to improve it. So if that happens, you should bring in the cycler and take away the burden of doing manual exchanges. If you are using a cycler, most patients will tolerate up to 10 hours per night. If you increase more than that, they won't be stuck to the bed for 12 hours, 14 hours, 15 hours. Very few people can stay in the bed for that long. So tolerance is anywhere from 8 to 10 hours attached to the cycler during the night. 12 hours per night is possible, but very few patients will like it. Daytime exchanges are accepted easily. 3 liter fill volume gives about 10% lower DORP creatinine for an average transporter at 2 hours, but clearance is 36% is higher because the volume is higher. Now I mentioned in the introduction, PD is a teamwork. It requires a multidisciplinary approach. You have a nephrologist, you have PD nurses, you have dietitians, surgeons, social workers, and most importantly, patient and his family. Never ignore a patient. Patient is the one who is doing the treatment. You may give all the education you want. You have to take patients, empower the patient. Training, retraining, psychosocial support, and shared decision making is the key to long-term success of PD. Empowering the patients to self-manage, recognizing red flags, and maintaining confidence is often more impactful than any other prescription talk you can give to the patient. Now in the next few slides, I will show you how empowering the patient that to the extent that you go out of your way to meet the patient's requirement, because a patient is the one that eventually want to live the life that they want. You help them, they should not follow your guidelines or your limitations. You help the patient what patient wants it. This is an example of a patient that I managed for 13 years. She was a type 1 diabetic. She started doing CAPD, and prior to starting CAPD, she and her brother and few others, they are a team of people who used to go for hiking along the Rocky Mountains. Rocky Mountains is southern border of USA, all the way up to Canadian border during the summer months, 6 months. She would walk along and along with her friends hiking in the mountainous region, and she says, "I will accept you as my doctor if you help me continue my hobby of hiking." So we had a group meeting of all the people involved, including the dialysis fluid provider. He said, we have no problem. We'll supply the fluid to the person. But the biggest question is, she's hiking in the mountain. Where do I find her? This was, she started this about 1986 or 87 for 13 years. At that time, there were no cell phones.
reaching somebody on a mountain trek is almost impossible. He says, how do I find? Then we brainstormed and whatnot, then came up with an idea that she does the CAPD, she empties the bag, she says you throw the bag on her route, and the driver taking the fluid supplies will find that bag and he'll find the next bag, and eventually they kept doing that for 10 years, providing her to continue her hobby of hiking. This is what is called going out of your way to meet the patient's need. Now, being a PD, which allows for home dialysis, there are other professions where doing hemodialysis either may completely take the person out of his regular profession, may have to find either give up, retire, or may not be able to do the hemodialysis. Whereas PD, here is an example. This is his name is Mukunda Swami, a commercial pilot on CAPD. For about 6 or 7 years, he continued to do CAPD while flying. So in one of your flights, maybe he was the pilot doing CAPD while this is going on. This was possible only because of PD. This would not have been possible if he was doing hemodialysis. Either he had to find another way of flying, or this empowers. PD will allow you to empower the patient what they want to do. Now, another story. This Swamiji in the neighborhood of Nepal, he was doing PD in this gufa. He was wandering around in his own and continued to do PD, CAPD. I had another patient who, one of my relatives who lived in Himachal Pradesh, in a place called Chamba. Most of you probably know from the movie Tal. In that city, 84 years old, she did CAPD for 2.5 years. In that almost 12,000 feet high mountain place. This was possible because she wanted to stay with the family. PD can achieve what, if you go out of your way, try to help the patient, empower the patient, you can achieve what you want. And this is what the secret of PD is. That's it for today. Thank you very much for listening to me.
Thank you, sir. As always, it is a privilege to listen to you talk about PD. For lack of time, we will proceed with the next session, but we thank sir for joining, and we really wish that you were here. I know you wanted to come, but due to unavoidable circumstances, you couldn't come, but thank you so much for joining us, sir.
If you give me 1 minute, I want to make a statement.
Sure, sir, sure.
When I was here almost 50 plus years ago, 1967, as a fresh medical graduate, I became a resident here. Professor Raghavan, he was HOD, head of the Department of Medicine at that time. I don't know why he called me and said that I want you to become the first house physician for AKD. That's when he started the new department, artificial kidney department, on the second or third floor of the hospital. And I was the first house physician. In 6 months, he promoted me to the registrar, and by the end of 2 years, I became the senior registrar. And I want to thank Professor Raghavan for having the vision in 1967 to set up an artificial kidney department, which has flourished and has become one of the premier institutions not only in India, and all over the world. And he also had the vision to pick his successor for doing dialysis in Madam Professor Acharya. And I'm very thankful to both of them for mentoring me, and what I am today, I owe it to them. Thank you very much.
Thank you, sir. So we'll move on to the next session now. DM की डिग्री तो मिल गई, बट कॉर्पोरेट हॉस्पिटल में इंटरव्यू के लिए गया था तो बोले कि 3 साल प्राइवेट प्रैक्टिस करो फिर ही जॉब के लिए लेंगे। तो पिछले 3 महीनों से पॉली क्लिनिक में ओपीडी कर रहा हूं, बट पेशेंट नहीं, सिर्फ इंस्टाग्राम रील्स देखे जा रहे हैं। पर कल ही एक पेशेंट आया और पेशेंट देखा, तो अगले दिन आज फीस लेने गया तो मुझे 70% ही मिला, 30% गया किधर? ये सब तो KEM में नहीं देखा था। I'm sure all these questions and issues haunt almost all early career nephrologists, and to decode this for all us young minds, we have a panel discussion specially for this on the tricks to build a successful private practice. I welcome panelists Dr. Siddharth Lakhani, Dr. Swati Mane, Dr. Sunil Javle, Dr. Ashwati Haridas, and Dr. Anwar. And to moderate this session, may I call upon Dr. Vaibhav Keskar.
So this is going to be a fun session, and mostly for this half, I think. And there is a difference between previous sessions and this one. You can see less gray here, if you notice. So my mandate is to talk about top 10 tips to build a private nephrology practice. When this topic was given to me, I wondered why I'm chosen. Probably they wanted expert lecture, but in reality, this session will be about disasters and things that we would hope we would know before we started our practice. So before I start, let me introduce the eminent panelists. So let me introduce myself. My name is Dr. Vaibhav Keskar. I am a 2010 to 2013 batch. After that, I was here for 1 year, and then with Dr. Swapnil Hiramat, who is online with us in Canada, and for last 7, 8, 9 years, I'm in Thane and Mulund. Can I request my panelists to introduce one by one?
I'm Dr. Anwar. I practice.
I'm practicing in Bellary. I'm basically professor of medical college and also do private practice there, which is allowed in our state. I'm practicing since 2010. I'm Tukaram's batchmate.
Okay, that's the most important line in the introduction.
I will also add that. That's a good thing. So I am Siddharth. So 2013 to 16, I'm practicing at present at Ghatkopar as a private practitioner, and I'm Divya's batchmate.
Dr. Swati Mane. I am 2012 to 2015 batch, and I am currently practicing in Pune, Jupiter Hospital.
I'm Dr. Sunil Javle. I was here in KEM from 2011 to 14. I'm right now in Pune, attached to Apollo Hospital. I was junior to Vaibhav Keskar. That's what everybody tells me.
I'm Dr. Ashwati Haridas. I'm practicing I was here between 2014 to 17, and I'm now in private practice since 6 years. I'm at Apollo Hospital, Navi Mumbai, and I have my own clinic there as well.
Okay, so once we are out of medical college, the first thing that comes to our mind is practice chalu karna hai. If we are not in KEM, we need to find out a place to work. So where to practice? So can I ask Anwar sir how he decided where to go?
Because I was native of my own Brahmila, I did my MBBS MD there in the same medical college, and there was opening also. So government job in a 3-tier city will be decent. And then if you are allowed to provide good private practice, that will be enough to gradually develop practice there.
Okay, that's very important. So, first thing is we have to identify where we want to settle down and also see where there is unmet need for a nephrologist there. You look at social support also and you look at your lifestyle also. But I think the last one is the most important thing for boys. Please make sure you do that. So we have Swati here. So Anwar sir he knew मुझे बेल्लारी जाना है. But Swati has a different perspective.
So my journey was actually disaster. So I initially thought ki I will go to Amravati where I will get more family support and my practice will be better. But somehow I was not satisfied. Anyway, after experiencing KEM and after working in KEM, it is difficult to find a perfect place to work. Then I moved to Nagpur. It was definitely better, but still I was not happy. And then I went to CMC for fellowship, and then finally I have settled down to Pune. So I think sometimes, or some people might find their destination after taking too many experiences.
And that's valid. That's very important. You learn with your experiences. One rule is, Dr. Billa actually told me this rule, 1,000 days. So it's a rule where you do not repent or change your decisions before 1,000 days. You have to work for those many days. If you fail after that, then you revisit. Yeah, is this place not good for me? Not. So if you imagine a place where you are still working 5 years, 10 years down the line in your mind, that's the place you work in. So yeah, so Dr. Anwar decided to go to Bellary and found himself as first nephrologist of the town. So let's hear from him. What are the challenges? How he set up his practice there?
Basically, when I went there, the only place where dialysis was available in government medical college. I was lucky that there are already 10 machines are there. So working there was not that difficult when suddenly 10 machines is there. But private practice, only non-dialysis dependent practice was started. And some clinical nephrology like nephrotic syndromes and all. Difficult cases, again we had to admit in the government medical college and do practice. So it was non-dialysis based practice initially. Okay. And cross-reference from the nursing homes and all those things, small hospitals.
Right. So wherever you go, first you have to see what existing services are present, their state, like if you can handle a sick patient there or not. You have to develop your own ecosystem there. You have to train your nurse, you have to train your dialysis technician. If there is no dialysis unit, you have to somehow connect to people who know how to set it, and that's how you want to proceed. The next important thing is finding a mentor. A mentor could be your PG teacher, could be your roommate, could be your junior. Few of my mentors are sitting here. They are my juniors. So, and you need not have one single mentor. So you can have one mentor for your clinical queries, one for your financial things, one for, in general practice things. He or she may not be a nephrologist, but you have to find a mentor. Can I ask my panelists how they find a mentor, or what is their practice? Sunil, can you take this question?
Basically, when you go out of a medical college, when you are in a medical college, you have so many options. You can call sir for all academic support you want. But when you go out, first 6 months are the time period when everybody evaluates you, what kind of opinion you are giving, and how the patient recovers. That is the time when the initial part of your practice develops. So the academic mentor, I think I have troubled Tukaram sir, Vaibhav, Manjunath a lot during that period. I used to call them left and right to know everything should be in place, and that opinion will be seen by a lot of people. And that is how your practice goes. So for academic support, definitely, I think I'm very thankful to all my seniors for this help. And when you go, another mentor, we have not written this, but when you talk about mentor, there are mentors who tells you where to go, how to do practice, whom to meet, and how to develop practice, basically.
Right.
So I was very fortunate that there were my teachers were there, whom after passing out, I met them. They were nephrologists, they were physicians who told me, you practice in this area, you go and meet these people, you go and ask for attachment to this. Yeah. So that is how the practice grows, actually, I think.
Right. And you have to choose your mentors wisely. So don't forget that. So next question is what kind of practice you want to start. So there are several models. You go solo, you go in a group, you go as a full-timer in a big corporate hospital. So most of us land up doing something called as freelancing. We set up a clinic, or we rent a clinic, or we sit in a polyclinic and we go and meet all the nursing home owners and hospital owners and tell that, look, I'm from KEM and I want to start practice. Please call me if you have any patient for me. And at some point of time, I used to travel almost for 70 to 80 kilometers in a day to see 5 or 6 patients. This grew, so my car was obviously unhappy with me. I used to drive for almost 120 kilometers a day, but this was not sustainable. This is a perfect recipe for burnout, as Ashwati rightly told me some time back. And consolidation is the key. So Ashwati, do you want to tell us how you consolidated your practice?
I think initially in the first few years, when you just come out of the medical hospital and then you join private practice, the only way to set up your practice is by freelancing. So there are many other options. I mean, you can join a corporate hospital, but when you're actually doing freelancing, the patients you get later on, when they come to see you in your OPD, they are your own patients. And it is not completely dependent on the hospital also. So first 2 to 3 years, I think freelancing is very important. And it's only after that that you can, start consolidating your practice.
Right. So पहले झंडे गाड़ो, बाद में एक जगह पे रुक जाओ. Okay. So, but in corporate hospital, there is something called as corporate insecurity. Insecurity in a corporate big hospital is often exaggerated, and not all corporate hospitals are bad. But are there any tricks to overcome this problem? Sunil, what do you think?
Basically, when you go to a corporate, you always have an insecurity. But I will tell you I met one nephrologist because I went to a corporate for an interview. They told me to meet the nephrologist. So what he told me was, that was very fair. He said, you have come here. So you are not going to take my patients, or nor I am going to take your patients. So when you come to a department, the department is going to grow. That is how it should be. The corporate insecurity, that day I felt you should be part of that department, and then only that department goes. There should be no insecurity between the colleagues.
Yeah, Swati, do you want to add to this?
So I agree with Sunil sir. And second thing, there is advantage of developing group practice in corporate hospital. You can take holidays, which might be more peaceful. Then in a complicated cases, you can take second opinion, which might help to handle the difficult cases. So I think it should not exist.
Yeah, that's true. So one way to go about is, if you are a full-timer, please try and develop your own OPD so that you know people, you develop your own referral networks. This clinic will give you a bit of autonomy, and that will be enough to overcome the insecurity. So the most important thing when you start your practice is, do not forget about ethics. In KEM, when you are on duty, when you are a lecturer before you leave, you always do ethical work, and we take a lot of we take pride in our work. So there is no reason for us to quit that practice. Anwar sir, do you want to talk about this?
Yes, this will help you in bringing your private practice for long term. You can have, I have some patients who are following me since almost 15 years.
15 years.
Because initially they felt that I am very telling the full facts of the disease, so this needs long term follow up, and financial capacity. You must be very ethical in that. You must give them full knowledge of the disease. Suppose the patient is not affordable, you can give him options of getting dialysis done in the government schemes also. You must not feel that he is being burdened by just being in private practice. Because if he will have a tense situation that how long to sustain this, if you have to give him all the options available in the government schemes also, that he should not be initially burdened that if he gets into more sick state, he can have other options. So that he'll be a long term this. And some patients come to me from almost 300 kilometers because one patient had gone and didn't come back with it.
Right, right. So in private practice, competence brings the patients and character keeps them. One ethical lapse and that can undo years of good work. So this is very important. And that brings to us to your USP. So as a brilliant student, you have certain strengths, but as a practitioner, you have to develop certain points of strength. So it could be interventional nephrology, like previous speakers told us, peritoneal dialysis or ultrasound, your behavior, the time you give to the patients. These can be your USP. Nurture them and do not ever quit them, because these are the things which are helping you to grow. Once you are busy, if you leave quit these USPs, it is not going to make any sense. Ashwati, you want to tell us anything about your USPs that you value?
So I think these are all, this goes across all professions. I mean, you be sincere, you be authentic, and do justice to your patient. But apart from that, also do justice to the person who has referred the patient. I always believe in giving feedback as well to the person who has referred the patient. I've realized that helps in, even fostering trust and long-term relations with the referral as well.
Right, unless you call the physician who's referring the patients to you, how would he or she know that you know your stuff? So that's very important. So next thing I would like to tell you is OPD. We always focus on ICUs, ICU rounds, ward rounds, admissions, but the backbone of private practice is OPD. If your OPD is strong, your practice will develop. So pay attention to your OPD. It requires a different skill set. It requires a lot of patience. So make sure that you invest that much time in developing your OPD. So there are certain strict no-nos, and we learn these no-nos very hard way. So I wish every nephrology pass out should learn these no-nos before even they start practice. Some of them are enlisted here, but do our panelists have any views of strict no-nos? Siddharth, do you want to start?
So I think practice-wise, a lot of discussions on how we go about. So strict no-nos is, of course, with time, if there's 1,000 days discussion happened, everything has to go and happen in a certain amount of time. You have to give that much amount of time, whichever is required. At start, you will be given a lot of opportunities where, like Dr. Vaibhav said, you will be asked to call a hospital which is probably very far off and there is no one there. Or you may be the third or fourth choice. One person not there, second person not there, third person not there. So with time, you have to select whether you really want to travel that place every time. So if I am selecting a place where I don't wish to travel on a long, you should be the fourth one to say a no. So it may happen that, oh, my losses are there, but probably that may not help because you don't want to build a relation there. So selecting a place is very important. OPD, as rightly said, yes. So if you want to develop a practice, there will be a place probably where You will have to be available, fixed time available wherever you are there. So a lot of us probably in that rush of running around, forget probably that's common to all of us. 8 to 9 here, 9 to 11 here, 12 to 3 there, and 5 to 6 at some other place. That's common for all of us to start with. As a freelancer, we feel probably that's the model where we can utilize more time and more hospitals. But consolidation and coming to one place where patient realizes that you are there here. You have to sit for some time, probably idle without patients. So making and consolidating at one place with time will help. And developing protocols and probably practice at one place. That is again one important part. You'll have to select an hospital or an area, whether it is yours or with someone else, where you want to do what you want to do. So if I want to put a dialysis catheter with this amount of things or with this protocol, I have to teach that staff there. Once I do them, then they know that. Every time jumping from one hospital to other hospital for putting a catheter is not going to develop an SOP. That's where probably every time you go, you will probably either end up puncturing something or not doing the procedure as you want, or not doing the dialysis probably as you want.
So you have to learn to say no. Is that what you
Probably
imply?
selecting places will be very important again. So wherever you feel this is not going to develop your SOPs, you will have to say no. And select out places and practice model which you want to do in future. That will again be probably what is there. If a corporate hospital approaches you, if you're not a corporate person, you will have to say a no. So again, that is an important no probably, which as a practice pattern or a person, you will have to decide what you want in future.
So let's talk about one of the most important things. When I started my training, I only knew a few handful of lady nephrologists. But the things are changing now. We have more and more girls opting for nephrology. And I think gender bias is a real thing here. So may I ask Swati if she has experienced gender bias and how she has overcome it?
So definitely gender bias exists. So I will tell my two experiences. In one hospital, when I went for interview, they asked me first question, have you completed your family? So fortunately at that time I had completed my family, so they offered me job. In another hospital, the CEO asked me कि I will have to go for peripheral outreach OPDs on Sundays, for which I was not ready. Anyway, I am not ready even if I have kids or I don't have kids. But at that time I told the reason that I have a small kid, so it is not possible. So they didn't offer. But fortunately, I got good experiences also where they did not ask my personal responsibilities. And I feel family responsibilities or motherhood is not equal to lack of commitment. In fact, personally, I am far better practitioner after experiencing motherhood. I handle the difficult situation with very calm attitude. So this is my personal opinion. Thank you.
Ashwati, do you want to add?
Yeah, I completely agree with Dr. Swati. I think there is definitely a gender bias, and in the context of private practice, I think women are kind of excluded from these informal networks, where a lot of opportunities come up in medicine. I mean, we're not part of, the post-work get-together or WhatsApp groups, and nephrology being a very referral-driven practice. So, I mean, that's one thing that, you certainly, you tend to miss out on those opportunities that are predominantly informal, network-driven. And the other thing is, this is worse when...
Ashwati, is there any way you can overcome this?
So I think it just gets better slowly and over some time. So very early in my practice, this must have been the second or third patient that I saw in my private practice. As soon as I entered the patient's room, the first question I was asked is, oh, are you the dietitian? I said no. Then the next question I was asked is, oh, then you're the physiotherapist. I said no. I mean, before I would utter anything next, then you must be this doctor's assistant. So that encounter kind of left me feeling very shaken. But the good news is that this gets much better over some time. And what happens is later, once you start communicating with other practitioners, regarding cases and everything, even if you're really not a part of informal networks, but then you still, earn that kind of respect, and it
Right. You
gets
can
better.
overcome that barrier.
So I think we have to prove ourselves.
Yeah, prove your mettle.
Yeah, so in my hospital, initially there was a little resistance to give me reference, but now people know, okay, I'm available. Whenever they give call, I see patient on time. So this gets better with your practice and your availability.
Right. So, ladies, please know that this bias can be overcome. In last couple of minutes, again, I must mention social media before I close. Social media is now a thing of the day. No one can be away from social media and practice nephrology. It's very important for your visibility, educating your patients, and networking. But don't use it to impress anyone. You can use it to inform your patients, but never use it to impress, and never discuss cases casually online. Make sure that you hide the identity of the patients. Also control your dialysis ecosystem. Some of this discussion has already happened, but I'll skip it. But you must ensure that you are the person in charge of your dialysis unit. And the last but not the least, financial health. While practicing, this is the most important thing. If you are financially healthy, you'll stay away from many headaches. Uh, we have do we have expert here? I think we see one expert. Siddharth, do you want to talk about your financial health or how you do it?
So probably financial wise, I think there are a lot of people probably who are doing much better. We have seniors, but yeah, probably as a younger part, I will say. So one thing is probably we have to start learning administrative stuff on our own much earlier. We understand that much later. On that run of running every day only for seeing patients and understanding, we forget that accountability part. Second, as probably the discussions of dialysis sessions which was going on, what I have understood with time is you need your own place where you can dialyze, where you are more available, so that patients become more comfortable with you. And it's like a chronic familial thing. Once they are there with you, they remain with you, they come and get admitted with you. If I'm practicing here and if someone is taking dialysis somewhere, the patient may not come back to me. So that is an important part in the financial discussion. Some risk you will have to take with time, where probably how you want to grow, as I was discussing earlier also. So that practice model of financial things will be whether I want to become a corporate person where I want to have a fixed 9 to 5, 9 to 6 place and have a practice. I want to probably freelance and run around, or with time I want to become a private practitioner with some entrepreneurship. So these three things probably with time will have to come. Most of us are probably practitioners with entrepreneurs where we have some or the other systems. It's the only time is when you want to start. So probably that decision you will have to take, which will help you out. And always probably make a team of yours. It may not be necessarily probably only nephrologists, but once you train your team, your works will be much lesser. So though it may be a financial burden on you at the start, but with time as you go ahead, a lot of other works of discussions, dieting things, probably like simple things of going and getting tested, where I think all of us must be facing how to do a 24-hour test. So if you have trained someone with time, you probably waste a lot of less energy, where you don't have to tell them, explain them everything. Addresses, as probably social media, this day is probably the generation, before coming to me or before coming to you, patients will always read what you are, where you are. It's not possible that they will not see. So wherever possible, make a presence of yours where at least they know what you are, what degree you have achieved, what work you are doing, where you are available. Simple things, doesn't need probably an expansion of this. And of course, making a team, and probably with time, as all of us are doing, somewhere or the other, teamwork will help. If you're not in the corporate world, if you want to practice in the private world, probably, or the freelancing world, you'll need to make your team like-minded people, which will help you probably to grow. At the start, probably like I think Dr. Gunjotikar and this were telling it, probably there will be revenue sharing or there will be this, but that's how it's going to grow. If I'm going somewhere for 5 days, I'm going to lose that. If I have a team person, the team person will take care of things.
Thanks,
So-
Siddharth. And we have one comment from.
Finances,
Hmm.
from personal experience, I didn't listen to Dr. Dedia. Many times he told me investment, streamline your investment, start it now, and so that it helps you in later life. My father always made me save something, and that helped me. But over a period of time, your day-to-day practice, you tend to ignore that. So I think it is you should start saving and streamlining your investment very early in your life.
Right. Thank you, sir, for that
And
comment.
you can contact Dr. Dedia for that.
Yeah, so let me sum up. I think we have heard this all. So I open this forum to all our seniors. Please tell us what you think we should know before we start the practice. Please, sir.
One is, please read the small book known as E-Myth Physician. It's available on Amazon, and it will change your understanding of practice and what we need to do. And secondly, do visit Renal Physician Association's website and material available on the net. That's the Association of Nephrologists in America, who are practitioners and not academicians. And they talk with some things which are very relevant to us, including a draft of the thank you letter to the referring doctor. What should be included, what should not. A lot of materials there.
Thank you.
Renal Physician Association.
Yes.
I think one message which we should give to the younger nephrologists is to develop excellent communication skills, not only with your patient but with your colleagues and with your other specialists with whom you are interacting. And if you develop that, I think patients also develop confidence in you, and the other colleagues also, they feel that you are knowledgeable enough. So I think this business is probably self-taught most of the time. But I think in the curriculum itself, I think there should be a part of communication skills. So when you go out, you are well trained for that.
It's a very important point. With this, if there are no comments, I think we conclude. Are there any other comments, questions? Sir, please.
Now, this is not an advice, but I'll just share what I did after entering into my practice. Like when I was doing residency, I had, I used to call Sir, Kalpana, Madam, Nitin, Jatin, Sanjeev, Ravi, anytime whenever I had any difficulty. When I went into the practice, then I had the big question, like the mentor thing, you said that what you should do. So, like, whom should I ask now? So what I used to do and what I did, and in fact, even I do it even right now also in my practice, in difficult cases, I imagine dialing 2061 during the daytime and dialing 2735 after 6 p.m. and revise the case in my mind as if I'm telling Sir that case and what Sir would have advised me. So that's why every time when I meet Sir, I touch his feet, even he must not be aware that I'm doing that. So the teachers are always with you.
Yeah,
So when you go back in time, you remember that this was his advice, and then all the confusing things go away and the path becomes clear.
Yeah, that's a fantastic hack.
I always remember Dr. Allen's word, whatever you have written is the evidence available. So always write on the paper whatever you have seen. So in the court of law, that is the evidence. So if you want to save your skin, write down whatever findings you had and your opinion on the paper.
Thank you.
One little thing, something that helped me, which I want to share with you. Detailed notes and embrace electronic health records. Patients watch you doing this, and they realize the amount of pains you're taking to document everything that they have. And there's a sense of security they feel with you. And once you give them their prescription printout or you mail it to them, they feel next time I don't have to get my huge file there. This man has everything.
Right.
And they'll keep coming back to you. There's a sense of security they feel when you take care of it.
EMR is very helpful.
Yes, evolution in practice, like what we learn in 3 years in PG days is just a confidence, because every day in practice is a new learning. Every patient is a new patient and new challenges we face. For example, Bijapur, I was the first nephrologist, but for 10 years I was a like this one. Now 8 nephrologists are there in the same city, same place, but still we all practice this one. But I evolved my practice now because they send me a patient of difficult fistula, like difficult cases, and like my new initiations have come down, but my practice has not come down. I'm still busy. Because that is what OPD is very important. Giving time to the OPD patient is very important, and we need to learn every day, because every day is we think any department, nephrology or any branch, we have to evolve. That is one important suggestion.
Thank you. So I think we'll close this session. Thank you for inviting us today.
For this last talk, I want to call upon chairpersons Dr. Manjunath Kulkarni, Dr. Avinash Chaudhary, Dr. Niranjan Kulkarni, Dr. Mustafa Khokhawala, and we have Dr. Swapnil Harimat, esteemed alumnus from Ottawa, a nephrologist, an epidemiologist, and an NFJC co-founder, and now also the editor-in-chief of KI Case Reports. He will be joining us on Zoom, and he will be talking upon top 10 neph stones of last year.
Am I okay to begin? Okay, excellent. Yeah, awesome, thank you. Good evening, everyone. It's morning here in Ottawa, so thanks for the invite. So my specific journey, of course, at KEM begins in 1991. I was a lifer. I was in this MLT in 1991. Entering MBBS, and I stayed at the Naiga hostel. I don't know if anyone went there, but I was lucky that in my second MBBS I saw Vipul Chitalia, who was a post-MD registrar going into nephrology. That's when I first heard the word nephrology, and during my MD with Dr. Medekar in Ward 12, I was fortunate to have AKD registrars like Sanjeev, Jatin, Nitin and Prakash, and they inspired me with their meticulous care that this was something really worth doing. And of course, Alan was my teacher from 2000 to 2003, and I stayed on for a year like many of us, being a registrar and lecturer before Alan pushed me to go abroad, and I went to Ottawa and I've stayed there ever since. The objectives that Tukaram and the team gave me today was to showcase some new science, mostly trials from the last few months. and some key lessons that we can draw from that for practice. And I'm going to cheat a bit. There are stories, so I'm grouping some multiple trials under one category. So give me some license for doing that. So these were the top 10 stories that were selected by the NEFJC team, but I'm not going to select these. These are the ones that I'm showing you are going to be my specific idiosyncratic choices. So I'll go from 10 to 1. So the 10th story I will tell you is that the global burden of CKD that was published in Lancet a few months ago. And we should be happy that they have tackled obesity, they have tackled cancer, they have tackled hypertension and heart disease, but this is when they actually went to kidney disease. And this is a heat map which shows the extent of CKD over the world, and the paper is really worth reading for all the details. But globally in 2023, about 800 million adults have CKD, which is about 14%, or about 1 in 7 people who are living with CKD. And the prevalence is actually highest in the MENA countries, in Middle East and North Africa. But if you look at the absolute numbers, not the rate, they are of course highest in China and in India, where we have 138 million people with CKD. Now, of course, you have to be careful because what is labeled as CKD is mostly CKD stage 1, 2, 3, not necessarily the ones that we care about, which is CKD 4 and 5. But the other interesting part is that the higher income countries, and this is color coded here in this graph, they have a lower prevalence of CKD than lower income countries. But despite that, probably because of access, they have a higher proportion of them who are on dialysis and transplant, which reflects the underlying health equity and access issues with care. And going with the top 10 theme, what has come, of course, is that CKD has made it, it's a dubious honor, we have made it into the top 10 causes of death. For the first time in 2023 and onwards. This is of course again because of the increasing prevalence, especially in China and India, where the numbers are really high, which is why we have made it into the top 10. It is dubious, but I think it is useful when you go and talk to policymakers and health policymakers and ministers saying, hey, more money should be spent on CKD. So this is a useful statistic to show to them that we really need to pay attention to CKD. Moving on, this is one of my favorites, is that people talk about this chronotherapy, which is, giving medicines at different times of the day, and it makes absolutely no sense. This was, of course, because of the Spanish group, which showed this fantastically implausible data. The reason I say it does not make any sense is that pharmacologically, we mostly use long-acting drugs like amlodipine and so on and so forth, and they don't really, for them, the time of day does not matter. It's a different story for something like statins. But for long-acting blood pressure lowering drugs, whether you take them at morning or evening or afternoon, it doesn't matter. What's important is that you remember to take them. So these and there were many other problems apart from the pharmacology with these trial, but the time was of course a couple of years ago, which showed that there was absolutely no difference whether you took the drugs at morning or evening. And this came out in 2025 called the BEDMED trial. It was a Canadian trial with about 3,400 patients, and they with a follow-up of about 5 years, and they showed that whether you take the blood pressure drugs at bedtime or in the morning, there's absolutely no difference, with a hazard ratio of 0.96 for cardiovascular outcomes. There was no difference in anything at all. So it doesn't matter. You should take the pills when you remember to take them. But remember, of course, that they did do an ABPM in a small subset, and they showed a small difference in blood pressure at night. So I think what is important is not that the blood pressure drop doesn't happen. It's that nocturnal hypertension is a very complex phenotype. It is because of, some people have diabetes, they have chronic kidney disease, they have volume overload, they have sympathetic hyperactivity. So just taking a pill at night doesn't solve this underlying chronic, complex pathophysiology. So don't do this. Tell patients to take pills whenever they remember to take them. This story is a little bit complicated, so let me explain it or belabor a few slides to explain what I mean. And you will all roll your eyes saying, this is not what you're seeing in India. But I think this is going to happen everywhere. So this is the prevalence number. This is USRDS, and the reason I'm showing USRDS is USRDS has excellent quality data right from 1980s, and they have been tracking this very, very closely. And if you look at the number of people who have ESRD in the US, it's a straight line until 2019. And since 2019, the prevalence of all the people who have ESRD, this includes everything, even transplant, it seems to have become, the curve has definitely changed. It has become a little bit flatter, though it is still going up, but it's going up at a much lower pace. Now, this is something you may say, oh, it's 2019, maybe it was just COVID, right? A lot of people died, especially in dialysis. But if you go back to the incidence rate, so this is the number of patients per million who require dialysis. Way back in 2006 or so, that is 20 years ago, this was the peak of incidence rate. So about 465 people per million population started dialysis in 2006, and since then it has been steadily dropping. The reason it has not become apparent is because the population is growing, so the absolute numbers go up. And the population has been aging, but once you look at the adjusted incidence rate, it's actually been declining. And you may say, what happened in 2005? Well, the renal trial came out in 2001, 5 years before this. CKD, the NKF Doki came out with this, CKD staging and GFR, and there was an increasing awareness about, early stage CKD, maybe blood pressure control, diabetes control improves. So this has actually been going on for a long time. You cannot say this is because of, SGLT2 inhibitors or Flozins or GLP-1 RAs, which are only coming into action now. So even before, just with ACE inhibitors, ARBs, BP control, good care, the incidence of ESRD has been slowly declining. So this is something we are going to see more and more. And this is across the top graph is about age, and it's again showing the greatest declines are in the elderly, but these are being seen in every group, even across race and ethnicity in the US. And these are US data, so you may say, why should we care? What I can tell you is that we are seeing the same thing in Canada, where we are having, our growth rate used to be about 10% per year, and now we are seeing growth rates of about 1%. So it has really slowed down. And parts of Europe are also reporting something similar. Now, of course, absolute numbers might grow because the population is expanding, the population is aging. So the rate may be slowing down everywhere, but your absolute numbers of dialysis patients may still go up. But I'm pretty confident that this will happen even in India. I'm unsure where the inflection point will happen for absolute numbers. The fertility rate of India just dropped below replacement last year. So, it will happen. It will take about 20 years for the population to stop growing as far as aging, as far as this is concerned, but this will happen. And we need to plan for the future. The reason this makes into my top 10 is because you have to think about the business of dialysis. You have to think about, requirement for nephrologists. You can't say, oh, we'll need more people, and we need dialysis centers in every town and every city. Yes, you will need them in many places, but it will change we should be changing the kind of work that is done. You cannot be in private practice just, even in the US, there are some places where nephrologists are just dialysologists. You cannot be that anymore. You have to look at the overall, chronic kidney care, chronic kidney disease care, and not just dialysis. And it is a good news story. It's really good, right? We don't want our patients to have kidney failure. So if this is declining, it's really good. But on the same thing of dialysis, this was one of the few positive trials that you can see in dialysis. That was on fish oil. This was again a Canadian trial, also with patients in Australia, and they included about 1,200 patients who were they were looking like the average dialysis patient. This was a very pragmatic trial. 55% had diabetes and 30% had underlying coronary artery disease. And what they saw is that with fish oil versus placebo, there was almost a decrease to half for cardiac death, for myocardial infarction, very impressive effects on stroke and peripheral arterial disease. This is a little bit, a lot of us were very skeptical, and I remember seeing these ads growing up for fish oil, and having tried them, they do give you a fish breath, and they are not very easily palatable, though they're very impressive results. Some people might argue that they are a little bit too impressive. How can you have a very consistent decline in all outcomes? I've seen nothing that affects peripheral arterial disease to this extent, and in the general population, the effect size wasn't so big. There was no interim analysis. There were some other things that we discussed on the podcast which give one pause. I would strongly encourage, if you haven't, that you should read the Last Month in Nephrology blog by Tukaram and Manjunath, where they go over these details and they come with a take that I would very, very much be sympathetic to. On the other hand, of course, it's something we should talk about because there is no harm, though there may be a cost and some other increasing pill burden, but this is something we should all think about. Though I do hope that these results are replicated by someone else before we can really practice it. On the note of animals, it's important to talk about xenotransplantation. This was something that it would happen when pigs would fly. Right? I honestly did not think it would ever happen. When I was training, we would be asked to write an essay on xenotransplantation in the DM exam or tolerance. Right? Those were the common topics. But suddenly things are happening, and this is mostly because of CRISPR-Cas9 and the technology that has exploded in the last few years, where we are able to get these porcine endogenous retroviruses out. You can take out the alpha-gal, which causes accelerated rejection. Otherwise, you can change the major histocompatibility antigens. There is this decedent model where the initial pig's kidneys were transplanted into brain dead individuals, where you could actually do that to see if it worked before putting it into humans. But now there have been a few humans who have got kidneys, and the longest it has been is about 6 months. Of course, eventually they did not work, so it's not been a complete success story, but it's gone from hours to days to weeks, now to months, that these kidneys have lasted. And then now there are 3 models. There are 2 in the US, one with the United Therapeutics and another with the eGenesis. And there's one in China as well. And there are slight differences. If you're interested in the immunology, there is much to think about and learn from them. One model is the thymo kidney with fewer additions in the genes, and the EU kidney has way many more gene edits, whereas the Chinese model is slightly different. But now the FDA has approved trials, clinical trials with multiple patients and not just a one-off xenotransplantation. So this is something that might be coming in the next few years. And we used to talk, maybe this is 50 years away, 100 years away. This is a story of science fiction, but now maybe it is going to be 5 years away. And there have been these isolated success for months, but it is pretty impressive that they have managed to do this. On the other hand, my cynical take is going to be that pet kidneys, these private companies are there for a reason, right? So these are going to be extremely expensive. I think they may be $1 million pig kidneys. And the post-op immunosuppression is expensive. It's not just, tacrolimus, mycophenolate, and prednisone. They are often getting eculizumab, extensivumab, as I call it. It's very expensive drugs that you're going to use, and they don't necessarily work forever. And remember, if you are impressed by the 6-month story in humans, the chimpanzee kidney in 1960s, there were a bunch of them done in 1960s, and one of them lasted for about 8 months. So, we have been here before, 60 years before, so it may take some time. Sometimes progress is slow, sometimes it seems fast, but the final story is still to be told about xenotransplantation. Moving on to another hypertension-related topic, aldosterone is back. This was something that people used to talk about a long time ago, and it fell by the wayside with angiotensin II and ACE inhibitors and ARBs. But aldosterone is back, and one of the reasons it is back is because of it's not just that we have mineralocorticoid receptor antagonists, but now we are having these new class of drugs which are aldosterone synthase inhibitors. And it took forever. You may say, hey, why? So we can think about them as ARBs, like MR antagonists, and ACE inhibitors, which is the ASIs. And it took forever, though, for ASIs to be made, mainly because they have a lot of homology with cortisol synthase. So the initial ASIs that were made, they also caused adrenal suppression. So that this is why it took some time for them to be very specific. And the newer generation of ASIs that have been made are very specific for just aldosterone and not for cortisol. Though you will see that the trials that are done, they always make sure they check the adrenal axis to make sure you're not causing addictions with these drugs. And there are 3 of them. There are a few more actually than the 3 that I'm showing, but a couple of them have been tested in difficult to control hypertension. And this is kind of, it's like, why? You've got spironolactone, it costs a few paise compared to, these drugs which are probably going to cost hundreds of rupees. So why do you need a new drug in this area? And I think spironolactone is just as good, but it's good to see a new drug class with some more evidence. But the place where this is really exciting would be in primary aldosteronism, where sometimes, we are using primary aldosteronism, by the way, is the most common cause of secondary hypertension. It is underdiagnosed. I don't think we diagnose it well. All you need to do is check a renin level, and if it is low, think about PA. But some of these patients who have, especially those who have bilateral adrenal hyperplasia, we end up using 100 milligram, 200 milligrams of spironolactone, which is hard, and even more, which is hard for patients to tolerate. And ASIs here will be very useful. This was a phase 2 study showing with only 15 patients, but it showed that not only did the BP fall, but the aldosterone levels fell by more than 90%. So you're not blocking the aldosterone, you're just taking it out. You're not allowing synthesis of aldosterone. So to me, this is the most promising. And there is a phase 3 trial with about 200 patients in PA, which is ongoing. Of course, with MRA, finerenone keeps succeeding. They have, apart from Fidelio Figario, there was the fine arts in heart failure in HFpEF, and what they have done, they've actually been very smart. They looked at all the indications where there was some evidence for spironolactone, but proper trials had not been done, and they said, okay, let's do the proper trials. Unfortunately, there's no money in doing spironolactone trials, so finerenone has jumped on the bandwagon. They have done the right kind of trials that needed to be done with spironolactone, and they have shown, of course, to no one's surprise, that finerenone works. It works in diabetic kidney disease, it works in high-risk patients with diabetes and heart disease, and it works in patients with HFpEF. To no one's surprise. But some other molecules are on its heels. There is balcinrenone, which is very similar, and this was a phase 2 trial from a few months ago, published in Nature Medicine, showing that it actually reduces albuminuria in proteinuric CKD, and there are phase 3 trials in non-diabetic proteinuric CKD with finerenone as well, FIND CKD, which should be out in the next few months, as well as with balcinrenone in proteinuric CKD. So they are looking not just at diabetes, they are looking at all the spectrum of proteinuric CKD. And in proteinuric CKD, you have also got ASIs, not just MRAs. So there is the large 11,000 patient easy kidney study, as well as the Arctic study of baxdrostat with about 2,500 patients. So it's amazing how much money pharma is putting into nephrology, and we should be really happy that there is attention being paid to reducing kidney disease in diabetes. But it's not all a good story, right? So in aldosterone blockade did not work in dialysis. So this was the ACHIEVE trial, which was again run out of Canada by Mike Walsh and McMaster, showing that with about 2,500 patients using spironolactone did not change all-cause mortality, it did not change cardiovascular mortality, it did not change all-cause hospitalizations. And similar results were with the French Alchemist trial that showed that there was no difference in MACE with spironolactone. So it doesn't look like spironolactone does much in dialysis, but there is much with aldo. The ASIs are now in phase 3 trials. There may be some data coming out in 2026, probably in 2027. And to me, the way I look at it is this is a sneaky way to confirm that these are settings where cheaper alternatives like spironolactone can be used. I'm a big fan of spironolactone. In hypertension, you can use that not just as a fourth drug, but spironolactone can probably used as a second or third drug even. And in proteinuric CKD also, it might be a useful drug to try. In states of severe aldosterone excess, I think ASIs are extremely useful. But spironolactone doesn't lower cardiovascular mortality in dialysis. It can still help with blood pressure if you can manage hyperkalemia. In peritoneal dialysis, we use it especially because PD patients often have hypokalemia, so we use spironolactone a lot. So it's useful for treating markers, numbers, but not necessarily for cardiovascular mortality. So story number 4, I know you are, it's going to be high T soon, so I'll try to make it fast. So flozins are SGLT2 inhibitors. They work in almost anyone. We should be adding them to the drinking water if you ask me. But these two systematic reviews showed that they work whether you have diabetes or you don't, and across all GFR levels. So this was the C-SMART group, which had a parallel meta-analysis published in JAMA a couple of months ago led by Brendan Nguyen from Sydney. They included 10 placebo-controlled RCTs and they show that whether the GFR is more than 60 or less than 30, whether there is diabetes or not, there is a benefit that is seen with flozins, and this was across albuminuria levels. That the earlier analysis was across GFR levels, and this is with diabetes or non-diabetes across albuminuria levels. Not only do they reduce CKD progression, but they also reduce AKI. So, all across, except of course dialysis and transplant, where we are waiting for the renal life cycles trial, but give Flozins to everyone. Any patient who walks into a nephrology OPD should be offered a Flozin. But one of the most exciting stories has been this explosion in IgA nephropathy therapeutics. So the latest one was, of course, this BAF and APRIL. And when they first came out, I had to go back to the immunology textbooks, and we were not taught about BAF or APRIL, and I was like, maybe I was sleeping when these lectures were held in immunology, but no, these were discovered in 2000. So I have a good excuse. I didn't know about BAF and APRIL because they were actually described in 2000. So this is the reason many of us were not even aware these things exist. So there are these APRIL inhibitors which work over here. But then you have the BAF-APRIL, which work on the TACI receptors. Hence, they block, both BAF and APRIL. And the molecules, the one that was published a few months ago was this Origin 3 atacicept trial, which reduced proteinuria in IgA nephropathy. There was a very, very impressive reduction in proteinuria of about 70%. But also, if you believe hematuria is a marker of IgA nephropathy activity, it also reduced that. The GFR data, of course, will come, but from the phase 2 data, we have seen that the GFR slope is pretty well attenuated. And the same thing was shown in the Chinese trial with atacicept, which showed that these drugs not only reduce proteinuria, but they seem to slow down GFR decline very, very nicely. There is another molecule called povetacicept, and then there are the APRIL inhibitors, sibeprenlimab and zigakibart, which also show a similar impressive reduction in proteinuria, but the phase 3 data with them also seems to suggest that the GFR slope will be slowed. There's also the complement inhibitor iptacopan, which reduces proteinuria, and there's a press release from Novartis showing that it also slows down the GFR slope. And there are some endothelin antagonists, atrasentan, sparsentan, which is also a dual ARB and endothelin antagonist. So there are many, many drugs. So, what do we make out of that? The problem, of course, is that access to new drugs is limited. Even in Canada, I don't even have targeted release budesonide, forget about, sparsentan and many other drugs. So this is not just true in LMICs. Many across the world, these new drugs are not easily available. They're going to be very expensive. So it's impressive that these work, and they really work well in IgA nephropathy, but I'm not sure how we will be able to access it for a few more years. Of course, the paradigm is changing, that maybe you should be using disease-modifying drugs first, whether if you want to use steroids, but otherwise budesonide, these BAF-APRIL inhibitors, and then you add these, we used to call them supportive, but I like how John Barrett calls them palliative care drugs, that is RAS inhibitors and Flozins, that they should not be first. You should actually be making sure you control the disease, and these drugs are then added to slow down things if you are not able to get the disease into remission. Now, of course, no one has tested one drug versus the other, right? So the most exciting trial to me, if you ask me, is not the Origin 3 or Origin 4 or what have you coming from pharma. It's this Grace India Alliance platform trial, because this is going to test multiple interventions using this really cool methodology of platform trials, and they are slowly, and with the platform trials you can add on new drugs as they come on. So once a drug becomes available in India as a generic drug, you can add that on, and you can compare that with everything else that has been tested before. This includes Flozins, this includes MMF, this includes hydroxychloroquine, and it will have phenyrenone arms and other drugs as soon as they become generic and available. This is led by Saxena Alexander, of course, but I believe KEM is also part of this India Alliance trial. These are the kind of trials that actually we need to do for our patients. Pharma is doing trials so that they can get the drug approved, but these are the kind of trials which will tell us, what will work in our patients. So last two stories, I'll be quick. The G4. So what do I mean by G4? So there is the GLP-1 RAs. And whether they came from the Gila monster or they came from the anglerfish, this is a scary fish which is seen in the depths of the ocean. If you have seen any episodes of the Blue Planet or our planet Earth, you may have seen these images. Both these animals have used this incretins, which because they eat very infrequently. and they actually secrete, they help stimulate insulin production, but they have effects throughout. They have effects not just on the gut, but they also seem to have effects on the brain and other organs. And what we have seen, of course, with the FLOW trial with semaglutide is that this reduces risk of kidney failure and diabetes in proteinuric diabetes by about 25%. But what happened in 2025? This is like, it has taken 2 decades, if not longer, for this story to happen, right? So the first GLP-1 RA was approved 2 decades ago in the US. But it's only in the last few years that the end organ benefit has come through with tirzepatide for diabetes and semaglutide. This year, of course, we saw semaglutide in peripheral arterial disease. We saw the SURPASS trial, which actually compared tirzepatide with liraglutide, one of their own molecules, dulaglutide, and we will be having more drugs coming in. The reason it's always important to talk about this is that they have this cardiovascular outcome benefit. It's not just kidneys, right? So they have cardiovascular outcome benefit. They seem to reduce sleep apnea. It reduces knee pains. It may reduce the need for knee replacements. Of course, there's a weight loss, but they have this interesting effects on reducing alcoholism and gambling. So they seem to sort of, help in all the ills of the modern world. And there are not just the GLP-1 RAs. There are all these molecules in development, and many of them are, so there are the GLP-1 RAs, but then there is the GLP-1 RAs with gastrointestinal peptide agonists. Then you've got, that is the dual, tirzepatide is one of them. With GLP-1 RAs, we also have the oral molecules which end with glipirons. Then there is the GLP-1 RA with GIP with glucagon, the triple agonist. Retatrutide is in phase 3 trials. It seems to have effects which are, similar to bariatric surgery. By the way, I think bariatric surgery is dead, right? If you have got anyone who's going to be training for bariatric surgery, tell them to switch careers. In a few years from now, when retatrutide and those molecules come into play, there's going to be no bariatric surgery. There's a GLP-1 RA with amylin, and there's much more. So we need some kind of, like we have flozins for SGLT2 inhibitors, we need to think about this for GLP-1 RAs, and they are all gastrointestinal hormones, so we like calling them the G4s. So I think this is going to come in the next few years, which is really going to change many things we do in diabetic kidney disease. And the reason, if we actually go deep into this, it's not only going to change therapy for diabetes, it's actually may reduce the incidence of diabetic kidney disease because of the effects of this molecule. So we really need to ramp up the way we think about these molecules, and it may be primary care that is using it, and we never even see these patients because it's putting diabetes into remission. But talking about remission, it's not just diabetes. We should really be thinking about this concept of CKD remission. And you may have seen these 4 pillars, right? People talk about 4 pillars of diabetic kidney disease all the time: RAS inhibitors, flozins, GLP-1 RAs, and mineralocorticoid receptor agonists. And there are things about, can we use these drugs sequentially, which drug comes first, and there are many different people with many different ideas about which way to do it. I think it doesn't matter as long as you try to get your patients on the most possible drugs. But it's important to think about this concept of residual risk. So if we look at the ACE inhibitors ARB trials, even with losartan or irbesartan, about 50% patients did end up with kidney failure at 4-5 years, right? So it wasn't that they didn't actually stop kidney failure. Now if we move on to the MR antagonists, about 30% are developing kidney failure in the active group, despite phenylalanine and RAS inhibition. About 30% are developing kidney failure at about 4 years. Now, if you look at flozins, so RAS inhibitors plus flozins, it drops to about 15 to 20%. Of course, this is at 3 to 4 years, not 4 to 5 years. So it seems to be getting lower and lower. But what will be the risk if we have all 4 of these drugs put together? What's going to be the residual risk? And no one has actually properly tested them in large cardiovascular outcome trials, but some of the extrapolated data seems to suggest, so this dotted line is the age-related GFR decline that we see, which is about 1 ml per minute per year. If you see the combination of drugs, we are actually coming pretty close. So if you have patients who are on all these drugs, you may be able to cause remission of diabetic kidney disease. Until now we have been talking about, let's slow things down. Kidney failure will happen, but let's, maybe it will be 5 years later or 10 years later. but it's actually looking possible that we might be able to prevent kidney failure with diabetes completely. And the same thing applies with, this is showing the IgA nephropathy data. So, if you look at the older drugs, fish oil, which probably doesn't even work in IgA nephropathy, and then steroids. But if you look at the newer drugs with BAFF/APRIL inhibitors, the phase 2 data and the telitacicept data, that seems to suggest that the GFR decline, it's almost a flat line. You are able to slow down the GFR decline to bring it back to people who have normal age-related decline. So this is a really different paradigm that we are thinking of. We are not there yet, but I think we are pretty close. Of course, one of the things here would be that we would now suddenly screening becomes important. People have been talking about screening forever, and I wasn't very excited about screening. It's because, okay, all you're giving patients is, you're telling them you have got CKD early, but we have nothing for them. ACE inhibitors, ARBs, anyone can give them. What are we offering them? Now suddenly we can offer them a lot of therapies. We can offer them therapies, and we can offer them slowing and maybe even preventing kidney failure. We are in that age where prevention is really the key. And this goes full circle to the dialysis decline I was talking about. This is something we have not yet practiced. And just with ACE inhibitors, you have seen the decline of about 20% in 20 years. What is going to happen once all these therapies kick in? For our patients, dialysis will be done. Maybe we'll be doing dialysis only for AKI, and there will be no chronic dialysis machines. One can dream. So in summary, we have an intervention, fish oil, that may decrease mortality. It's probably, I'm with Tukaram and Manjunath on that. I would like to see some replication of that. But there are many new classes of drugs that are coming. ASIs, BAFF, APRIL inhibitors, and I think this is really an exciting time in nephrology to see all these drugs coming into play. And we are really close to achieving remission in diabetic kidney disease as well as in IgA nephropathy. I think dialysis is declining, so I look forward to a time when there is no dialysis for chronic kidney disease, only for AKI. There were many impressive AKI breakthroughs this year. This was mentioned earlier, but there is this new journal called KI Case Reports. I encourage you all to send your papers there, and if I know you, this is going to come to you. I'm going to tap on your shoulder to review some of the papers that we are going to get for KI Case Reports. So if I have your email, beware, please accept my review requests. So thank you, and I will end there. Yeah, not bad, and I'm happy to take any questions, but otherwise, I'm really sorry to miss being there in person. I'm going to miss the high tea and the social events that are going to be there this evening, but it's really a pleasure to be invited here, and thanks again for the wonderful things that have happened because I was at KEM and a GA site.
Amazing talk, Dr. Swapnil. If anybody in the audience, like many of us here are your students in the audience. Whatever has become an extended part of KEM EKD. So many of them have visited and been trained under you. So if there are any questions here. Okay, I have a question if nobody is. Now, like you ended with a very optimistic note regarding starting close-ins, ERBs, MRAs, and GLP-1 RA. Like, how would you consider this? Like, add them sequentially or put it all together?
Yeah, that's a really good question, and this is something. It's a very practical question, right? It's okay for these lecturers to say, "Oh, there are these 4 pillars." There was this study called Confidence where they added empagliflozin and finerenone at the same time. And that day they are showing it was safe to do that. I'll confess, I'm too scared to do that. Because you're going to see a GFR drop, the creatinine spike with empagliflozin, and you're going to see a creatinine spike with finerenone. And despite what they said, there was a little bit more hyperkalemia with the combination. So it is not easy to do this at once, but it is important to not wait for 5 years to do it as well. So if you are brave, sure, do it at once, but it's important to see patients every few weeks and then add these drugs. So at least by 6 months they are on everything. So that's one. I think I like the rapid sequential approach rather than do them all at once. Now, which comes first is a different story. I think if you've got someone who is obese, I would put them on a GLP-1 RA once it is available. I know access is still a challenge, even in Canada it's not easy, but if they're obese, then GLP-1 RAs are really something you should put even before Flozins. If the potassium is running high, I would definitely add a Flozin before I add finerenone or spironolactone or eplerenone. So those are, some considerations. Should we even add a Flozin before a RAS inhibitor? To be honest, I'm a Flozinator. I really think Flozins are dramatic. If there is any heart failure, you should be thinking of adding a Flozin. And I think it may be justified to add a Flozin even before ACE inhibitors, so it may seem like heresy. But I think Flozins are generic even in India. So I would support even, doing Flozins early. Though if there is obesity, GLP-1 RAs would get a priority.
Please. In a diabetic with chronic kidney disease, what is the risk of say dapagliflozin or empagliflozin converting an asymptomatic bacteriuria or pyuria into a symptomatic urinary tract infection? What is the risk?
That's an excellent question. I cannot tell you exactly what is the risk, but I have to accept that I'm a Flozinator. I say everybody should be getting Flozin, add them to the drinking water, but the UTI risk is real, right? So the fungal infection risk is very real. It increases the risk of fungal infections by 5 times, and it increases the risk of UTIs in the clinical trials by 5%. Now you may think 5% is low, but the absolute risk of UTIs in diabetes, as you know, is so high. Even that 5% risk is high. The other thing you should keep in mind is that this is in clinical trials. In clinical trials, they have patients who are, very clean and they are well managed. Their diabetes is good. If you have a patient whose diabetes is out of control and they already have pyuria, your risk of converting it into a full-blown UTI is extremely, I would say, is high. Again, I don't know how high it is because we don't have good prospective data to say that. Having said that, should you be scared of giving it if someone has asymptomatic pyuria? Like asymptomatic pyuria can be anything, right? It need not necessarily be because of an infection. Maybe it is some other kind of inflammation. Maybe they have kidney stones. Maybe they have some other process going on. So I would still say, rather than be scared of using it, you should use it. But if you have a rip-roaring UTI, and watch for a symptomatic UTI to happen, and if that happens, that's when you should back off. It's really good to see the MLT. I think it's been renovated. It's good to see all the faces in the MLT. Brings me back old memories.
Yeah, so I had a question. When you are targeting proteinuria, how low you can go? I mean, currently I think the new thought is that even less than 30 also should be targeted. Even up to more than 30 million is also questionable as far as toxicity is concerned.
You're absolutely right. So I remember when we used to be happy with less than 1 gram a day, or then it became less than 0.5 gram a day. We were having this conversation on social media actually about what should be, how low should we go, especially when you've got newer therapies. It's like, should you just stop? Oh, you added a ACE inhibitor and that proteinuria is is a 400 milligrams. Should you be happy with that? But the things to consider, and this is not just for diabetes. If you look at the UK data with the renal radar registry, they show that so for example, in IgA nephropathy, even with the amounts of proteinuria that you are talking about, over a lifetime, this took long, right? It's not a 5-year or 2-year phenomena, but over a lifetime of 20 years, 30 years, 40 years, these patients who have smaller amount of proteinuria also end up with kidney failure and dialysis. It takes really, really long data to show that. But if you've got a 20-year-old with proteinuria, with IgA nephropathy, even if it's not 4 grams, it should be taken seriously, which is the whole point about this. Now, again, I'm not trying to say give these drugs to everybody, right? Just add them to the drinking water. Any patient that walks in the OPD should be getting these 5-4 drugs. That's not our job. So yes, if you've got an older patient and they have a small amount of proteinuria, the risk of kidney failure in their lifetime is low. So in those patients, you may want to decide, hey, I would just use 1 or 2 drugs and reduce the pill burden. But the paradigm is changing, and when we are thinking about reducing proteinuria, we are looking at going lower and lower and lower. It will be hard to show, right? I'm talking about reducing proteinuria, but that's on the basis of epidemiological studies. It will be hard to show this in a clinical trial, because clinical trials, you can show that at higher levels, even in the IgN more than 1 gram of proteinuria. Once you start going below that, the rate is going to be very low. So you're going to have the progression, the GFR slope decline is going to be slower, and your proteinuria reduction is going to be slower. So it's hard for them to have enough power to show an effect. So the question that you're asking, I think is yes, the lower you go, the better it is. But this is on the basis of long-term observational data. I cannot say that, and it will be impossible to say that on the basis of clinical trials. So hence what you should keep in mind is, maybe the age of the patient, maybe how accessible these drugs are, what are the side effect profiles. Medicine remains an art, right? You can't have just clinical trials informing your practice. So in that sort of a situation, you should be taking all those aspects into account while planning therapy.
Any more questions? Okay. Thank you, Dr. Swapnil. It was great listening to you. We would like to...
Thank you. Thanks for the invite again, and enjoy the rest of the evening.
As we come to the end of our incredibly insightful sessions for the day, I request everyone to gather on the stage for a group photograph. We will follow this up with a brief tour of the department and the AKT unit, post which everyone is requested to assemble at gate number 1, from where we would be driving to the dinner venue.